Forgive me because I'm not very good with Zoom, but I'm going to try and see if you can you see my screen? Share that one?
Yes, absolutely. Amazing. All right, I'll unmute myself now. Yeah.
And am I on the right screen? Excellent. Okay. Sorry, bear with me for 1 second, and I'm going to just move. That's it. That's much better. So, good morning, everybody. Hope you're all well this Saturday. So I'm here today to talk to you all things genomics, pharmacogenomics, precision medicine. If you have any questions, please do put up your hand. If I can't see your hand, just shout out if you have any questions. So please do shout out if you have any questions. So I'm going to start off with, let me see if I can move this. Has it moved? Excellent. Okay, excellent. So this is a little bit of a timeline. I know it's a little bit busy, but this is a little bit of timeline about myself and where I've come from. So as you can probably see, I graduated many, many, many years ago from King's, and as an undergraduate, I always wanted to be a medicines information pharmacist. We had a talk from medicines information pharmacist. She came in, and I just thought, wow, that's the career that I want. So my initial aim was all hospital. I want to be in hospital, and I want to do medicines information. So I was very lucky. I did a residency and hospital information role with it was Middlesex Hospital at the time, which was part of UCL. And I did a little bit at Nottingham City Hospital as well, but then moved into aseptic oncology because I got to, it was more of a clinical role where I actually got to be part of the ward rounds with a clinician. So that was really, really interesting. But something happened in 2003 that just made me change. I saw a job advert, well, apart from the fact that I had baby number 2, I saw a job advertised for primary care. And it was so different to what I was doing. It was at a time when pharmacists didn't really work in primary care, didn't work in GP practices. It was completely unheard of. And it was just a very new and exciting post. It was working very much on your own. As you know, when you work in a hospital, you're always part of a team. There's somebody always there to help you out. This was very much you're out in a GP practice on your own. And it just felt such an amazing opportunity not to give it up. And also I wanted my weekends and my late nights back as well. Hence that was another push to move to primary care. But thinking about it now, if you imagine a GP practice, you could not imagine a GP practice without a pharmacist now, to the point where, at that point, the kind of things that we had to do just to get our foot in the door, the crazy things that we did. But it was really, really interesting. It was an interesting post. It was an excellent post. I was also part of the Pincer trial. I don't know if any of you have heard of this. I was one of the pharmacists in the Pincer trial. And then in 2005, I sort of felt, you know what, I've done too much pharmacy. Everything, my whole life is pharmacy. I just want to get out of that little pharmacy box. And I did a master's in public health, and it really opened up my eyes to the wider population, the health implications for the wider population. And that master's in public health actually also helped me gain my role as head of medicines management with Derby. At the time, it was the PCT. We changed to the CCG. Now it's ICB. So any acronym you can think of, we've changed to it. And part of my role with Derby was reviewing NICE guidance. And as you know, NICE are really they look at the clinical effectiveness and the cost effectiveness of medicines. And I could get my head around the clinical effectiveness. I couldn't get my head around the cost effectiveness, how it was all done, what it actually meant. So I was very lucky. I won a bursary from the Pharmacy Society, and I went and did a master's in health economics with the University of Birmingham, which really helped me understand the whole health economics and where we're coming from. And in the sort of age that we live in at the minute, it's so important to understand the implications of the medicines that we're using. And then this has led on to recently, I'm doing a PhD with the School of Primary Care, looking at pharmacogenomics. So you're going to ask me, where did pharmacogenomics come into all of this? So back in 2008, I co-wrote an article with my other significant half. Actually, he was asked to write this, and he said to me, "This might be interesting. It might be something that you're interested. Did you want to write it with me?" And it was really, at the time, it was looking at pharmacogenomics and is it reality? Is it a myth? Can it be used in primary care? And it was a really interesting article to write, actually, because it was all these fantastic things that pharmacogenomics could do, but it wasn't happening in the NHS. And then, yes, it's on the horizon, but it's not actually on the horizon yet. It's quite far away, it's in the distance. So nobody really thought much about it at the time. In 2018, I saw a job advertised, which was a PhD stroke hospital pharmacy job where they wanted to look at pharmacogenomics in secondary care. And in my head, from the article that I'd written, it felt like, well, pharmacogenomics, the home of it really is primary care. Why can't I flip this and do this in primary care? So I got onto a pre-doctoral bridge program with the University of Nottingham to look at the implementation of it in primary care, which has then led me to be successful at the School of Primary Care program to actually look at the implementation. So I'm looking at the operational barriers for pharmacogenomics in primary care, and I'll talk about a little bit more about my project towards the end. I'll plug my project towards the end a little bit. So we're talking about today, we're talking about genomics, all things genomics. So what is genomics? So all living things, they have a genome. In humans, this is all our DNA, and it contains the instructions to build and repair our bodies. So every person's genome is around 99.9% the same as everyone else's, but there's a 0.1 difference, and this equates to around 3 million differences. And some of the difference in our DNA, they determine physical characteristics such as your eye color, and others can influence your susceptibility to develop a disease. So we can now sequence and analyze genomic information to help healthcare, to inform healthcare, helping to better diagnose, treat, and even prevent disease. So this was you may have heard of the Human Genome Project. So this was a large and highly collaborative international effort that generated the first sequence of human genome. It was carried out between 1990 to 2003, and it was a landmark significant effort whose signature goal was to generate the first sequence of the human genome. So the DNA sequencing, it involves determining the exact order of the bases in the DNA. So that's your A's, your C's, your G's, and your T's that make up the segments of the DNA. And they did this using a technique called Sanger DNA sequencing. So the Human Genome Project from 2003, it produced a genome sequence that accounts for over 90% of the human genome, and it was as close to complete as technologies for sequencing DNA allowed at that particular time. Moving a bit closer to home, in the UK, we had the 100,000 Genomic Project, which some of you may have heard of. It was a UK initiative, and the point of this was to sequence 100,000 genomes from NHS patients that were affected by rare diseases or cancer. And the recruitment for this completed in 2018. So the 100,000 project, it was leading to groundbreaking insights and continual findings into the role genomics can play in healthcare. So the study looked at there were 4,000 people from 2,000 families, and it found that by using whole genome sequencing, it led to new diagnosis of 25% of the participants. And of these diagnoses, 14% found variations in regions of the genome that would have been missed if they'd used any other technique apart from whole genome sequencing. So this was a world first study. It was published in the New England Journal of Medicine, and it demonstrated for the first time that whole genome sequencing, it can uncover new diagnoses for people across the broadest range of rare diseases investigated to date, and it could deliver enormous benefits for the NHS. So this is just a diagram to show you some of the benefits of genomic medicine. And, you know, they range from things like early diagnosis, more precise diagnosis, effective treatments, and most importantly for us is fewer adverse drug reactions. That's through identification of predisposition side effects, going all the way up to sort of prognostic and preventative approaches. So genomics enabling personalized medicine. So how is genomics relevant to medicines and pharmacy? So it's impacting the whole drug journey, from drug development to optimization of existing treatments. So we're starting from novel therapies such as gene therapies, which deliver tailor-made genetic material into a patient's cell to treat the disease, to optimizing existing diseases. I'm going to talk to you a little bit more about gene therapies. I'm by no means an expert in this, but I'm going to try and talk intelligently a little bit about gene therapies. So gene therapy, this is a new generation of medicine where a functioning gene is delivered to a targeted tissue in the body to produce a missing or a non-functioning protein. And by using the gene as the medicine, the underlying cause of the disease can be targeted at the cellular level. So some of the benefits of gene therapy, so unlike traditional medicines, which often require frequent administration and focus on managing symptoms and disease progression, the gene therapy actually aims to address the non-functioning gene and provides a long-term treatment benefit with potentially just one dose. And that's really exciting that you can do that just with one dose. However, the downfall is gene therapy holds promise for people with genetic diseases. It'll not be an appropriate solution for every patient. And the potential risks and benefits of gene therapies will emerge as continued research, with continued sort of research and evaluation. And just to give you an example of a gene therapy, you may have heard of this drug called Zolgensma. I'm not sure if I'm saying that right, but Zolgensma is for a treatment called spinal muscular atrophy, SMA. And this has been approved by NICE. SMA, it's a rare genetic condition, and it's caused by variants in the SMN1 gene. SMA causes paralysis, muscle weakness, and progressive loss of movement. In the UK, about 65 babies are born each year with SMA. And 90% of the babies with severe form of SMA, of this condition, they don't survive beyond the age of 2. So Zolgensma, which I can't say its other name, I'm not even going to try and pronounce the other name. What it does, it delivers a virus packaged working copy of the SMN1 gene into the patient's cell. They only need a single dose, and it has lifelong effects. So in studies, Zolgensma, it's helped babies reach their milestone, such as being able to breathe without a ventilator, sit up on their own, crawl, walk, after that single treatment infusion. So this is one of the most expensive NHS-funded treatments. Although the listed price here is 1.7 million, for this to be available on the NHS, the company would have agreed a discounted price with the NHS, but that's commercial in confidence, so we don't know that price. But this is one of the most expensive medicines that's been approved by NICE to date. I might just skip over this. I mean, this is just showing you some of that. You probably can't even go down to the granular detail, but this is just showing there's a lot of gene therapies on the horizon that are coming, and there's so many therapeutic areas. I mean, things like diabetes, Alzheimer's, but this is quite a busy slide. So we talked about, and so you had your one end, which was your rare diseases, and then the other that genomics is tackling is cancer. So the main point to put across here is that traditional cytotoxic cancer therapies, when you treat a cancer, they target the dividing cell, and the disadvantage of that is that you have severe adverse drug reactions, and it has limited therapeutic benefits, and quality of life for the patients is abysmal. These new targeted cytotoxic cancer therapies the modern cancer treatments, they target specific genetic mutations, and they target only the cancer cells with mutations, and patients have better outcomes and survival rates. Again, I'm going to say this is a little bit out of my zone because I'm primary care, but this is where genomics is most active in your rare diseases and in your cancers. Familial hypercholesterolemia is a genetic condition, and this is where you can get primary and secondary care pharmacists working on familial hypercholesterolemia. So as I said, this is a genetic condition, and it causes high levels of that causes high levels of cholesterol. If it's left untreated, heart attacks happen in 50% of men by the age of 50 and 30% of women by the age of 60. So it's an inherited condition, and it's due to changes or mutations in certain genes, and those genes I've listed there, like the LDLR, PSK9, it's these particular genes, and these affect how the body regulates and removes cholesterol from the blood. About 60 to 80% of people with FH have a mutation found in one of these genes. So it can be diagnosed by a genetic test from birth, and early and aggressive treatment to prevent cardiovascular disease is ideal, and you can screen family members. So in terms of what pharmacists do for this in primary care, pharmacists are used to support case finding for these particular patients and optimize their treatment. Statins is the first port of call, and is to ensure that patients are on the optimum dose of statins, and where needs be, they can be referred into secondary care to go on to the more sort of complex drugs such as the PSK9 inhibitors, which are really effective at lowering cholesterol for these particular patients. But you will find some areas will have specific familial hypercholesterolemia pathways, and pharmacists working in primary and secondary care within these pathways. So going into, let's have a look at pharmacogenomics, and this is our sort of bread and butter, pharmacogenomics. What is pharmacogenomics? So everyone has a different genetic information stored in their genes they inherit from their parents. So pharmacogenomics, sometimes you'll hear it called pharmacogenomics or pharmacogenetics, and it is used interchangeably. There is a subtle difference between them, but they are used interchangeably, or you may see PGX as well. So pharmacogenomics, it's the study of how genes affect a person's response to drugs. It brings together the science of drugs, pharmacology, and the study of genes and their function, genomics, to develop and prescribe medications tailored to a person's genetic makeup. So put very, very simply, it's basically how your genes influence how you respond to a drug. So what would determine our response to medications? What actually determines your response to a medicine? So some of the things going sort of starting from the bottom, going around, factors such as, you know, your age, your sex, other diseases, drug interactions, drug food interactions. There is now evidence that the potential for both adverse drug reactions and the lack of efficacy for many drugs can be predicted by genetic variation. This genetic variability, it can be related to both the pharmacokinetics and the pharmacodynamics of the drug. So when we talk about pharmacokinetics and pharmacodynamics, and you guys probably, you will know this much better than I do, the pharmacokinetic genes, they affect the body's absorption, distribution, and metabolism and elimination of medicines. So the cytochrome P450 enzyme family, this is a major pharmacokinetic mechanism for biotransformation of medicines, of many of the medicines, and can have several variations that affect the way medications are metabolized. In terms of pharmacodynamics, the genes affect what the medication does to the body, and it could alter the efficacy or the side effect profile of the medicine. So this slide here, a little bit busy, but I want to try and introduce you to some of the terminology that's used in pharmacology, and it's all about the metabolizing status of a patient. So you'll be familiar with this. This is a bell curve, and the majority of the population fall into this terminology called extensive metabolizers or intermediate metabolizers. So these are people, when you give them a medication, they will get that desired response that you want. However, at the two extremes, you have people who are ultra rapid metabolizers and you have poor metabolizers, and they're at the extremes. And I'll show you a little bit about how your alleles will actually influence what kind of metabolizer you are. Excuse me. So hopefully this sort of shows you a little bit easier. So I'm gonna use the example of CYP2D6. Since we inherit a copy of each gene from each parent, each person will have two CYP2D6 alleles. So a person who is a rapid metabolizer will have at least one functional allele. However, an intermediate metabolizer will have a decreased function and a non-functional functional allele, and a poor metabolizer will have two non-functional alleles. And in rare cases, it's not depicted on the slide here, a person can be classified as an ultra-rapid metabolizer, and these people will have three normal alleles for CYP2D6 rather than two due to genetic duplication. And so they will metabolize drugs extremely rapidly and efficiently because they have more enzymes. So changes in metabolism can alter the effectiveness and toxicity of the drug. So you can see here how the person's genes will affect how they metabolize a drug. The point to remember here is it's only the drugs that are metabolized by CYP2D6 that wouldn't apply to all drugs. It would be the ones that are metabolized through this particular pathway. So this was really interesting. This was in oh gosh, I forgot. It's a personalized medicine. It was a document produced by the Royal College of Physicians, and basically what we're saying here is at the minute when we prescribe medicines, it's very much a one size fits all. This means that people are prescribed a medicine for a particular health problem at a set dose. But we know medicines don't work the same in all people. Some people might respond really well to treatments, and some might not show any response at all. And for some, they may get the unwanted side effects. So by doing a pharmacogenomic test, it can be used to discover which variants of genes a person carries. And how they're likely to influence the way the patient's body responds to medicines given. So because the person's genes hardly change throughout their life, you can do you can do a pharmacogenomic blood test. It can be done once, and the test could then be used throughout the patient's life to guide the choice and the dose of the medicine, making it more likely that the patient will receive the most effective medicine the first time, with the fewest potential side effects. So we just, the takeaway here is you do a medicine once, and you can tailor the dose of the patient based on the results of that test, and that test results, they can be stored in the patient's medication record. This is just to show you some of the commonly prescribed medications affected by pharmacogenomics. So as I said, the CYP450 group, they're involved in the metabolism of more than 80% of drugs. And these are two really big genes, the CYP2C19 and CYP2D6. You can see they're involved in really common drugs such as, clopidogrel, PPIs, the antidepressants. They're involved in drugs that are used in primary care so easily. Even the HLA, which are involved in things like carbamazepine, GPs would prescribe carbamazepine, allopurinol. So you can see that it's not just the cancer and the rare drugs, it is everyday drugs that are used in primary care as well. So I wanted to give you a little bit of an example of how it works, and I'm going to use codeine. As I've said here, codeine is affected by CYP2D6. So codeine is it's a widely used analgesic. It's considered a weak opioid because it has a potency of around 1/10 of morphine. So 60 milligrams of codeine is equivalent to 6 grams of morphine. And the dose is about 15, the dose is 15 to 60 milligrams 4 times a day, and you can have a maximum of 240 in a day. Codeine is actually a prodrug, and it has little or no analgesic effect until it's metabolized to morphine in the liver by CYP2D6. So if you're a normal metabolizer, you take your codeine, which is inactive, and it becomes the active morphine through metabolism via the CYP2D6. And actually only 10% of codeine is metabolized by CYP2D6 to yield morphine. So this is just to depict how it's actually done. So codeine, as you can see, if you're a normal metabolizer, codeine is converted to morphine and you'll get your normal analgesic effect. If you're a poor metabolizer, the codeine you'll have decreased levels of morphine in the body, and you'll have little or no analgesic effect. You may even get side effects from the codeine, but you can see this would be a waste of resources to give codeine to a poor metabolizer. If you're an ultra rapid metabolizer, you'll have excess of the CYP2D6 gene. You'll have excess levels of morphine in the body. This can lead to increased levels of side effects. So in these patients, even if you give them a small dose of codeine, this could result in toxic levels of morphine. So this is the group of patients that you really want to avoid giving codeine to. This is just another case study about codeine. So this is from the States, actually. A 62-year-old man. He presented with a 3-day history of dyspnea, fever, and cough. He was admitted to hospital, and his only current medication was valproic acid, which he had for his seizures. The clinicians decided to give him some codeine, at 25 milligrams 3 times a day, which is quite a low dose for his cough. So in the hospital on day 4, his level of consciousness level, it started to decrease rapidly, and he became unresponsive. When they checked the drug levels, the valproate level was actually normal. So they decided to deliver naloxone, and the patient luckily recovered after 2 days of this acute event. It's only later on that they identified that actually this patient was a CYP2D6 ultra rapid metabolizer, and he should never have been given codeine in the first place. So you can see why genotyping people to understand what their metabolic status is so important prior to giving these kind of drugs. I think here just to say most people, so although we've talked about codeine and the pitfalls, and the MHRA have actually on the back of another case study with a lady who was breastfeeding her baby, and the baby died, and it turned out that the mother was actually an ultra rapid metabolizer, and the baby was getting excess levels of morphine in the breast milk. The MHRA have put a warning out that it shouldn't be given to certain patients, so for instance children and breastfeeding mothers. And this is really just to show you that the majority of the population are going to be extensive metabolizers. That is, they'll have normal activity. You give them codeine and they will have normal activity. It's the poor metabolizers and the ultra rapid metabolizers. So you can see up to 2% of the population would be ultra rapid metabolizers, and that's the group of patients that you actually want to give something else as opposed to codeine to that to those patients. Is another example of pharmacogenomics. Clopidogrel, it's an antiplatelet. It prevents blood clots. It's commonly used in things like heart attacks, strokes, such as these. 1 in 4 patients who has clopidogrel actually has a subtherapeutic response. Clopidogrel is another example of a prodrug. So this is how clopidogrel is metabolized. You take clopidogrel, which is the inactive drug, it's absorbed and metabolized by CYP2C19, which is one of the other enzymes in the liver, and the metabolites then go on to cause inhibition of platelets, and you get decreased thrombosis. That's basically how clopidogrel works. Yeah, oh, sorry. Oh, I've gone too far, haven't I? Sorry. Where are we? That's it. So clopidogrel, which is metabolized by CYP2C19 to the active form, patients who are poor metabolizers may be more likely to have an adverse cardiovascular outcome due to reduced platelet action. So CPIC, which is an international guideline, it's called the Clinical Pharmacogenomic Implementation Consortium. It's an international guideline. They actually recommend you use an alternative antiplatelet for CYP2C19 poor or intermediate metabolizers. For instance, prasugrel or ticagrelor. Currently in the NHS, we don't actually have any testing for clopidogrel. However, having said that, NICE are looking at the genotyping for clopidogrel. Even though the date here says October 23, which we've passed, NICE has delayed it to May 24. So hopefully, if we get a positive decision from NICE, we will be able to do a genetic test for potentially for patients who are going on to clopidogrel, and we'll know whether we can give clopidogrel to certain groups of patients or not. So those patients, it would be giving them an alternative if we find out that they're poor or intermediate metabolizers. And I think just my last example, antidepressants. Antidepressants, again, primary care has played such a massive role in antidepressants. And we know that 50% of patients, they don't respond to their first antidepressant, and about 30% of patients discontinue within the first week, within the first 6 weeks of having their medication. And there is evidence that multiple genes and genetic variants play a role in determining the response to antidepressants and the side effects that they experience. Most antidepressants undergo metabolism through the CYP450, notably 2C19 and 2D6. So again, it's the same CYP450 enzymes which are implicated with antidepressants as well. This is what I was talking about, the CYP guidelines. CYP guidelines are really difficult to digest. They come in a systematic review paper, and you have to sift through the whole paper to get to the end, where they have quite a nice little table. Sometimes, not all of the time, sometimes they have a nice table. And as you can see here, if you were starting your patient and is a poor metabolizer and you wanted to start them on citalopram, oh crikey, sorry, I've gone 1, 2, 4 forwards. Yeah, if you wanted to start them on citalopram and they're a poor metabolizer, the CYP guidelines are stating do 50% of the starting dose or try an alternative. We don't, again, at the minute, there is no testing for antidepressants in the NHS, and we don't know if this would be used by our clinicians. So this is one of the things that we're researching to see whether UK-based clinicians would use recommendations from an international guideline. Yeah, this was just to say some of the examples of where pharmacogenomic testing is actually used in the NHS. So we have something called the Genomics Testing Directory, and in there's a lot of rare diseases and cancer tests, but some of the ones that you may come across if you work in secondary care is DPDY testing. This is done, this is offered to all patients before they start certain chemotherapy, such as 5-FU or capecitabine. And this has been done since 2020, so this has been ongoing. And then there's also HLA testing for abacavir. So this is abacavir. It's a first-line treatment for HIV. But when given to patients, 1 in 17 have a bad reaction, which at worst it can be fatal, and it's due to variation in their immune system. So all patients now have a specific genomic test before they start Bacavir, which identifies those who are more prone to the allergic reaction. And this has significantly reduced the pressure on NHS services that previously had to deal with people who were only found once they'd started the drug. So the adverse drug reactions only occurred once they actually had the drug. And you can see how this would be much better for the patient as well, because you're cutting out those severe reactions for them and improving their quality of life. So I'm sort of coming towards the end now. So what would be the advantages of using pharmacogenomics, PGX? There you go. There's the acronym, or pharmacogenomics. So it's more effective drug therapy. You can get faster symptom relief, better response rate. In terms of adverse drug reactions, you can reduce adverse drug reactions, and there's recently been a trial, a multi-centered trial, where UK was one of the sites, and they actually showed a 30% reduction in adverse drug reactions through the use of pharmacogenomic testing. If you're reducing adverse drug reactions, you're going to get better adherence to medications with your patients, fewer hospitalizations, fewer deaths. You improve the quality of life for your patients, and a long-term cost savings. So ultimately what we're trying to do here is match the right drug to the right patient at the right dose, and you want to minimize the amount of adverse drug reactions occurring in these patients. And who would benefit from using pharmacogenomic testing? So again, this is something that is being researched, but you can see the likely candidates would be people taking multiple medications, people who have multiple medical conditions, patients who experience serious or ongoing adverse drug reactions, patients who are reluctant to take their medications because they're concerned about the safety or the efficacy of their drug, people who are not responding to their medications, patients who require very high or very low medication doses, and in certain high-risk ethnic groups, for sort of certain severe adverse drug reactions. So for instance, in the Han Chinese, you wouldn't give them carbamazepine or allopurinol because it's contraindicated in these particular patients. But if you were to do a test before, you could highlight these particular groups of patients. So it could be applicable to so many patients, pharmacogenomic testing. I think I'll just skip this. This is about CPIC. I mean, this is just talking a little bit about CPIC. There's not just CPIC. There are other groups. There is the Dutch Pharmacogenetics Working Group. They also have guidelines guiding you how to dose according to your pharmacogenomic test. There's also the Canadian pharmacogenomic networks, and then there's the big pharm GKB. Also, all of these are international bodies who look at pharmacogenomics and develop guidelines. But the PharmGK, yeah, we don't actually have anything in the UK at the minute. Yeah, and then just finally, I wanted to just touch on what I'm looking at. So I'm looking at the implementation or the operational barriers for pharmacogenomics in primary care. And this is a very busy slide, but as you can see, it's my project is split into three work streams. So what I'm going to start off with is doing some qualitative interviews, semi-structured interviews with healthcare professionals. So that would include GPs, pharmacists, nurses, and some patients, to identify what are the barriers and enablers to the implementation of pharmacogenomics in primary care. And then using those barriers and enablers, start to think about developing which healthcare professional will be best placed to deliver pharmacogenomics. And as pharmacists, I think we are the ideal profession to deliver pharmacogenomics, particularly in primary care. And what are those operational barriers? What are the sort of cultural differences that we need to overcome in primary care to allow pharmacists, be they practice-based or community-based, to be able to implement and use pharmacogenomics for their patients. So sort of trying to develop a pathway. And then finally, the third one will look at the cost effectiveness of that pathway. So is it cost effective for a pharmacist to deliver it, or would it be more cost effective to have a sort of a multidisciplinary, so would it be a GP pharmacist, or would it be a nurse and a pharmacist? So looking at the cost effectiveness of delivering that in primary care. So, and I think I just, yeah, so just to end up to say, future of prescribing is pharmacogenomics. It has tangible patient benefits, and I think most importantly, it saves money for the NHS. So thank you very much for listening. And I will end my somehow. There we go.
Thank you, Sarah. That was an incredible presentation. I think I've learned from you more today than I ever have about pharmacogenomics, because I think we can all agree, as like pharmacy students and trainees now, we don't really understand the impact, and sort of we don't gain an overview of that sort of understanding, and fundamentally why pharmacogenomics is actually important. And like you said, this is your expertise, and you've been involved with the community, you've been involved with the developments and the advancement in the last few years, and you said there's still so much more to do, and I'm really excited to see how that can be implemented. I already have so many questions for you, but I'm sure the rest of the team and everyone attending do as well. So guys, if you do have questions, please pop it in the chat. One of us will bring that to the attention, and then we can have it answered. But I'm gonna start with the question, because you said, especially with your experience involvement in GP practice before, and then when you got into sort of the more in-depth with pharmacogenomics and the development side of things, you saw there's a lot of implications and usefulness of how this should be in GP practice. So my question is to you is, how do you see that process of implementation? I know you said you have to look into, the barriers, cost effectiveness, but how do you see that being implemented in the next few years, or how it's being implemented sort of right now as well? And which sort of areas of testing do you see that going into for primary care specifically?
In terms of sort of how it's going to be implemented, that's part of my project, is to see how are we actually going to use it. At the minute, it's done in secondary care. So, like I said, before you go on to 5FU, some cancer chemotherapy patients will go in, they'll have their test done, and then they'll be prescribed according to their test. In primary care at the minute, we don't have access to these tests, and there are so many barriers. So part of my project is looking at those barriers. So the first barrier is the tests aren't available. So the technology might be available, but the tests aren't available on the NHS. So we need to introduce those tests first into the NHS. Okay, and then it's, when do we test patients? Are you going to test patients when they turn up at your door and say, right, let's take the really simple example of codeine. I need some codeine. Are you going to test then? Is it going to be reactive, or is it going to be, will you have the information already in the patient's notes? Would they have it, are you going to test everybody from birth, or would it be at 40 when they have their cardiovascular checks? Again, these are things which we don't know yet, and everybody's researching and looking at these things. So let's just assume the test results the test has been done. It's also having the IT. You might have the test result on a piece of paper, but the GP is not going to go and look at a piece of paper. It needs to be integrated into their clinical care decision support system. So it has to pop up to them. So again, this is something that we're looking at. So when a GP goes to, or a pharmacist goes to prescribe codeine, the alert will pop up and say, did you realize this patient is a poor or a rapid metabolizer? You can either do a lower dose or prescribe a different drug. So these are some of the barriers that we have to overcome to be able to implement pharmacogenomics in primary care. It's coming, it is coming, but there's quite a lot to do yet before we get to the point where you're going to see it. Having said that, There are some pharmacies called, I think they're called Day Lewis, who are they're giving pharmacogenomic testing out. So there are some pharmacies that are doing it, and I think it is also being done piloted in Scotland as well. So there are some pharmacies that are doing it, not yet in England, but I think by the time, are you guys undergraduates, or have you all graduated?
So there's a few members in our BPSA exec team who are qualified as well.
Okay.
Emma is one of them. So Emma actually works at Day Lewis and she's a qualified pharmacist. And then I'm doing my training. Kieran is doing his training as well. And Denka is undergrad
Right,
MPharm
right.
student. Yeah. So there's a mixture of everyone. But yeah, it's very interesting to
Yeah, so I think
hear about
within
it.
the next 5 years, I mean, Genomics England are really pushing the agenda, and I think you're going to see this, maybe not in primary care, but more so in secondary care. Within the next sort of 5 years, you're going to see more and more pharmacogenomics being implemented.
Perfect. Thank you, Sadaf. I have another follow-up question now because I think I understand the sort of, your explanation of why there has to be so much more the process of things, isn't it? It's sort of like it's one thing to sort of have the idea, but the research to back it up as well. And I guess that's how you start an initiative that's implemented through NHS, and that's where you get the fundings to come in and sort of implement it on a wider scale. So now that it's sort of, would you say it's quite integrated well in secondary care, the series or pharmacogenetic testing? And can we see it expanded even more in secondary care? Because in the examples you've given, I think you highlighted how chemotherapy testing is utilized, but is there sort of more leeway for non-chemotherapeutic testing?
Yeah, I'm not an expert on secondary care by any means, but I think the testing is driven by what's in the directory. So in the directory, it is mostly cancers and rare diseases. So if you think back to a time when Herceptin was in the news, there was this big thing about Herceptin. So even back then, for Herceptin, for you to be able to get Herceptin, you had to have a genetic test because you had to have the BRCA gene to be able for Herceptin to be useful for you. So it is all dependent on what goes into that directory. So I'm part of a committee called for the UK CPA. We're part of the genomics committee, and recently we've submitted for carbamazepine. So that's a really common drug to go into the directory. However, like anything, things take time, and I don't think they're going to actually review the submission until I think it's the end of this year. So we're looking at 2025 before something as simple as carbamazepine is possibly introduced into the directory. So it's a big machine, and it takes a long time before it's embedded. And you're going to see your common, I think your question is about common everyday drugs. That's going to take quite a long time yet. But the rare diseases, the cancers, you will see more and more nice guidance coming out for cancers, and genetic testing available for these kind of drugs. There was a recent one called mavacamten, I think, and that has genetic test. So depending on your metabolizing status, it's whether you're prescribed it or not, or at a lower or higher dose. So it's coming, but it's coming slowly.
Thank you, Sadaf. That's wonderful. We have a question actually from one of the audience. It says, how is the pharmacogenomics test done?
Oh, okay. So it can be something as simple as a swab in your mouth, a swab, or a blood test. It's as simple as that. Goes to the laboratory. We've got 7 hubs in England. So depending on which geography you're in, it will go to one of the laboratories, and then they will send the results back. Again, it's those results that come back. It's making it digestible for your pharmacists, your GPs, your nurses. If you imagine if you're in primary care, making that as easily digestible for them, because they're busy. We're busy professionals, and you want to look at something immediately and say, right, I'm not going to prescribe this. I'm going to prescribe you something else, or I'm going to decrease or increase the dose of this particular drug, because that's what busy professionals want. They don't want to have to think about the science and go into it all. They just want to know, okay, my patient is an ultra rapid metabolizer. I'm not going to give you this drug. I'm going to give you something else instead. So yeah, it's about sending that information digestible for the end user.
Perfect setup.
Excellent.
I have like one more question before obviously I pass it on to Emma, because I know Emma has a few questions for you as well, maybe. But just to follow up with that. So the available testing we have now, say secondary care or primary care, or community pharmacy, if that's been implemented as well. Do the results, like you said, do they tend to be digestible? Do they tend to be concise and quite easy to sort of manipulate treatment or initiate treatment in accordance to that? Or do you think that's still something that requires quite a bit more work? And
I
yeah,
think the latter, that requires quite a bit of work, because again, testing isn't that routine yet. So if you imagine you send a test, your patient off for use and ease, it comes back and it's easily digestible by everybody. We haven't got to that point yet for pharmacogenomic testing. That's the point that we want to get to, where it comes back from the lab and anybody can read it and say, yes, I understand this. We're not at that position yet, unfortunately.
thank you. I'll pass it on to Emma.
Thanks, Sally. Thanks, Adam, for such an insightful talk. I always thought genomics very complicated and not so interesting, but you changed my opinion now. I just wanted to ask, how would you advise students and training partners to get involved in genomics if they're interested in that topic?
So there's so many things that you can are on offer at the minute, and I can send you some links as well. So, excuse me. So CPPE have genomic modules that you can do. If you go onto the Health Education England or Genomics England website, they have bite-size little courses that talk about genomics and about the healthcare implications and about pharmacogenomics. If you're more interested and you want to really get your teeth done, there are master's courses being run by quite a few universities up and down the country. And I did it a couple of years ago, and they were actually offering free funding for NHS professionals because they want people to know about genomics. So you can go on. I just did a couple of modules which teaches you about genomics and about pharmacogenomics. So you can do that sort of level as well if you want to become an expert in it. Yeah, I mean, I can send you the links later on if that's okay.
Yeah, that would be very useful.
I might be able to ask
Thank you.
you guys one question, which will really help me actually. As undergraduates, do you guys get taught pharmacogenomics in studies? Because going back to the day, I mean, many years ago when I did it, we were not taught pharmacogenomics at all. Are you guys taught anything about genomics, pharmacogenomics? And is it meaningful?
I think I'll start with that. So I think we did to an extent, because a part of the program did cover a bit about the metabolizers, the ultra metabolizers. So that I think that's something a lot of us as undergraduates, and Danka now as an undergraduate, I mean, you can answer that question better than me, but I think we did have exposure to it. We didn't, however, have much exposure to the implications of it. And we didn't get to sort of we weren't sort of encouraged to read sort of the papers behind it, but I guess, you know, that's sort of more, maybe if that's a niche interest, then students could be encouraged to do that. But we didn't, it was very much like, right, this is part of the program, this is what you need to know, but nothing more, nothing less. So it was never to the point where it would have one of us get curious to think, oh, is this already a part of secondary care? When I go to my placements, or when I go to, we're not encouraged during placement experiential visits to actually gain any exposure at all in the pharmacogenetics of things or any available testing. I think the only experience I had personally was just to see clinical trials and see how clinical trials work. But even that in itself was very brief. We didn't go into how the testing side of things worked essentially. So
Right.
yeah, it's very, yeah, just kind of surface understanding of the topic, which is why I think a lot of us are now curious because as a trainee, you know, as part of our learning outcome, it says we need to know more about the genomics. And that's
Yeah.
to me surprising because I didn't think it was an important topic. I didn't think it was prevalent as it is now, and maybe in the future, the next 5 to 10 years. And so for to hear it from someone like yourself, who's very much in as a part of someone developing this and integrating this into NHS more and more, it's important that I think we have this exposure and just sort of break that bridge between understanding and really caring about it altogether.
Yeah,
But
I mean, that's one of the major barriers which always comes up is knowledge, not just pharmacist knowledge, but GPs, medics knowledge of pharmacogenomics. And everybody, when you say genomics, says, oh, it's too complicated, but actually it's not. It's actually quite a simple thing to get your head around. And I think the thing I just want to leave you with is, think of it as another test. It's not going to be the answer to everything, but it's just another test, like you would do a liver or a kidney test, where you would change the dose of the medication based on that test. This is just another test. And again, it's not going to eradicate all adverse drug reactions, but it could reduce them. There is really good evidence to say it can reduce some of the adverse drug reactions. So thank you so much for the opportunity. I really enjoyed speaking to you all.
of
Did
course,
anybody
thank
have
you.
anything out? Any other questions?
There is another question.
Okay.
Yes. The question says, what is the average cost of these tests? So the cost
Oh.
effectiveness side of things. And then keep
Okay, that's a really good question, actually. When it started off, again, these tests are not actually available in the UK at the minute, so I can't give you a UK estimate. But when they started off, they were in the sort of thousands, and we're talking dollars here, in the thousands of dollars. The price has now gone down to the hundreds. So you can see how the price, as technology improves, the price actually goes down, and the price is now in the hundreds. We don't actually, I don't know what the UK price would be at the minute, though.
Can I just say that is actually surprising. I didn't,
Yeah.
yeah, I didn't expect that. Is that was specifically to the averaging of all the tests that's available across different settings, or is it just, are we talking about a specific test?
So it depends on the test. It really, really depends on what test you're doing and which company you're getting it from. So if you did a panel test would look at a raft of different enzymes. So if you remember, I talked about the CYP450, it would be maybe the CYP450, the 2D6, 2C19, it might have the HLA, it might have a few other ones as well in it. That's called a panel test. And then you have single tests. So it really depends on which test you're looking at. Single test will obviously be cheaper than a panel test, but even the panel testing, the cost is coming down every day. The cost of these are coming down. And there's been quite a few studies which have said they're actually cost effective at the current price. I'm thinking probably in the region of about $200. There have been trials which have shown that they are actually cost effective even at these prices today.
That's very insightful. Thanks for answering that question, Sadaf. And I'll pass on to Key.
Yeah, hi, Salaf. Thanks for the presentation. I wondered if you had any advice on how to navigate conversations with patients when we're talking about genetic test results and how to almost explain to them what it means to be an ultra metabolizer or a poor metabolizer and what that will mean for them.
Oh, that's a very good question. And unfortunately, I don't have an answer for that. I think so we have they're called what's their names? So we have 7 genomic experts, and I can't think of their names. They have a specific title. They work in secondary care, and I don't know if they liaise with patients, but they liaise with other healthcare professionals. So, for instance, like you're saying, if you had a patient in front of you and you had this genomic test and you didn't know how to sort of digest it and deliver it to your patient, we have these genomic experts that sit in secondary care who you can contact, and they'll be able to help you. Unfortunately, I don't really know how you would have that conversation. I've not gone down to that level yet of talking to patients about it. My apologies, I wouldn't be able to answer that question.
Thank you, Sedef. Thanks, Key. Yeah, no, I think that's such a great way to also like understand that, you know, in the future, if this was something of a routine testing, because I think one of my questions to you, well, I was going to ask, but you did cover it anyways, was if you see this as a part of a routine thing that could be really useful in primary care. And then, you know, when you sort of implement it over the next few years, people will start to sort of see the benefits of it, and maybe then that conversation with how can you communicate that to patients, how do you communicate that to the wide multidisciplinary team, you know, to technicians, to receptionist teams, to the admin team, how can they then even communicate that to others? So it's such a great yeah, it's the a possibility, you know, of what this could be in the future, and I think it's really great. Yeah.
Absolutely. I mean, you're going to have, if you can imagine, in your community pharmacy, you might have somebody turning up with a direct-to-consumer test and say, "Can you digest this for me and tell me what are my implications?" So you can see how we need to train our workforce as well, so that they're able to, you know, to tell patients, this is what this means for you. This is the significance that it means for you. We will be there. I think within the next 5 years, we will be there, where you will see, as practicing pharmacists, people coming up with tests, or you ordering tests and having to act on those tests. Hopefully in the next sort of 5 to, if not 10 years.
Yeah. Very
Brilliant.
exciting.
Okay. Thank you so much for inviting me. I've really enjoyed this morning.
We really enjoyed having you, and I think we've all definitely are going to leave this knowing so much more and being so much more inspired, and going hopefully to do our own homework and understanding of this this topic better. But thank you for helping us with that and supporting us, and yeah, delivering such a wonderful session. Thank you, Seth.
Okay, brilliant.
Thank
Thank
you.
you. Bye-bye, everybody. Bye-bye.
Okay, guys, I hope you really enjoyed that session. What I'm gonna do is actually put a poll up. I don't know, Key, if you want to help me with that, but just to see how you guys thought about that session. Did you find it useful? You can also just pop it in the chat if you found it useful, or any comments you have, any thoughts you have during the presentation, and then maybe a few of us in the exec team can also give sort of their 2 cents about what they think, because I think I don't know if you guys are familiar, all of us are of different parts of our pharmacy training right now. So myself, Key, as a trainee, I think we're very much, you know, in the sort of working environment. I work in a GP practice right now. Key's working in hospital, and that talk was quite important in a way because it made me reflect on how, you know, we don't use a lot of genomics in our day-to-day practice, but how useful it would have been if we did, because we always get cases of patients coming in saying they've got an adverse reaction, they've got side effects, we have to deal with it. And a component that as a healthcare professional we may not think about is that your genes and the genetic variations you may have can affect how you interact with certain medications. I have a patient who has so many interactions with so many classes of drugs, and doctors are thinking none of the drugs work for this person. Why, you know, why is that? We have that question, and sometimes we never sort of look at the solution of bringing them into testing and seeing maybe there is something more underlying there that could help resolve that issue. I don't know, Keith, if what you thought about that, but yeah.
Yeah, I definitely learned a lot. It was very interesting to kind of think about not where we're at now, but where we're going, and the impact this is going to have on a lot of treatment sessions for people, especially the impact on adverse drug reactions and how we can minimize that. But I'm also excited to see where the training will go on how we can actually learn, because I think this will be far more applicable in community pharmacy, where that will be in the future where the majority of testing is. And how do you go about having those conversations as that sort of that first port of call? How are you going to then have those conversations, and what does that mean?
Yeah, absolutely. Thanks, Key. We have the poll up now as well, so guys, feel free to fill that in. Danka, you have your hands up?
Yes, absolutely. I was just going to mention one of the biggest messages which I'm taking away from it is the conversations with the patients, and especially SSRIs were mentioned. So I think from my experience, there is still a lot of stigma about having these conversations with patients, especially with patients in mental health conditions. So I am really excited to see where the future is going to take us and how this will be handled in the future to benefit the patients.
The antidepressant talk was actually very interesting because as I'm sure a lot of us know, when a patient starts on antidepressants, for the first 2 weeks, they get worse. And then a lot of people feel that there was actually no benefit at all. And we've always put it down to the drug was ineffective, but actually we just left it at that. And maybe we should be looking at, okay, the drug was ineffective because that particular person, their genetic makeup means that those drugs will be ineffective. And I think that's going to really change the way we look at how we treat certain conditions. And I think antidepressants and mental health in general will be a very, very big interest for the use of genomics.
Absolutely. And I completely agree with both of you, what you said. And yeah, like there's so many ways this could be helpful, and so many ways we can bridge that gap and bridge that barrier to communication with our patients. You know, we're always there we always expect to be honest and transparent, but also we have to make the information we provide our patients digestible and easy to comprehend. Another thing I've realized is if you were working in a GP practice, so I've experienced for 6 months working there, and a lot of the things that we do is reconcile a lot of letters, a lot of sometimes complicated hospital letters. So I would get a hospital letter about a patient undergoing some form of chemotherapy or an oncology letter, and I would have no idea what that letter is telling me. But what I've realized is that some of those letters actually go through the processing of testing that the patient has done, and therefore they would say, well, we recommend the patient to be on this treatment versus this treatment because of the results of their testing. And if I had this previous knowledge, or if I went away and look into this more and do a sort of additional learning, my own self-directed learning on this, maybe I would even have a better time understanding and gaining that appreciation for the process, the step-by-step process that patients have to go to find the right treatment for them, especially if it's a treatment that's quite niche, but is very much necessary for them to, fight against something like cancer, or fight against a very complex and difficult disease or condition. So there you go. We've listed out so many different benefits. And guys, I do highly encourage that you maybe have a look at the CPPE course. I'm not sure if this is something that your tutor or your supervisors already mentioned to you, but obviously, there is the CPPE courses and other websites you can use as well in order to learn more about genomics and pharmacogenomics. And yeah, definitely go and just search it up and learn. And obviously, I think there's no pressure really, because we're still in position that we're always learning something new. Emma, you can feel free to chime in whenever. Yeah.
Yeah, I just wanted to share a comment from Alexandra. She sent it to host and panelists, so the rest of the participants can't see it. But she said the topic is very interesting, but she's working in community pharmacy. She struggles to see how she can apply pharmacogenomics into her daily practice. As a pharmacist that works in community, I actually had an encounter with a patient that's on gene therapy yesterday. So I do believe in coincidences. But the lady came in, she had familial hypercholesterolemia, and she tried all the statins, ezetimibe, bempedoic acid, and nothing worked. So they've now put her onto gene therapy, and she basically walked in, and she showed me what she's been prescribed from the hospital. She was like, how do I administer that? And I was like, first, I don't know what that is, but I can have a look for you. So at the end, I've advised her to go back to her GP because you have to be a nurse that educate her on how to use it. But in community pharmacy, you're in a great position that you can literally have anyone walking in your community pharmacy asking you any sort of questions related to pharmacogenomics, gene therapies, and patients watch a lot of telly, they listen to a lot of news. So if a new gene therapy comes out, you definitely have at least one patient coming in that day in the community pharmacy to ask you about it. So hence it's very important to be aware of the gene therapies and what's advancing therapies as well in relation to pharmacogenetics, no matter which healthcare setting you're based in, because that's an example from yesterday that I had. And with my career growing, I'm sure I'll get more and more of those questions and those queries from patients. So I hope that answers your question in a way, but I thought I'll share that because that was very interesting. And I went away and actually started reading into the topic and what gene therapy the lady was prescribed. So it was very interesting to educate myself as well and be able to help.
Yeah, absolutely. I wonder as well if we're more exposed to patients sort of the gene therapy side, because I know in hospitals obviously you have the oncology ward. So I was wondering, Key, if you want to share maybe how in hospital you as a trainee pharmacist, why the knowledge of this could actually benefit maybe how you care for these specific patients, and when you go on your different wards and rotations, how you can actually impact maybe on the counseling side of things, or even having that conversation with other healthcare professionals as well.
Yeah, I mean, one of the very interesting things when I started working in hospital that I was looking at, and it was kind of mentioned in the presentation, was about codeine and in particular pain management. Every patient in a hospital was on some form of pain management, some more than others. And what's very interesting when you have those conversations with those patients and you start to kind of explore, okay, what's worked, what hasn't, nobody really ever asks why. They just take it on face value. Okay, you've tried paracetamol, you've tried cocodamol, it doesn't work. Let's try morphine. That doesn't, let's move on to tramadol, let's try on to fentanyl. And before you know it, you're on the top end of the pain ladder, and nobody's ever stopped to take a look back and go, well, actually, is there a reason behind it? And I think that genetic testing is going to have a really big impact on the way that we manage pain in our patients, because with opioids in particular, there's a big focus in my trust, and I think a lot of trust, on trying to get people off opioids or only be using them short term, just because of the long-term effects of addiction, liver damage, and all of these other effects. And I think I look forward to the day where actually we're having these conversations at our multidisciplinary team meetings and we're going, well, do we need to move this patient onto morphine, or actually are they just a poor metabolizer? Do they need an increase in dose? Okay, this person's having a lot of side effects. Maybe we lower the dose because they're an ultra metabolizer. Really looking at optimizing the dose of what we've got than actually moving up to where we're getting to a point where there's no turning back and it's going to cause more negative impact towards the patients.
Yeah, absolutely. And I can say that that would be impactful across all settings. And if we're talking about pain-related medications, guidelines, I think some of you guys may know the guidelines have changed quite recently. I don't know how recent actually, but I was told throughout my training that now with the use of the pain ladder, it's not really applicable to non-cancer patients. That is very much the treatment of patients who are in very intense pain. And I'm not sure if it's the pain ladder, but I think it's sort of the use of opioids and upping that use of opioids and trying, the higher potency and upping the dose until, because there's obviously from what we know as well from our training is that patients can tolerate more, and the higher the dose they take, the more they'll tolerate that, and they'll be eventually ineffective to control their pain. And you know, patients will think, well, I have to go on a higher dose. I have to go on a more potent drug. I have to keep trying. And sometimes the solution, like you said, is taking a step back and looking, let's see where's the underlying issues that we can resolve without having to put patients at greater risk of the side effects associated with opioids, of the long, and these are long-term side effects as well. So even having that conversation with patients, getting them off those medications are already so difficult. So if we have these testings, I think it could be really impactful, because now we can say, well, this is, now we know a bit more about your sort of genetic makeup. Now we know a bit more about your predisposition to certain things. This drug just does not work for you. And like you said, Key, if someone is an ultra rapid metabolizer, they're going to get even more side effects, even at a lower dose. And if we had not known that and we up the dose, that could be really, you know, it could end up being really bad. So I think absolutely this is in hospital is very important, but in the GP, we're trying to have these conversations. You know, we're trying to try patients on stuff like duloxetine, which is known to have, which is more, there's more evidence with regards to how it helps with pain, but it has a lower side effect threshold. So many interesting conversations. I think all of us have quite many different opinions and where we stand with this as well, but knowing what the evidence is out there. And what I would say is I'm really excited to see the evidences that are going to come up with regards to pharmacogenetics, so we can utilize and implement to the guidelines we use now to inform a lot of the decisions we make. I mean, you know, a lot of us are still sort of and the trainee stage of things. But for instance, if you're in the same position as Emma now, and you know, she's basically in the forefront where she's able to influence that and integrate those changes, that is such an amazing position to have. And the knowledge we should have to inform those decisions are even more powerful. So yeah, really excited. I do think we do have time for maybe a short break. What do you guys think? Because I do know that our next workshop session starts at around 11:30 time. But I'm gonna go to Emma and see what you think, Emma, if we should get a break. Your face when I said that. Or actually, what you guys as attendees, I mean, because I'm not sure if you guys had, you know, food this morning, you're getting maybe a bit hungry, or you just want to go for a little walk. I think we should take a short break. I think we should take, I would say, to come back at around 11:20. How does everyone feel about that? A 20-minute break, yeah? And the execs, you guys can obviously just chill here a little bit, or you can, you know, yourself take a break as well. Obviously, it's for everyone.
As my face is all over YouTube. It's perfectly fine to record. Fantastic. Okie dokies. Let's see. I'll just give it a couple of minutes, see if anyone else is going to join, and then we'll get cracking. Okay. We'll just get started now. So hello everyone, and welcome to a calculations masterclass by Pre-Res Shortcuts. Can you all hear and see me, guys? If you just want to raise your hand or just want to put something in the chat so I know that you can hear and see me, guys. Yeah. Fantastic. Okay, so welcome, guys. We're going to be doing a calculations masterclass in this session, and so essentially we're going to be going through, going to have a little taster of some of the calculations that we do in our courses across our essential, standard and premium courses. And I'm also going to introduce to you our cheeky new question bank with over 1,000 questions, GBHC style questions covering the whole GBHC assessment framework. And essentially, of course, one of you guys will be a lucky winner tonight. There's going to be a bit of a raffle. There's going to be a raffle because one of you guys are going to be a winner of a 1-week free trial of our standard program. So our standard program covers our clinical, OTC, counts and MEP. So we have a full week free access to all of that content, and you also have access to our question bank as well. So guys, if you haven't heard of me or even seen of me before, I'm going to give you a little bit of taster about myself. So my name is Georgina Gillard. I'm the MEP and OTC lead with Pre-Res Shortcuts, and I'm also a calculations tutor for Pre-Res Shortcuts as well. I'm a community pharmacist by background, and I specialise in anticoagulation. I have a special interest in mental health, and as a result, I was one of the COVID trainees, and I sat my exam during when COVID was absolutely wild. And essentially, as a result, during my training year, I created a COVID-19 mental health awareness service, and that was to support patients, but also staff, because it was a very, very nerve-wracking time for absolutely everybody. As a result, I won a Chemist and Druggist Award in 2021. And I also won an award at my university. I went to Medway School of Pharmacy for the best academic performance in the MPharm degree programme. And something that essentially Marvin always says, essentially when we do webinars together, in the GBHC registration assessment, I got 100% in my counts exam and 98% in clinical. And just so you know about pre-reg shortcuts, essentially we have been finalists with C&D for 4 awards across 2022 and 2023. So guys, are you ready to smash some calculations? Give me a yes in the chat, okay? Give me a yes if you are ready to smash out some calculations. We're going to give you a bit of a taste of the calculations that we do in this session, guys, and I'm going to give you a quick introduction to our question bank, and you can pick and choose what you want to see in that question bank. Okay, so rules of the game, okay? When it comes to our calculation session, make sure you have something to write with, make sure you have something to write on, and make sure you have a nice GBHC approved calculator. But if you don't right now, anything will do, okay? It's always good to practice your calculation with GBHC approved calculator. Okay, guys? So, guys, if you are ready, we'll move on to our first question. I will time you for 3 minutes per question. After that 3 minutes, I want you to tell me what your answer is to that question, okay? We will go through the question step by step and ensure that you have a good, thorough understanding, okay? So, guys, if you are ready, give me a yes. Give me a yes if you are ready. There's no need to be shy on here, guys. I don't bite. We will absolutely smash it. Yes, lots of yeses. Emma, Kira, Salita, wow. Damn, okay, right. Let's get started, guys, okay? So here is your first question coming up now. Okay, guys, that was your time. What answers do we have for this question? What answers do we have? If you wasn't too sure how to answer it, it doesn't matter. We're going to go through everything together. Okay, so what answers do we have, guys? Pop your answers into the chat. What answers do we have, guys? Yeah, 1.1 mil, 1.1 mil. Fantastic. Do we have any other answers apart from 1.1? Or are we all happy the answer is 1.1 mils? Okay. No, fantastic. It seems to be 1.1 mils. Fantastic. And that is the correct answer. Fantastic, fantastic, guys. You're absolutely smashing it. Okay, awesome. Okay, so of course we're going to have this patient. They're on the digoxin 62.5 micrograms, and because of a SALT assessment, essentially that patient is no longer able to swallow tablets, and we need to switch them to digoxin elixir. And of course, digoxin in terms of bioavailabilities, they differ. I've told you the bioavailability of the tablets is 0.75, bioavailability of the elixir is 0.85. Okay, and essentially what we need to do is that we need to find out the equivalent dose in milliliters of the digoxin elixir. So my little secret formula, okay, of course I'm not the one who invented this, but there's essentially a technique I always use for this, okay, is to follow this equation, okay? Whatever dose that you have of your tablets, you multiply it by the bioavailability of the tablets. And the reason why you followed that step, okay, is because essentially by doing that calculation, it tells you how much the digoxin actually reaches the systemic circulation, because of course, drugs get impacted by first pass metabolism via our liver. You then divide by the other bioavailability, and there you go. You have your equivalent dose of your suspension. So therefore, by doing that, you have your 62.5 micrograms multiplied by 0.75. That's the bioavailability of the tablets. Divide by 0.85 bioavailability of the other tablets, of the suspension, sorry, and that's going to give you the equivalent dose of 55.147058 micrograms. But of course, it's a 50 microgram in a mil concentration solution of the digoxin elixir. So what you can do a cross multiplication. So 50 microgram over 1 mil is going to be equal to 55.147058 micrograms over X. Okay, and you can solve that. Okay, and by doing that, that's going to give you an answer of 1.1029411 mils. But of course, I've been cheeky and I wanted to give you, I want you to give your answer to one decimal place, and that's going to be 1.1 mils. Fantastic. Does that all make sense for this question, guys? Give me a yes, thumbs up, wave, just so I know it all makes sense. Smashing. Okay. For your next question, okay, I'm going to give you a cheeky little hint and tip. You need to be hot on rearranging your formulas, and you need to be hot on your units and pharmacokinetics. Okay, just a bit of a cheeky hint. Okay, so if you guys are ready, let's move on to our next question. And here is your next question, guys. Okay, guys, that was your time for this question. How did we find this question? Everyone hates pharmacokinetics. I always find that if you ever, yeah, sorry, so please don't kill me, please don't kill me. Everyone hates pharmacokinetics, okay? I always reminds me of the scene from The Office, and you have Michael Scott going, you know, the screaming of no, 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 no. That's what everyone does with pharmacokinetics, right? So let's not worry and stress too much, okay? If you had an answer, pop your answer down. If it's not the right answer, it doesn't matter, because I'll explain this question to you. Okay, it was just an educated guess. Go for it. Okay, just go for it. Okay, because if you don't pop an answer down, okay, you don't have that chance of getting it correct. Okay, so essentially, we have this patient. Okay, they've been admitted to hospital because they're having another asthma attack. They have theophylline prescribed to them 200 milligrams twice a day. Okay, and naughty Mr. Lee, unfortunately it's not Mr. Gohill, my fiance this time, I've made up a character, okay? Naughty Mr. Lee has actually increased the amount of cigarettes he's smoking in a day. Okay, and of course that's going to impact the theophylline metabolism, because we know smoking is going to be an inducer of theophylline metabolism. And so essentially, we need to use this equation, okay, and calculate the most appropriate dose, okay, of theophylline for Mr. Lee to be taken every 12 hours, okay? So if you got an answer of 300 milligrams, you were smashing, spot on. That is the correct answer, okay? So that is the correct answer, so absolutely smashing. So the first thing that I want to ask you is, okay, we've got a theophylline clearance here of 0.02 litre per kilogram per hour. What are the units of clearance? Just guess. If you don't know, just guess. So I've been really, really cheeky in this question. I've been very sneaky, I have to be honest. Okay. So essentially the units of clearance are actually in litre per hour, because the clearance will actually tell you how much drug is going to get cleared from the body over a certain amount of time. So that's the units of clearance. So we have a theophylline clearance of 0.02 litre per kilogram per hour. So essentially what we need to do is that we need to get the units from litre per kilogram per hour to litre per hour. And how we do that is that essentially we multiply it by the patient's body weight, because we know that the patient weighs 75 kilos. So therefore, by doing that, that will give you an answer of 1.5 litre per hour. Okay, does that make sense about how we calculate the clearance? Yeah, fantastic, we're getting some nods, okay? Next thing that we've got to do is rearrange the equation, okay? With Canva, I never have an equation format, so I can never demonstrate it pretty, but I have written it down on a piece of paper. So how many of you struggle with rearranging equations? Or is everyone generally okay with that? Okay, we've got some, that's not a problem, okay? I know, I'm not too sure. Can you guys see this doodle that I've got on here? Can you see my little doodle on here? Should I minimize my screen, or can you actually see my writing here? Okay, all cool. Okay, so if I get you to write down the following, okay, the steady state concentration is going to be equal to the dose multiplied by the bioavailability, multiply that by the salt factor, okay, and you're going to divide it by clearance, multiply that by the time interval, okay, and how you can rearrange it is essentially is that you multiply both sides by the clearance and time interval. By doing that, the clearance and time interval will actually cancel each other out here. And therefore, you actually get a rearranged formula of this, okay? You get steady state concentration, multiply that by the clearance, multiply that by the time interval, is going to be equal to the dose, multiply that by bioavailability, multiply that by salt factor. Then what you can do is divide both sides by bioavailability and salt factor. By doing that, okay, your bioavailability and salt factor will actually cancel out on this side here. And that will give you your rearranged formula of dose is going to be equal to your steady state concentration, multiplied by clearance, multiply that by time interval, divide that by your bioavailability and salt factor. Okay, so does that make sense about how to rearrange the formula, guys? Smashing. Okay, so once we've actually rearranged that formula, we can just plug our numbers into the formula now, because we've got everything in the correct units. So essentially our dose is going to be equal to 15, because in the question, I've told you that the steady state concentration needs to be 15 milligram per litre. multiply that by the clearance as we have just calculated, and we're going to multiply it by 12 because I told you what that time interval is. I was quite nice here. Not all questions do that. Okay, we're going to divide that by 1 for by availability, and then divide by 0.9 for the salt factor. And by doing that, that will actually tell you that the patient needs to have 300 milligrams twice a day. So because I've actually asked you to calculate the most appropriate dose to be taken every 12 hours, the answer that you need to put in the exam is going to be 300. So 300 milligrams. Okay, does that make sense, guys? Yeah, smashing. Okay, are you ready for your last question before we move on to our question bank? Yes, okay. So I do need to send you a resource pack. It's just a link. It will open up perfectly fine. So if I just pop it in, that's going to straight to hosts and panelists, and I'm going to send it to everyone as well. Okay, if you can just let me know when you've got that up and open, guys. Yeah, fantastic. It should be the SPC for ceftriaxone. Okay, so if you've all got that open, guys, I'm going to start your time now for this question. Okay, guys, how did you find this question? How did you find it? It was all right? Well, that, well, I was being evil, Georgina, again. I'm sorry. So, okay. So generally, I wanted to put this in here because essentially in the GPHC registration assessment, we're having more questions coming in about patients who are transgender. Okay. And so I thought it was really important to cover this topic for you guys. Okay. So how many of you were not sure about what constant to use in this patient for the creatinine clearance formula? Okay, no, that's perfectly fine. Perfectly fine. Okay, we're going to go for a bit of a hypothetical situation here, because essentially the standard is there isn't actually any set standard, okay, about whether we sign a male or a female constant. Okay, it actually depends on a case-by-case basis. Okay, some research papers say you should actually calculate with both male and female and actually have a range. Other research papers say creatinine clearance is not accurate at all in transgender patients, and maybe we should do an estimated glomerular filtration rate or an absolute GFR. Okay, so essentially kind of like there is no set standard currently at the moment about what we do. Okay, so when it comes to the creatinine clearance formula, okay, why do we have different constants for men and women? Why do we have that? You can shout out your answers, I don't mind, guys. Okay, so the reason why we have a difference in our constants, so 1.23 for males and 1.04 for women, is that because essentially the creatinine clearance, okay, it's based on creatinine, okay, and there's a biological difference in muscle mass between men and women, okay, it's a biological difference, okay, and then of course creatinine gets mainly formed in our muscles, and so therefore, because if there's going to be a biological difference between males and women, with their muscle mass, there's going to be difference in terms of how much creatinine gets excreted from that muscle. Okay, so that's why we have those constants. Okay, let's go through a hypothetical situation. Okay, let's say, for example, we're gonna use me as the subject. Okay, so Miss Gillard over here, okay, I want to transition to a male, okay, and if I wanted to go through phalloplasty surgery, but I haven't had hormonal surgery, so phalloplasty surgery, just essentially to explain to you, it is a gender identification surgery where they form a artificial phallus, scrotum, and testes, okay, and that surgery is for gender identification for the patient. Okay, so if I had phalloplasty surgery and I haven't had any hormonal surgery, would that make a difference to what constant we use? Would that make a difference to my muscle mass? No, I'm getting some shakes. Fantastic. It's not going to make a difference. Okay, so in that case, I will still have a muscle mass that reflects the female body mass. So therefore, you use the female constant in my case. Okay, if I went through hormonal surgery and I went through hormonal treatment and I was on testosterone therapy, okay, and now I reflect a muscle mass more of a male, what constant would you use? Yeah, I can see some, I can lip read, I can see some males, yes. I think that was you, Craig. I thought I can lip read, yeah. Okay, so it'll be a male constant. Does that make sense? About, yeah, okay, fantastic. Okay, so essentially, this patient, they haven't yet received hormonal or surgical treatment. So therefore, what constant do we use in this case? Male, yeah? Male. I was trying to figure out the lip reading, okay? I'm quite good, but I'm not quite perfect, okay? So you would use a male constant because this patient hasn't gone through any hormonal, any surgical treatment, and they would actually have a muscle mass reflecting of essentially of a male patient, okay? So essentially, that's what we do, guys, okay? So step one, we're going to calculate the creatinine clearance using the formula, but we're going to use the male constant because the patient hasn't gone through any hormonal or surgical treatment, okay? So their muscle mass is still reflective of a male patient, okay? So essentially, when we calculate that, so we do 140, take away the body weight, so it's going to be 64 kilo. Oh, sorry, said that the wrong way around. 140, take away the age, which is going to be the age of 64. Multiply that by 62 kilos. That's the patient's body weight. Multiply by the male constant. That's going to be 1.23. Divide that by the serum creatinine. That's going to be 288. And that's going to give us a creatinine clearance of 20.124166 mils per min. Okay, then we're going to look under the SPC. My top tips for you, okay, if you're going to have an SPC question and you have a creatinine clearance question and you need to find out if there's going to be a dose adjustment, the information is always going to be under the clinical particulars, okay, so part 4 of the SPC, and it's going to be under posology and administration, okay. So the structure of it is you have your normal dosing, okay, and underneath it will give you details about patients with renal impairment, hepatic impairment, pediatric doses, okay, so that's the general structure, okay. So is everyone happy about how you can find that information in the SPC? Okay, if you need me to show you, just let me know and I can do that for you. Okay, So when you go onto the SPC and you look under clinical particulars, posology and administration, it will tell you that the normal dosing for complicated skin and soft tissue infections is going to be 2 grams once daily. This is going to be suitable for the patient. This is the perfect dose because the patient has severe cellulitis. Okay. And then if you scroll all the way down, okay, and it says patients in renal impairment, it will tell you this. I've copied and pasted from the SPC. It will tell you there is no need to reduce the dosage of ceftriaxone if the hepatic function is not impaired. So I've told you in the question here, patient has no hepatic impairment. Okay. So, oh, there we go. Okay. So essentially, as a result, okay, we keep our dose as 2 grams once daily. Does that make sense about this question? Yeah, fantastic. I'm getting lots of nods. Fantastic, fantastic. Okay, awesome. Okay, so guys, who wants to check out our pre-read shortcuts question bank? Give me a yes. Give me a yes. Yes, lots of thumbs up. Amazing, amazing, amazing. Yes, 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 yes. Okay, right. I'm going to quickly stop my share for 1 second, and then I'll have to bring up my screen. Just give me 1 second, guys, and I can do that for you. Okay, if I go on here. Okay. I have to do a new share. Just give me 2 seconds, guys, because I'm sharing directly from the website. Okay, guys, can you see our website here? Yes, fantastic, fantastic, fantastic. Okay, so I bet you it's logged me out, hasn't it? No, I'm still logged in. Fantastic. Okay, so if you're not registered with any of our courses, you can actually have a free trial of our question bank, okay? And our question bank covers the whole GBHC assessment registration framework. Covers absolutely everything. There's over 1,000 questions on there, calculations, clinical, OTC, and MEP. And you will find the question bank if you go onto our website here. Okay, so guys, what do you want to see? Do you want to see a mix of clinical? Did you want OTC, MEP, calculations? Shout out or put it in the comments what you want to see, guys. Just pop it on them. Okay, whatever you want to see, you can see it. Okay, you're getting some OTCs, fantastic. Okay, so let's go on to our OTC. Okay, so if I just do clinical waiting, I have to do 5 questions because that's the minimum we will actually for the questions. And essentially what it will do is that you type in how many questions you want and it will give you the recommended duration, but you can always edit it here. So if you wanted like 2 minutes or like 10 minutes, you can do that. You can edit according to your learning needs. Okay, so if we go, we're going to start on the quiz. Okay, so we have questions like this, guys. Okay, so of course, if you actually go onto our website, you'll be able to click onto the SPMC. So if you click on here, and boom, there's an SPC edit base there for you. Okay, so if I just quickly move on to the next question. Okay, so let's say, okay, have a go at this question. Just have a go. Just pop a random answer down, guys, and we'll have a go. Okay, so guys, what are we thinking for this question? Okay, so psoriasis is a condition that you're going to find very common across patients. Or we're getting some cyclosporin, okay? Okay, we're getting some cyclosporin, okay? Okay, we're thinking cyclosporin for this one, okay? So we'll skip this one because there's an SPC and essentially you can't see both of them. Let's go for this one, okay? So the answer for that one was actually, I think it was lithium. Yes, it was lithium for that question because lithium actually induces psoriasis flare-ups. You can actually have a medicine-induced psoriasis flare-up. Okay, guys, what are you thinking for this question? There's 2 red. Yes, A&E, fantastic. Why are we thinking A&E in this case? What do we think is actually going wrong with this patient? So first of all, one of the red flag symptoms, a new onset of a headache with no explanatory cause in over 50s. Okay, that's an urgent job anyway. Okay, but essentially she informs you his headaches are severe, intense pain at the back of the head with nausea and vomiting. Okay, he's been vomiting with the pain. What do we think is going on with this patient? If you're not too sure, just guess. So you're all correct. So basically go to, could potentially be meningitis. Okay. Okay, so migraine. So the differential for migraine is that essentially the headaches wouldn't necessarily be, so in terms of the severe intense pain at the back of the head, it will essentially become around this area. A migraine often has a shooting pain and it often affects one lobe. Okay, so it often affects one lobe. Sometimes it can affect both lobes. Okay. So essentially with severe intense pain at the back of the head with vomiting can actually be a sign of a subdural hematoma. Just a fun fact there for you. Okay, so if we go through essentially to this one, we have lots of nice pictures. Okay, the picture is quite large. Okay, so have a look at this and just let me know when you're, just give me a thumbs up when you're ready to, when you're ready for me to scroll down the page. Okay, get some, fantastic. And what do we, what's wrong with this what's the option here? Okay, we're getting things for refer to GP. Oh, Emma, you're straight on it. Okay, refer to GP. Chloramphenicol is not licensed for those under the age of 2. That is spot on. Okay, so yeah, fantastic. They've got bacterial, the child's got bacterial conjunctivitis. We can see here that both eyes are actually affected in this case. We've got some nice crusty eyes here, haven't we? Some nice crusty eyes. So we can tell straight away it's got a bacterial here. Okay. So just a quick throw out question. What's the difference between bacterial and viral conjunctivitis in terms of their symptoms? Does anybody know about the difference in terms of their symptoms? So for instance, if you had, yeah, okay, the eyes are also going to be effective, yeah? So viral is less yellow discharge, fantastic. So essentially bacterial conjunctivitis, it can affect one eye, but of course it can affect both eyes because they're very contagious. So is viral conjunctivitis, okay? And the main thing is here is that you don't have the gunky discharge, okay? With viral conjunctivitis, it will be a watery streaming of the eyes. Both eyes are actually going to be very red and it often comes along with a cold and flu. So an upper respiratory tract infection, you can often get a viral conjunctivitis as well. So essentially, when you go onto our question bank and you submit your questions, it will give you feedback, okay? So we give you the answers and feedback to say it is correct, okay? Your answer is correct, okay? Say it's an emergency situation for this patient with their headache. Could be a sign of a subarachnoid hemorrhage, okay? And also I'll tell you in terms of what your red flag referral is. Anyone over the age of 50 with a new onset severe headache is an immediate red flag referral, okay? And it'll be very similar to, if I just quickly go back, so let's say, for example, let's go to this question, okay? If you didn't get this question correct, it will tell you, okay, your question is incorrect. It'll tell you what the correct answer is. And we also give you an explanation of why that answer wasn't correct. And we tell you what the correct answer is and why. Okay, does that sound awesome, guys? I think I have just seen the request to go through just to have a quick look to see about mixed. Okay, so I'll just quickly show you that and we'll go on to our raffle, guys. So I'm a bit cautious of time. Okay. So fantastic. We're going on to a bit of mixed here. So if I just do 5 and 5, let's go for some high weighted topics. Screw it. Let's go for high weighted. Okay. And we're going to Stars Hall quiz. Fantastic. Let me just scroll this down so you can see the whole lot. There we are. So in our question bank, we have extended matching and single best answer questions. So everything is covered there for you guys. Okay, what are we thinking for this question? If you're not too sure, just guess. It's perfectly fine. I always say to trainees, essentially, if you're never too sure about a question and when it comes to your exam, okay, you can always have the option to flag a question like we do here, and you can have the option to go back to it, okay, because essentially in an exam, your time's limited, okay, and even if you guess, you always have a chance of actually getting it right. Even if you're stuck between a couple of options, if you guessed, you always have a chance of getting it right. Okay, it's just the basis of probability. Okay, someone's saying insulin decimir. Okay, let's go through that. Okay, we get some insulin decimir. We just go through to review the answers. Okay, we go. Is it? Oh, I have to submit it first. Sorry, I'm being a plonker, guys. Let me just go review answers, submit answers. Okay, fantastic. Okay, so you were correct with insulin decimir, guys. Okay, fantastic, fantastic. Okay, so essentially have a long duration of action of up to 24 hours. Okay, don't have any pronounced peak of action. Okay, and it's very, very suitable for those who are going to be traveling across different time zones because they can be injected at any time of the day, as long as you keep it to essentially the same time interval each time. Of course, if you're going to be injecting it essentially 24 hours and then 12 hours the next day apart, of course we're going to have a problem, but as long as you keep that interval the same, perfectly fine. Fantastic, guys. Okay, right, let's just do a new share for you guys. So what do you guys think of our new question bank? I say it's new, but we've had it since November. We've released it in November. What do you guys think of it, of our question bank? Do you like it? Yes, we're getting lots of nods. Fantastic, fantastic. Okay, awesome, awesome. Okay, guys. So, yes, you love it. Amazing, amazing. Okay, so who loves a freebie? Who loves a freebie? Of course, it's not going to be a pre-reg shortcuts webinar without a freebie. Who loves a freebie? Give me a yes, guys. Give me a yes. Because essentially your freebie, okay, is going to be a 1-week free trial of our standard program. You can have access to all of our standard program, okay? Take advantage of our standard program for a whole week, okay? So essentially, the winner, please email info@preregshortcuts.com. Okay, just give us your name and contact number. Okay, so then essentially we can arrange that free trial there for you. Okay, so guys, just quickly before we do the draw, okay, in order to access our free revision materials, if you scan this QR code, you can actually join our free mailing list and you can get up-to-date GPHC style questions and answers emails to you on a daily basis. And of course, subscribe to our YouTube channel as well, because we have more than 200 free videos on there for you. We've got MEP, OTC, counts, clinical, all there for you guys, okay? So who wants to win free access? Who wants to win free access? Give me a yes if you want to win it. Give me a yes in the comments. And what I will do, I will scroll up and down. Okay, I will scroll up and down. Okay, and then I can just close my eyes. Yes, amazing. I'm getting yeses, yeses, yeses. Okay, fantastic, fantastic. Okay, I'm going to close my eyes, guys. Okay, and I am going to close my eyes and I'm going to randomly pick. Okay, so I'm just going to get my scroller ready so I could just, oh, hang on, my scroller's not working. Okay, there we are. Okay. Okay, so I'm closing my eyes, guys. Closing my eyes, closing my eyes. My eyes are covered. And I've got Alexandra Tan. Alexandra Tan. Are you here, Alexandra Tan? Oh, you won a 1-week free trial. You won that 1-week free trial. I can see you. Yes, you go, oh my God, I'm here. Okay, amazing. Okay, so you won a free trial of our standard program. So please email info@preregs shortcuts. I'm just going to type it in here for you. info@preregs shortcuts.com. Okay, if you just email that, okay, Alexandra, okay, you've won that free trial. Okay, so fantastic. Okay, so just so you know, if any of you guys actually want to join our course, okay, we have our programs are available now to join. Okay, you have access all up to your June exam, and of course we do the same for the November exam, etc., etc. For every exam, you have access to your course content essentially till your exam. We have over 140 hours of recorded interactive clinical and calculations, MEP and OTC content. We have over 40 live sessions, okay, for you. So these live sessions are to help you to consolidate your learning, get active recall is essential for your learning. Lots of questions, okay, different from the pre-read shortcuts question bank, okay, and it's just a good revision session for you. You'll have exclusive access to our Telegram group with additional resources, summary sheets, mind maps, and of course we have a fantastic pass rate with pre-read shortcuts. Absolutely fantastic. All you need to do is check our reviews on Trustpilot and you will see what people think of our course. Okay, fantastic, guys. Guys, did you enjoy that session? Did you find it fun? Okay. Did you find it fun? So you got to have a look at we got to smash out some calculations, and you also had a look at our pre-read shortcuts question back. Yes, you loved it. Fantastic. Amazing, amazing. Okay, guys, I am really glad that you enjoyed that session. Okay, do you have any final questions for me before our session ends? Any questions at all? I'm an open book. You can ask me anything. Okay, I don't think there's any other questions. Okay, I'm glad you guys enjoyed it. Okay, did you learn stuff today? Yes, woo, that's what we like. Okay, yes, okay, you're very welcome. You're very welcome for the session, guys. Okay, so this is the end of the session. I'm glad you enjoyed it. Okay, and congratulations, Alexandra Tan, you won the free trial. Woo! Okay, time to party. Okay, so congratulations. Okay, this is the end of the session, and thank you all very much for joining, and thank you, BPSA. It's a great honor to do a webinar for you guys. Okay, so catch you guys later soon. Okay, and also don't forget about our YouTube videos, because we've got a live session next week as well. So catch you all guys on YouTube. Okay, adios amigos, see you later.
Thank you, Georgina. Take care. Thank you for joining us. We appreciate it. What an amazing session you put for us.
Oh, that's amazing. I'm just glad you enjoyed it. Okay, really glad you enjoyed it, guys.
Absolutely. Thank you for joining us.
No problem at all. See you later, guys. Bye-bye.
Bye. Amazing. I think we're just waiting for our next speaker to come in and join us as well. So I think he should be joining in a few minutes, and we'll get a head start once that happens. But yeah, I really hope you guys enjoyed the session. It was very engaging. And yeah, I feel like it's a really great sort of way to, you know, I guess refresh on all of our of our clinical and calculation skills. But of course, I think at any stage in your training and your learning, it's always important to take a break, but also come back and like revisit these topics again and again. And as you have heard from Georgina, they have a wide bank of resources, wide bank of I think webinars. They also have different sessions, their programs and courses that they provide. It really is incredible. And congratulations as well to Alexander for winning the raffle. I really hope you enjoy the 1-week trial and find it very, very useful. But yes, definitely, guys, thank you for being so engaging, so interactive. I'm just going to give it a few minutes for our next speaker to join us. And yeah, we should have our next workshop coming up next. I'm not sure. I think there's a poll as well, Key. Did you make a poll for the session previously?
Yeah, I can put another
Yeah.
one up. Give me one
Yeah.
moment.
Perfect, thank you. Oh, Fayas is just joining us. Let's wait for him to get on the platform. There you go, guys. We have the poll up for the session Georgina just delivered. So be really helpful to get your feedback, see how you found it, if you found it helpful. And obviously go and explore all of their courses, their page, all of their contents and resources, and hopefully it should help with your training or with your studies. But yeah. And now we have Fayas joining us. Hi, Fayas.
Hello, guys. Hi.
Okay.
Hello.
Hi.
Can you all hear me?
Yes.
You can all hear me. Smash it.
Amazing.
Shall I make a start or?
Absolutely. Well, I just want to introduce you to all of our attendees here today, if you're not familiar with Fayas. So he is the founder essentially of Kazi Academy. He's the education lead, and he's also a local pharmacist. But anything else you want to share about yourself before you start your session as well?
I'm also a father to one beautiful princess, so I thought I'd mention that as well. Yes, so I'm looking forward to speak to you guys and giving an insight into your exam and giving you guys a hopefully an inspiring 35-40 minutes talk, and hopefully you'll take away from that and take benefit and really crack on and revise extremely hard for your exam. Is that okay? Shall I share my screen? I've never shared the screen before.
Yes, you could try and share your screen.
How do I share the screen? Let's have a look. Share screen, green buttons here. Okay, right. Right, I think. Can you all see?
Absolutely. Yeah.
Okay, smashing. Let me. Can you all see? I've just made it a bit bigger. Is that okay? Yeah, smashing. Sorry, I'm not very technical, so I thought I'll make. So yes, guys, hi. Hope you're all doing really, really well. My name is Fayaz. As Salita mentioned, I'm the founder and education lead of Kasi Academy. And today's talk is about your June GPHC clinical exam. And we are going to talk about how you are all going to smash your GPHC clinical exam in June. Okay. So just a little bit about myself. I graduated from the University of Bradford in 2019 with a 2-1 honours. I then did a 1-year pre-reg in a community sector, which was not far from my house. It was only about 10 minutes from my house. So it was quite ideal. Luckily for me, I had a really, really good pre-reg tutor, and she was really helpful. And she gave me immense confidence in my work, and I took that into my GPHC exam. Unfortunately, in that year, obviously, we all know we had COVID. So I was part of the COVID cohort where the GPHC unfortunately cancelled our exam. And they did not tell us when we will be doing the exam. So it was a bit like we were all revising, but to no affirmation when the exam was going to be. And it was quite annoying for me and a lot of the trainee pharmacies. We took to Twitter. I was kind of like spearing a change with the PDA, BPSA as well. And luckily our exam unfortunately got delayed until March 2020. So that was the first ever online exam that the GPHC had done. So with it being the first ever online exam, they were going to be teething issues, unfortunately. So I sat my first ever exam in March 2020. I was quietly confident. I will be honest with you, because I had finished my pre-reg in July 19. So I had a good 8 to 9 months of no work, but just purely studying for the exam. I actually smashed the clinical exam, and I'll tell you all how I did that in a few minutes. I scored 105 out of 120 in the clinical exam, but unfortunately, in the calculations, I don't know whether it was just fear of the exam or fear of the unknown or lack of preparation. I'm going to put it more down to anxiety and being scared of the exam. That's what I would most likely, looking back at it. It was more so a fear because calculation was the first exam. I don't know. My mind was going crazy. I was thinking about everybody, my wife, my mom, my late grandma, my cousins, my brother, like everybody, unfortunately. And I think I let that got the better of me. So one key thing I will definitely share with you guys is curb your stress levels. I don't know, maybe find yourself a stress ball, or I don't know if you guys listen to music or like a holy book, use some form of coping mechanisms because it is an exam that is obviously going to make or break you. And unfortunately for me, it broke me in the first attempt, and that's why I'm here today, and that's why I founded Cassie Academy, because unfortunately there are a lot of people that just get succumbed to the pressure. It can get you. I was part of the 12% that unfortunately failed that exam. I think it was probably the highest pass rate that there was in history of the GPHC exam. 88% of my cohort passed. All of my friends passed. Every single person that I knew had succeeded. And the one that really needed to pass, i.e. myself, because I was married and I didn't know how to even pay my bills because I was not working. It was really a very, very, very tough time for myself, for my family, but we kind of stuck in there. Okay. uh, Gladly for me, the GPHC, because of COVID, because of what they did, they allowed they allowed another attempt in that July. So I didn't have to wait until November of that year. Otherwise, that would have broken me even further. They gave the people that failed a second attempt in July 2021. And luckily for me, uh, I think that exam went well. With exams, I never know whether it's gone well or not. It really is. It's scary because you know that, especially this is your final hurdle, and you know that you trainees have jobs on the line, trainees have families on the line, trainees have your life on the line, really, if you think of it. And the results came out. I really do remember this. I'll never forget this. 9th of September 2021. Leading up to that, I will admit I was kind of scared. I was pretty scared. I did not want to sit the GPHC exam for the third time. I really did not want to sit the exam for the third time because a third exam is difficult. You're in there, but you're not in there. You're thinking about everything. You're over complicating every single thing that is going in your brain. And unfortunately, it's an exam that really mentally gets you. People, like, I can safely say for me, because I feel I'm speaking from first-hand experience. People that fly with flying colors, great. I'm really happy for them, but the majority or even half of the cohort, we find it hard. I've not scored 100% at university at all, so it really is a tough exam. But there has to be a standard. To become a pharmacist, the GPHC have to make the exam, I wouldn't say difficult. It's just the standard of UK becoming a pharmacist. If you were to live in America or Canada or wherever, you'd have to get their standard of becoming a pharmacist. So it's the same over here. The results actually came at, I think, 5:50, not 6 o'clock. I'll be honest, I was ridiculously scared to have a look at. You get a notification via your my GPHC account, and I just could not do it. I told my wife to have a look, and bless her, she just clicked in, she just clicked on it, and all she said was I passed, and I was like, you what? Like, well, I was really, really, I mean, goosebumps. Look, speaking to you about it, it really is. I mean, I've got goosebumps coming out, and it was a day that okay, it changed my life. It really did. Working hard, working tirelessly, everything kind of got together. And I'll tell you my scores just to inspire you guys. I actually scored the exact same mark in clinical exam again. I got 105 out of 120. That's mad that, I mean, I'm not even saying that to show off. I'm actually just saying that to inspire you. I never really publicize my scores in the public domain. I'd rather just keep it quite humble. But it really is. I'm saying all this to inspire you guys. I want you guys to work hard, and when you work hard, you reap the fruits of your hard work. I know this is a clinical talk, but I'll mention my calculation score as well, because obviously, as you know, I got really bad score. I increased my score by 76% from 17 out of 40 to 30 out of 40. And this was all done by single-handedly. I did not do anything different. I just worked incredibly hard, did loads and loads of calculations that I could get hold of. And then I realized that, wow, I think I need to do something, because I kind of had the passion that there are a lot of students that are coming to me, but I'm not doing anything. And I just realized that when you fail second time, third time, or even your first time, it knocks you back for a six. And it's these trainees that, I'll be honest, we all forget, we neglect. I'm not saying that people neglected me, but I can safely say people did. My friends neglected me. I'm not going to say family. My family were always there, but my friends who had just passed, I was helping them. They were not helping me, and I was like, wow, this is just ridiculous. Even companies who I was speaking to, potentially, there was just no pastoral emotional care, and I just felt that I needed somebody to hold my hand and say, Fayaz, it's going to be okay. And this is why I have created Cassia Academy, because many trainees who fail second and even third time, those that have failed third time, I actually help them. I don't even charge them money. I help them write a letter, and then they are able to get a fourth sit. You cannot get a fourth sit if you don't know how to navigate how the GPHC operate. Now, I'm not saying I've got a PhD with the GPHC. No, all I know is that I know how to help, and that's why we have created Cassie Academy. That's my logo, a little fancy blue logo for you guys. So yeah, your clinical exam is 120 questions in total, guys. Okay, it's 2.5 hours in total, unless those trainee pharmacists get extra time. Some might get 20%, 30%, 40%, or the maximum is 50% extra time. Okay, I do believe that the reasonable adjustments deadline, if you are wanting to apply for reasonable adjustments, which I would always advocate for, if you have sufficient grounds to get extra time, I would 100% get extra time if you can. It just alleviates pressure. It allows you to think of that, do that calculation questions twice. It allows you to do the easy questions in calcs and clinical twice. It allows you to focus on the hard questions that you've flagged and you don't know what the hell you're doing. Just the extra time gives you a breather. It really does give you a breather. Okay. And your clinical exam, you have 90 single best answers and you have 30 extended matching questions. Okay. So your exam is out of 120, and you are required historically to get around 77 or 284. Okay. The past two cohorts, the exam pass mark has been 77. In my opinion, that's pretty low. Okay. I think when I passed, it was about 84 or 85. So historically, the exam is getting slightly harder, a little bit, a tad harder. Okay. But if you master your content and if you know your content in calculations and clinical, there's no reason why you cannot score above 90 in clinical and above 29 in calculations. But you have to be working hard literally now. You don't work hard from April onward, it's too late. You have to, if somebody told you that, for example, somebody like myself, I go to the gym to lose weight, okay? And if somebody told me that, Fayaz, you're gonna lose 2 stones by the 1st of August, I I would follow their nutrition diet, I will follow their gym routine, I would follow everything that personal trainer is telling me because I do want to lose that 2 stones. So it's the exact same thing for you guys. If I'm telling you start studying from today, there's a reason for that. That doesn't mean that you kill yourself and you work 10 hours a day. No, you maximize your time, and I'll tell you how to maximize your time very shortly. There will be around 25% of your clinical exam will be based on resource pack questions. These resource pack questions can be photos, it can be graphs, it can be extracts from the BNF, it can be extracts from your SPC, it can be almost anything that GPHC will throw to you that you then need to extrapolate the key information from whatever they've given you. So generally, a lot of people get scared and worried about resource pack questions, but I kid you not, if the answers that you're trying to get is in front of you, you just need to remain calm. If it's a 4-page resource pack, you just look at it carefully and you can get to the right answer because the answer will be in that resource pack for calcs and clinical. Okay? If you don't already follow us, this is our little fancy Instagram page. Give us a follow. It would mean an absolute world for myself and my team. The bio says it all. We actually help trainee pharmacists not only pass your exam, but smash the registration exam without spending countless hours revising aimlessly. And I tell you why that. It's important because currently, many of you who are working full time, number one, you don't have time to make your own notes because you're working a 9-hour shift. Number two, you don't have time listening to 500 pages on a PowerPoint. You don't have time because you're working full time, you're shattered. You need to use resources that, in my opinion, are efficient, that are latest, and are there going to help you. And I'll tell you how we can potentially help you guys. Okay? So you're probably wondering, how did Fire score 105 out of 120 twice? I remember I told you that I was part of the COVID cohort and I had around 8 to 9 months at home. I was unemployed, I was not working. My main aim was to pass the registration exam. My wife was working 4 days a week. I was literally at home doing the cooking, cleaning, and ensuring that I work a lot of hours in the day. And equally, because I had so many hours in the day, unlike you guys currently, I was able to change my routine. So I've actually collated your full BNF, which is 1,300 pages long, in a, in 130 pages, literally. And it's all in question and answer format. Okay, you do not need to spend countless hours flicking through your BNF or making your own notes because you don't have the time. And it covers you the full high, medium, low weighted chapters, OTC. And to date, I've only been doing Cassie Academy for about 16 months now, and we've helped over 300 trainee pharmacists become a pharmacist. We've helped 300 trainee pharmacists achieve their dream of becoming a pharmacist. Okay. I've just put a sample there. There's a 2-page sample on our website, but this is basically what it looks like. It's all in question and answer format. It's based on the science of active recall format. Okay. For example, let's have a look at which is the only anti-diabetic medication, anti-diabetic medication that does not require a dosage change in renal impairment. So potentially the GPHC, what they would do, how they would reword that is, there's a guy called Philip. He's 55 years old. He's on paracetamol, bisoprolol. He's on not cocodamol because there's an interaction there. He's on finasteride, and the doctor wants to initiate antidiabetic medication, but his EGFR is probably 28 or 29. Okay, and that's how the GPHC would overcomplicate it in your head. So my main motto is, if you know the facts, if you know the science, if you know the clinical content, you know that the answer is linagliptin, because linagliptin is the only medication that does not require a dosage change in renal impairment. So I've given you the understanding of you basically just need to retain that information. The GPHC will put a bit of spices and masala into it, but as long as you know your content, you will be absolutely fine. Okay, so it's all carefully done in endocrine, infections, gastro, you name it, all of your high, medium, low weight chapters. The second page is from our CNS notes. It's got your treatments for atonic, clonic, Dravet syndrome, Lennox-Gastaut syndrome, treatment of status epilepticus, medical emergencies, very, very important to learn in your GPHC exam, because as a community pharmacist, as a hospital pharmacist, as a PCN pharmacist, you will encounter medical emergencies at work. I think about a month ago, I had a medical emergency at work. I was really, really scared. Luckily, the patient was okay. She had a absence seizure, a little girl, 6-year-old girl, in the pharmacy. It was quite scary, to be honest. We called the ambulance. She came round after 1 or 2 minutes, but luckily she didn't go on the floor and all that stuff. But that's why it's so important that you're not just learning all this content that I'm showing you. You're not just learning for your GPHC exam. You're actually learning it for practice. Whether you become a community pharmacist, local pharmacist, hospital pharmacist, industry pharmacist, you need to know your content. And that's what we do. We help trainee pharmacists master their clinical content and calculations content. So I don't know if any of you have been on our website, but we've got separate little products, colorful products. The first one is our Cassie Academy activity called Clinical Notes, which is what I've showed you guys. That is literally only $199. You can pay by Klarna at checkout, and you get full access until the day of your exam. None of this 6 weeks, 12 weeks, 20, 30-week access. It's literally until the day of your exam. If you fail your exam, which hopefully you won't, I extend it until your November exams with no hidden fee, with no extra fee. I'm here to support you and achieve your dream of becoming a pharmacist. I've got students that really I'm there pastorally, emotionally. Okay, we have a separate calcs course, a separate clinical course. So those that are okay with calcs can buy this, the clinical and vice versa. But our blue photo, which is a full Cassie Academy combo course, is basically all those three. It's the clinical course, calcs course, and you also get the Cassie Academy clinical notes for free, literally. I'm not even lying. You get that for free, saving you $199. And the reason why trainees, majority of them are going for that, is because they get an unwavering amount of support from myself. I think I'm the only company, I know I am, and I'm not showing off, that gives my trainee pharmacists, Cassie Academy trainee pharmacists, 24/7 access to myself, not my team, to me. If somebody messages me, if Salita messages me at 10 o'clock, I'll message her back at 10:15. You know, it's that pastoral care. You know, it's very, very important. When I failed, unfortunately, nobody was there to indirectly hold my hand. And this is why Cassie Academy is, I'll be honest, as you know, there are a lot of providers out there. We know that. You know all the names. But there's not a company out there that gives that TLC like how I do. And that's what is quite important, because we all need that TLC. We all need that daily motivation. We all need that daily support. And if true trainees get the combo course, they get that, they get added to the WhatsApp group. They can message me anytime personally. I just ask my trainees, do not message me after 11 o'clock at night because I'll be sleeping. But yeah, if I'm at work and somebody messages me at 2 o'clock, I'll message them back instantly. And that's quite important to know as a trainee pharmacist, knowing that you've got a guide there helping you in the wings, and that's important. Okay. I'm not going to go through this. It's all on the website, and I've given you guys a full brief of what we do. I'm just going to skip that. It's on the website anyway. But I've got a bit of a gift for you all. A Saturday morning, Saturday afternoon gift. I'd love to help every single one of you achieve your dream. So I'm giving you all a £50 gift voucher to use on the Cassie Academy combo course. One of the reasons why it's just on the Cassie Academy combo course is I don't want trainees to favor calcs over clinical or clinical over calcs. You need the full learning experience for calcs, for clinical, and you also get the clinical notes for free worth 199. So you save a lot of money. And if you pay by Klarna at checkout, I think it's like 125 quid for the next 3 months. But you get access until your June exam. And we also the only company that will extend it for free for your November exam. Now I don't want anybody of you guys to fail. That's why it's important for you guys to take advantage of this lecture or this teaching session. Okay, so our website is cassieacademy.co.uk and user code cassieacademy50 at checkout. If you want more information or if you want a one-to-one consultation call, feel free to reach out to me via Instagram DM, and I'm more than happy to give you guys more information on why we have the best course. Okay. Now, guys, a bit of learning for you all. Have you all got your uh, brains fired up for these 5 questions? So, guys, I'm gonna give you guys about 30 seconds just to read the question, okay? And I'm going to. I can't see the chat, but yeah, read the question, and then type the answers in the chat. I will let Selita see the comments because I can't see any. But yeah, I'm gonna be quiet for 20 seconds and I'll let you guys focus, okay? You all got an answer, guys? Ah, I can see the chat now. Okay, that's cool. We've got a few answers coming in. Molluscum contagious. I can never pronounce it. I'm just gonna call it as MC. Molluscum contagiosum. Is that the answer, guys? Yes, guys, it is. Okay, so it's not acne. In little children under the age of 10, it appears pretty much like that. When you try, it's not even like a spot, so you can't even bust it like an ulcer. It's like hard. Um, as long as the patient's got no fever, um, it would just be a basic OTC sale of paracetamol if they have pain. There are molluscum contagiosum tablets, but we rarely give them out in practice, and I highly doubt GPHC will expect you to know that. All you need to know is the photo. The NHS website is a pretty cool website. NHS A to Z conditions for your OTC conditions, because I've got a feeling that that's where the GPHC get their photos from. Okay, so that's the first question. Let's move on to the second question. I'll give you guys about 30 to 40 seconds. What is this? Great answer. We getting some answers in. Measles, mumps, rubella. Yeah, guys, this is measles. Obviously kids rashes can present with almost anything, okay? But the distinct differential diagnosis why this one is measles is because the patient has whitish grey Colpic spots in the mouth. So if you're a pharmacist in practice or GP surgery or even hospital, you just tell the little child to open up their mouth, and you will actually see. I've seen it in practice loads of times. It appears like oral thrush, but obviously it presents with a widespread rash. It presents with fever, and yes, this is measles. So make sure you know your measles, mumps, rubella, scarlet fever, hand, foot, and mouth. You know, all those classic pediatric OTC conditions. Okay. Now this is a good law-based question. So those of you who have studied your MEP or not studied the MEP, it's a pretty good question. Law questions, you either know it or you don't. Okay. Any answers, guys? Or educated guess? So a dog called Wilson has been prescribed Zomorph 10 milligram capsules for his broken leg or foot. I can't see what's there. What is the good practice maximum recommended supply for him that a veterinary surgeon can prescribe him? So, guys, any more answers? Law-based questions are going to pop up in your GPHC exam, and it's one of them ones you either know it or you don't. In my humble opinion, law questions are very, very easy. They are easy 5 to 10 markers in your exam. They could potentially be the difference of you passing and not passing. Okay. The actual answer for this is D. Okay. According to the MEP guidance, MEP, which is the law-based aspect of your exam, for animals, so this dog is obviously an animal. For animals, a veterinary surgeon, good practice recommended supply is 28 days. Okay, so if the dog was taking it OD, it'd be 28 capsules. If the dog was taking it 10 milligram BD twice a day, it would be 56 capsules. The difference between animals and humans, you're probably wondering, humans have a 30-day maximum recommended good practice supply. Obviously, for animals and humans, doctors, prescribers, GPs, they can prescribe extra or more tablets or capsules in controlled drugs, providing that there is a good justification. For example, if this dog had epilepsy, then according to the MEP, the vet can prescribe almost anything. Okay, so that's why if it was epilepsy, the answer would be no maximum supply. Okay, that's why it's so important to, I keep using these words, master your content. Okay, it's very, very important that you can master your content because, like this question, you either know it or you don't. Okay, we're going to move on to, I think, question 4. Yep, Question 4, another classic pediatric OTC condition. I'm going to give you guys about 30 to 35 seconds. First question is, can you all tell me what this is? In the comment section, what is this condition? Yep, it's impetigo. What are the answers, guys? What is the answer? A, B, C, D, or E? Would you refer to the GP for Cristicide? Would you sell Cristicide? Would you do nothing? Would you refer the patient child to the A&E? Or would you refer to the GP for oral antibiotics? This is a GPHC question number 75 in a GPHC exam. And this is basically how it is. Okay, you either know your content or you don't. Okay, you'd refer to the GP for Cristicide. Okay. One thing is Cristicide, okay, is actually you can sell it over the counter. Okay. Cristicide 1% is, I believe the generic is hydrogen peroxide. Okay. And the guidance actually changed, I think 18 months ago, 2 years ago. So if it was for a normal case of impetigo, I would sell Cristicide to the child or anybody, no problem. But this case, this photo looks a little bit severe. It looks as if that, if you can see by the chin, it's oozing, it's blistering, it's a bit on the nose as well, it's weeping. So these are classic infections, right? And I don't think the Cristicide would help. The patient would need to be referred to the GP for oral antibiotics. Okay, skin infections, the doctor would prescribe this child flucloxacillin. Just know that anything skin would be flucloxacillin. Okay, and anything like a photo like this, the way that I describe this as widespread impetigo. Okay, where it's on the nose, it's on the mouth, it's on a bit of the face, it's on the chin, it's oozing, it's weeping, it's wet. Okay, these are classic symptoms of widespread impetigo. Okay, let's have a look. Hey, last question number 5. Mr. Patel. This is a very, very good question for your learning. I'll give you all 30 seconds. Very, very important question for your knowledge. Again, you either know it or you don't. There it is. It's very important when you read the question, you pick what you think is the most important information. So I think reading that, the most important piece of information that I've got is his EGFR is 27 mil per minute over 1.73 meters, which is the most suitable diuretic that doctors should prescribe. Yeah. Furosemide, bumetanide, benzo, metolazone, eplerenone. Any more answers, guys? Let's see. Bumetanide. I'm gonna say, unfortunately, it's not bumetanide. Come on, guys, I'll let you all out of your misery. Okay? The actual answer is C. I can't pronounce this, but it's metolazone. Okay? Because any metolazone is the only diuretic that can be used in the EJ if the EGFR is less than 30. And this Mr. Patel's EGFR is 27. Okay? It's rarely given in community pharmacy. It's actually a special order. I do see it occasionally. But yeah, you either know it is very important, very, very important question. So these are the sort of questions that can pop up in your GPHC exam. If you've got 5 out of 5, amazing. If you've got 4 out of 5, amazing. If you've got less than that, you need a bit of work in terms of it's good that you've attended this session because now you know that you can take back and work really, really hard, and now you know how we can help you. Okay. Does anybody have, I think we've got like 5 minutes or so. Does anybody have any questions or concerns or anything to do with your clinical exam or calcs exam, or even how we can help you? Any questions or anything, guys? I think we've got 5 minutes or so before you go off on your lunch. I know you're all a bit hungry. I hope you've all had your Weetabix this morning.
Hi, Fayaz. Thank you so much for delivering that wonderful session. While I'm waiting for everyone to submit their questions, and of course, any members of the exec can do that as well. But guys, use the chat function and the Q&A, and raise your hand up if you want to, for one of us to disable your mic and enable your microphone as well.
Yeah, if they want to speak like this, then it's fine as well. I'm all right.
Absolutely. I do have a question for you, Faya. So that was a wonderful session and a really nice session, especially with the OTC. I think a lot of us may feel similarly in the sense that when you work in a specific setting, especially in your training year, and you tend to sort of have clinical knowledge more revolving around what that setting requires from you, but sometimes that can mean that certain knowledge of OTCs could go missed if you work in a hospital setting, and vice versa. If you work in a community setting, some more in-depth clinical knowledge can go missed because you're more dealing with patients face-to-face, dealing with minor ailments. So my question to you is, how best can someone from a specific pharmacy setting then accommodate their knowledge that they think might have gaps still because of their environment, if that makes sense?
Yeah, no, I fully understand what you've asked there. So I actually speak to trainees every day. Almost there doesn't go a day where I don't speak to trainees on the phone. Many of them work in community, many of them work in hospitals, some work in PCNs. So obviously they all have the same concern where if you're in hospital, you think that your OTC knowledge is really poor. If you're in community, you feel as if your in-depth clinical knowledge is poor. And I think the only answer to that is by working hard and starting early. And I've been trying to think of that starting early will not put you at a disadvantage. And what do I mean by that? Is that to get what you want, you have to do something that you've never done. Do you get what I mean? So it's important that if you it's mature for students and trainees to think that wow, that their clinical knowledge is weak, so they take action on that and they do the clinical knowledge. Or if your calcs is weak, they're mature enough to understand that, right, I need to do 5 to 10 questions a day. If your OTC knowledge is poor, I think it's all about maximizing time, man. You know, it's we all have 24 hours in the day. We all live the same 24 hours in the day. I go to the gym at 5 o'clock in the morning, and I could go to the gym at nighttime, but it's about how much do you want it? Do you get what I mean? It's all about, so if you all have like 1 hour lunch, you can actually maximize your time by having your sandwich or your hot meal for 10-15 minutes, quickly go on TikTok, Instagram, Twitter for 2-3 minutes, and then you've got a good 30 to 35 minutes where you can cover a low rated chapter. You can go home. If your work is 45 minutes away from your house, you can stick a Cassie Academy law session. You can increase the speed to 1.5. So by the time you've gone from your hospital to your work to your home, you've covered the law chapter in 35 minutes. So I think it's all about maximizing your time, recognizing your weaknesses, not forgetting what your strengths are, but acknowledging the fact that don't be worried, don't be scared in asking for help. Many trainees, they who I always speak to, they kind of feel a bit embarrassed for asking help. But I think as a trainee, it's important to not worry about that, because there are people out there trying to help you and support you. What you want is also what I want. What I want is also what you want. So it's just a lot of students kind of feel overwhelmed, and it's important to not feel overwhelmed.
Thank you, Fayez. Yeah, I agree with you. I think a lot of it is initial stages is just getting started, and I think people are quite intimidated knowing that all the contents, that you have to sort of understand off by heart, and I think the memorization. So I mean, you've been that position many times, and I'm in that position myself. So absolutely. But yeah, thank you for sharing that, and really your words of wisdom. I'm sure that's something all of us need to hear at any point of our training, at any point of our pharmacy journey.
I think one thing that I've not mentioned is that around Easter time, there's gonna be a lot of anxiety in your cohort. Okay, there'll be people that will say, "Do this, do this, do that, do that," and I will also say that around that time, now till then, there's going to be a lot of information that's not in the latest guidance. Like, there's always stuff that people forward and stuff, and people think, oh, if you study this, it's going to pop up in the exam. Like, it's important to kind of curb that, and that's why I think that's one of the main reasons why trainees participate in pre-reg company, because they know that they're getting everything in the tin. And I think it's the anxiety that I think I had that anxiety. That's why I failed. Do you know what I mean? Everybody was sharing everything on the WhatsApp groups, and you're on like 10 different WhatsApp groups. Somebody says do this, somebody says do that. It can get really mentally draining. Are you going to study, or are you going to focus on what your best mate is telling you? And I'll be honest, it's very, very important to uh kind of get that away from your head, and it's just important to do your own work and sit down and get stuck in and put the hours in. I think somebody just asked a question, advice for third and fourth year M-Pharm students and what they can be doing. Third and fourth year students, I think it's just important to, I think if your exams are coming up in May, it's just to start your work from today, right? Start revising now. A lot of people will say, "Oh no, revising now is too early. Your exams in June." Or it's not early. It's never too early. It's never too early, because you're all working 9 hours a day. It's taking you 45 minutes to get to work. It's taking you 45 minutes to get back from work. So that's 11 hours in the day. You're sleeping for 9 hours. So it's important to maximize your time. It's important to start early. It's pharmacy is I don't think anyone has told you this, but pharmacy is a profession where you're actually changing people's lives on a daily basis. And if you work incredibly hard, you can all become a pharmacist and achieve your dream. I've done that. It's taken me 7 years, guys. 7 years of hardship, 7 years of blood, sweat, and tears, 7 years of darkness, 7 years of crying profusely. And I was never diagnosed as depression, but if I ever went to go see a doctor, I think I'm the classic diagnosis for depression, you know. So it's important to recognize what your mental health is as well. You know, a lot of trainees get really overwhelmed, get scared. They got family pressure, they got peer pressure, they got internal politics pressure. So it's important to understand that your short-term goal is to pass your registration exam, and you will do absolutely anything to work hard, i.e., you are not going to go out with your friend, you're not going to go out with your family. Like the amount of family gatherings that I sacrificed, Blackpool trips, Flamingo Land trips, Alton Tower trips. My exam was in July, guys, similar to you guys, where the weather's going to be really beautiful. You want the ice cream, but you can't even spend 10 minutes to go get an ice cream. That's how much dedication, tenacity, sacrifice, discipline you have to have, because once you become a pharmacist, that's it. Your life changes. Your life ultimately changes for the better for yourself, your family, your kids, your mom, your dad, your whoever that you are with. It really, really does change your life. And that's why I'm here today speaking to you guys. I'm actually in London. I came all the way from Yorkshire, Leeds, and I'm actually in London. Because I booked a hotel, and you can't not be in the hotel. So, you know, I'm here for you guys. You know, and that's why I really enjoy speaking to trainee pharmacists. On Monday, I'm actually going to Huddersfield University. They've got a pharmacy careers fair there, and the doctor there, Professor, I don't even know their name, but a professor there has invited me to do a talk with third and fourth year MPharm students. So this is where we're going. You know, our trajectory is strong because our work is solid. Our work is 10 out of 10. I would not be talking to you guys here this morning. I would not be here on a 1 hour call if I didn't feel that I can help change your life. And it's all about taking action. And if you are ready to commit and working hard, we give you everything. We give you a revision timetable. We give you a religious plan what to do. And then all you need to do is put in the hours on our online platform. I can see what you guys are doing. I can see that Salita has only spent 10 minutes on the CNS teacher session when she should have done 1 hour 40 minutes. I can see that Kieran has only done it for 2 minutes. And then if I see things happening persistently, I will then drop them a message to say, look guys, what's going on? We need to spend way more hours, way more minutes. How can I help you? So it's important to choose a company out there that's not only got impeccable content, but are there just to hold your hand and give you that pastoral emotional care, which I never did. And that's why I've created Cassie Academy for you guys, really. Is that okay, guys? I think I've gone a bit over, haven't I? Yeah, I've got 5 minutes over now.
Sorry, Bias. Thank you again so much. I think we all really appreciate having you here, and obviously the time and effort you have put to, you know, put all the contents together and be here with us today as well. I really hope you equally enjoy the session yourself.
Thank
And
you.
enjoy your time in London as well. Are you going to be staying there for is it just the day or the week?
I came yesterday and I went to like Covent Garden, Leicester Square, and all that stuff. But now I think in about half an hour, I'm gonna make my way to Camden Market and get some Argentinian steak and eggs. So yeah.
We all wish we were you, but yes, absolutely. Have a wonderful rest of your day. Thank you again for joining
It's
us.
been an absolute pleasure, guys, and thank you very much for listening to me. I'm a little newbie here, but I really appreciate the work that you guys are doing, and I pray and I hope that BPSA keep getting stronger, keep getting better, because it's important, right? You know, it's important to keep on the trajectory, and I hope that we can continue to keep working hard for the betterment of not only trainee pharmacists but MPharm students and the future of pharmacy.
Perfect. Thank you, Fayez.
See you later.
Bye. As well, guys, on that note, it is now our lunch break, so feel free to go and take your lunch, and please feel free to come back. I think it's just 10 minutes before 2, so come back then and we'll go into our next session, which is the panel discussion, so that should be quite exciting. So yes, just a reminder again, guys, come back at around maybe 13:50, or yeah, just 10 minutes before 2. I'll pop that in the group chat as well. If you'd like, you can always stay on the call and obviously have your, you know, video and mic off, and feel free to just go get your lunch. Hopefully that should be enough time. And if you still want to have your lunch with us, feel free. When you join back, there is literally no restrictions. You may do as you please. But you know, just feel free to, yeah, take your break now. And we're gonna come in next for our panel discussion. So that should be quite exciting. But we'll see you guys then, okay?
So I guess I'd like to start just by asking you if you could share a little bit about your pharmacy background, a little bit about your career journey, and how you became an independent prescriber. So Asra, do you want to start us off?
Yeah. So I've been qualified for now 10 years, but going all the way back, I started off, did my MPharm degree at UCL School of Pharmacy, and then did my foundation year, pre-reg year at Bart's Hospital. And it really gave me an experience to rotate through various different specialties and develop my expertise and experience. And it was the perfect year to put all that learning from university into practice. It was a very steep learning curve, but absolutely, I think that was my favorite years to my career to date. But nevertheless, I decided to stay on after completing my foundation year at Bart's Hospital and did my first rotation in acute medicine, and also was put on the 24/7 rota. So it was a very stressful time, being put in the acute medicines ward where you have everything and anything, and also having commitment over 5 hospitals, doing night shifts, late shift. But nevertheless, that experience did put me in the deep end, but I think it was a very valuable experience, and it did help me thrive in my career, having to do something quite complex quite early in my career. I also had the opportunity to enroll onto a diploma course, because at the time you had to do a diploma course before you could do prescribing. So that was a 3 years diploma course with UCL School of Pharmacy, and it had 2 parts. The first part looked at clinical conditions, and the second part involved completing a clinical audit, a therapeutic review, and also thinking about service improvement. So I continued to develop my skill of clinical expertise through clinical rotations as a band 6, and I moved over to St George's Hospital in Southwest London as a band 7 pharmacist, and also had an opportunity to do more specialist rotations. So I got a chance to do cardiothoracic and oncology and hematology. I think for me, I always knew that cardiology was something that I was very much interested in, and it was something that was my passion. So I always was drawn to cardiology medication. So I was glad I was in that opportunity to do that. But just to fast forward to where I am now, so I decided to take on a lead anticoag pharmacist straight after my band 7 rotation, and that's when I did my prescribing course in anticoagulation. And then I moved over to primary care because I thought I was an anticoagulation lead pharmacist, but my scope of practice was very narrow. So I had the DOACs, had the warfarin, but I think it was too young for me to become a specialist. So I also want to see what was out there, and there was so much new opportunities coming out from primary care, and especially with the pharmacy care education, pharmacy pathways in primary care. So I decided to transition over and come to primary care, and I was working as a senior clinical pharmacist in Haringey GP Federation. So it was a 2-part role. One part included being patient facing. So I was able to utilize my prescribing course more so in primary care, but also had an opportunity to take on more leadership roles and responsibilities. So helping support clinical pharmacists embed in general practice, work on the work streams, support education training, service improvement. And yeah, so I was during that time, I also decided to do a Darcy Fellowship. So I looked into, I did a course with London South Bank University, looking at leadership in health course. And after that, education training has always been an interest of mine. So I stayed on at the North Central London Training Hub, working as the education lead. And that came into an end in January, and I started my new role with the RPS earlier this year. So going back to my prescribing journey, I always wanted to be a prescriber, but at the time you had to wait until you completed your diploma. So you had to do your 3 years. But in hindsight, I think it was a good decision because I was able to consolidate my learning. And also when I became a prescriber, I was able to utilize that. So whilst I was doing my Band 7 rotation at St. George's Hospital, there was opportunities to do prescribing, and you put an expression of interest in, hoping you'll get selected, and you had to find at that time it was designated medical practitioners. So it was doctors that could be your prescribing practitioner. So I got a chance to find a consultant who was happy for me to be my DMP. I also decided that I wanted to do something cardiothoracic, looking at clinics, sort of like pre-admissions clinics. And I thought, yeah, that would be great scope. So I got really excited, put my expression of interest in, sent it in, and unfortunately it wasn't my time. There were more senior pharmacists that, because the funding at that time, it wasn't open to all. You had to apply. So nevertheless, it was a bit disheartening, but nevertheless, patience, everything lines up eventually. So a year later, I got the opportunity to become the 8A lead anticoagulation pharmacist. And at that time, it was even more perfect opportunities because the expectation of my role was to do outpatient clinics in anticoagulation. And I was part of a multidisciplinary team. I was working closely with consultants, nurses, and advanced practitioners. So I had that support when I was doing my prescribing course. So I got a chance to do that. And I'll talk a little bit later on about my prescribing journey. But yeah, so that was just a bit of snapshot of my early career, well, my career to date, and how I did my prescribing course. I'll pass it over to Jen.
Hi there. So I've moved somewhere else in my house to see if I can get a better signal. So hopefully it's not quite as clunky as it was. Last century, which seems like a very long time ago now. So I've been qualified since 1999, so probably before some of you were born. I did my training as it was then in Colchester in Essex, after having done my degree in Strathclyde, mainly because I lived, which is nice. It was also really nice because NHS England and the NHS in Scotland are quite different. So it was good to see different systems and how they work. After that year, I went back to Scotland for about 15 months, and I actually did community locums for that time, just because I know where I was going to say in what I was doing. And while I enjoyed it, I knew community wasn't for me. And when my now husband and I moved back down to England in the year 2000, I went to Southampton. We were going to be there for about 5 years, then moved back to Scotland, we thought, and it's now 2024, and I'm still in Southampton. So I initially went in as a C grade rotational. So C grade is sort of a senior 6, junior 7 grades. And during that time, I did rotations in orthopedics, general surgeon, medicine, oncology, and hematology. During that time, I did my diploma, and then I got a role in critical care, originally in the emergency department and with the critical care outreach team. Over the years, with life changes and years, I'm in work now within critical. I love critical care. Tell you, I've got really short attention span, and I really enjoy the variety of things I see within critical care. And it's not something that's everybody. Other people, I enjoy that variety and the challenge of seeing different things. And I also like that always sort of answer to every situation. During critical care, I helped do some research in the emergency department, where I wrote some of the first prescriptions in the hospital before I prepared drug charts for doctors to sign to see if it would improve efficiencies within the emergency department. I've been on various ward rounds and sort of did similar things on ward round. I didn't actually become a prescriber quite a lot later into my career, just because I was doing a master's project. I recommend you don't do a master's while you're on maternity leave, because it's really hard work to get a hold of bits of paper, but it is doable. Don't recommend it. But when my children were all a little bit grown up, I decided I'd do my prescribing course. I did my prescribing course in 2015, and I prescribe every day in my role now. And with our team, pharmacists, prescribers, the prescribing, the consultants are contacting us. Where are you? We need your help. So I will hand.
Oh no, I think we might have lost Jen there. I know Jen's having a couple of technical issues today, so hopefully we can get those resolved. But in the meantime, so yeah, if anybody didn't catch that, so Jen and I actually work together. So Jen is our Band 7 manager. She's been down in Southampton for just over 20 years. She specialises in critical care. And I mean, I might be biased, but she is a genuinely amazing pharmacist to work with, and is the font of all knowledge with all things critical care related. So hopefully we'll be able to get all the tech sorted out and you'll be able to hear from her. No lagging, fingers crossed. But Emma, did you want to raise the next question?
Yeah, do you want to wait for Jen, or she will make a start then?
Azra, if you're happy to start the next question, hopefully by the time you've answered Jen, we'll be back with us.
Yeah, you can repeat the question for Jen when she returns. Yeah.
Yeah, no, that's fine. So the next question is, in what ways has independent prescribing influenced your personal career and patient interactions within your practice?
Okay, so just rewinding back, so going back to when I completed the prescribing course. So at the time when I was applying, the HE had a pot of money looking at supporting hospital pharmacists complete prescribing. So the prescribing course that I completed was the clinically enhanced pharmacist independent prescribing course. So it was a 9-month course, and it had a little bit more credit than your usual just independent prescribing qualification. And what it essentially offered is that you had the standard independent prescribing course, but in addition, you also had additional credits associated with clinical assessments. So it was, you had the clinical health and diagnostics as part of that prescribing course. And that was very unique in the sense that we had the opportunity to learn about and practice using different common diagnostics aids. So we got an opportunity to learn about basic observation, resuscitation and sepsis, respiratory, ENT, MSK, neurological, dermatology, and mental health. And we had to log hours of us utilizing that and practicing some of that. So we had the 90 hours prescribing plus 20 hours of doing clinical assessment skills. And that was very unique in the sense that we had an opportunity to practice this. But given that I was in anticoagulation, I had to seek out opportunities to learn and practice some of these clinical assessment skills, because I wasn't going to do an otoscope examination in an anticoagulation clinic. But one of the fortunate thing about working at a large trust was that there was lots of opportunities. So some of the opportunities you had to really go and look for them and really go knocking on doors and see what other opportunities. So I reached out to ambulatory care, admissions, specialist clinics to go and have and observe multi-professionals too. So it wasn't just, you know, sitting with doctors and pharmacists. It was like, what can I learn from an advanced practitioner nurse or other advanced clinical practitioners? What can I learn from community and consultants? Because everybody brings their own unique input when it comes to prescribing, and you learned so much. So as part of the university, so I went and did it at Medway University, and there were about 5-6 of us in our cohort, which was really lovely, because that we formed a sort of pair network, a bit of study group, so we would learn something and come back and consolidate that learning. And if we wanted to practice for our OSCEs, we could practice on each other, doing respiratory examination, doing neurological examinations and practice. So that I think that really was a useful experience as well. So after completing the course, I registered with GPHC and was ready to prescribe. So I always remember your first time you're prescribing. So it is nerve-wracking, and it was, edoxaban, and it was in my clinic setting. And I, made sure that I had a little performer, made sure that, I checked everything that I needed to check, and was able to prescribe safely. And then I remember my next couple as well. So all of it was an anticoagulation, and it was a clear scope of practice, which was great. But the clinical assessment skills, even though I had learnt about them, I didn't utilize them at that time. But nevertheless, those experiences definitely came in handy for my next role when I joined primary care, because it was so relevant when it comes to clinical assessment. And one thing you do learn is about there's a lot of focus around proactive, personalized care, shared decision making, moving away from the paternalistic model that we have within healthcare of doctor knows best, and actually thinking about more about the patient, making sure that decisions are patient-centered, thinking about what matters to the patients rather than what matters to you. So that was something that I really got a chance to practice when I joined primary care as part of your consultation skills. So even though I was anti-coag, I then had to, coming as a generalist in primary care, you won't just prescribe in a certain area. You will have to expand your scope of practice, because you won't just have anti-coag medication. That person will be on a range of other medications. So how do you then look at that person holistically and help optimize other areas? So it was like thinking about how can I safely expand my scope of practice. So I definitely felt more confident in cardiology medication. So I was like, okay, let me start with hypertension, optimizing medication therapy, and then you brought in your statins and your secondary prevention medications, and then gradually as you develop your portfolio, you expand your personal formulary, then you do become more of a generalist. And so that was definitely a learning experience and a steep learning curve coming into primary care. But nevertheless, all those experiences that you experience as you move through your career may not be used at that time, but you will utilize it much more later down the line. So yeah, so I will stop there and pass over to Jen. But you might want to repeat the question for Jen.
Yeah, thank you very much, Azra. That's very thorough and well explained. So thank you for giving us an insight into that. So Jen, I will repeat the question. It's good to have you back. Hopefully the location will be good. So the question Azra just answered was, in what ways has independent prescribing influenced your career personally and interactions with patients?
What I'll do is I'll turn off my camera in case that increases my bandwidth. I have gone round to turning off various electrical devices in the house as well to see if that helps. There's only me here, so it's very unusual to have low bandwidth, and there's only me here. So as I mainly prescribe within critical care, I was a critical care pharmacist and had been for a long time when I started doing prescribing. But my main focus was on parental nutrition, because that was a service pharmacist intensive care, but with support therapies around your and electrolytes and vitamins to ensure patients were taking care that they needed at that time. The other thing that we do a lot of our work on within our critical care group is looking at therapeutic drug management. So we tend to manage our vancomycin infusions, we tend to manage our gentamicin dosing and that, and also so lots of things that we used to just go ahead and do that and take over that management of the patient. And it's basically expected within our intensive care units that our pharmacists would do that. So from my point of view, being a prescriber facilitated that me doing that really well. None of the drugs that I use in my scope of practice are particularly exciting, but I'm not there to make the decisions necessarily to say it needs this particular vasopressor, this particular inotrope, this particular sedative. I'm there to optimize the therapy. It's quite a different place to prescribe in intensive care to say other people's experience where you actually want to do, because quite often my patient is unconscious or sedated and not in a position to make necessarily decisions about their healthcare, so you have to work in their best interests. But I always consider an advocate for the patients and think, if that was me, or if that was how I'd want their drug therapy to be managed, is that, am I doing the right thing for this patient? And I think you have to sometimes be able to sort of justify, with the information that I've got available, this is the right thing to do at this time. And I think it is something to consider as a prescriber, that there are patient variabilities. If I'm prescribing nutrition and I know somebody choices, if I know if they have dietary choices along that line. So I do try to get as much information as I can. It's not always as easy as saying to the patient, tell me about your life, tell me about what you like to eat, what you don't like to eat. Because if we can make their PN, make their PN vegan, and it's like, no, sorry. But we can give people the information, and if it's something that they choose, that if they're awake and they can make that decision, that's fine. If they're not awake and I have to do the best interest, it's quite difficult sometimes to be able to justify that. But I am lucky that within Southampton, not only do we have our critical care pharmacy team, because we've got a big department, there's 7 or 8 of us in most days, and we can discuss things between us, but we also have a nutritional support team who we could then go say, right, I've got this tricky case, I don't know what to do, and you can have that sort of discussion between different professionals about what the right thing to do is. Themselves, and we have to try to work in their best interests. So a lot of the things I do, being a prescriber facilitates things and makes things more efficient. And we've done some work that shows that when they're prescribing, it improves the time for prescribing decisions to be actioned by about 4 to 5 hours on average, because by the time the ward finishes, your doctor catches up on all the tasks that they were going to do. The prescribing often is the task that falls behind, because they've got to order scans or review chest x-rays or talk to another doctor. So it makes things much more efficient if we can actually be there doing the prescribing, and it also means that appropriate doses are prescribed at the start, rather than us coming along the next day and say, actually, that's the wrong dose for that patient, can we fix it, please? So hopefully you heard all that.
And yeah, just to add, I think for me, leadership has also been really important, especially clinical leadership. As pharmacists, typically, especially in primary care, a lot of the leadership roles are taken up are mainly GPs. And I think there's a real room for pharmacists and other allied health professionals to lead clinical leadership as sort of a multi-professional leadership. And I think prescribing certainly helps along that process, because you're able to look at a service. When we're in practice, we always see things that we can do differently or better. So coming from a QI perspective and actually having prescribing under your belt, you're like, actually, there might be an opportunity for a pharmacist to be more involved in a certain element, or actually, what about a pharmacy-led clinic, or working more closely with the rest of the multidisciplinary team to really provide better care for your patients. And I think I've worked on a couple of projects. So one of them was setting up an anticoagulation service within primary care, and utilizing all that knowledge as a prescriber in secondary care. I was able to bring that to primary care and support nurses and pharmacists upskill within anticoagulation, but also develop their confidence when it comes to prescribing within anticoagulation, especially the DOACs. At that time, they were still classified as NOAC. There was real hesitation, especially within primary care, to initiate. And then we've seen such a huge difference and such a huge improvement in the uptake of DOACs, and actually giving patients more choice. So that was another example. Another example was during COVID, we knew that there's a lot of, when it comes to access to patients, a lot of people weren't going to the GP surgeries, but at the same time, we knew that some of these long-term conditions, they needed to be optimized and managed. So at the time, NHS England had, as part of the NHS at Home initiative, they had created blood pressure at home service, where they were encouraging blood pressure monitors to be issued to patients so they could go home and check their blood pressure. And so avoiding the need to go to general practice. So again, using QI, using your prescribing pharmacist and the wider MDT, we were able to supply the blood pressure monitor devices, get remote readings, and then our prescribing pharmacists optimize the medication. And that was just a new way of working. And they worked closely with GPs and healthcare assessment, HCAs and nurses to really provide a targeted approach. And I think that's a really great example of how a pharmacist can fit within a multidisciplinary team and think of innovative new ways of working to really improve the care of our patients. And I think that, you know, the idea of having more prescribers will only benefit the patient, especially when we're thinking about service design and pathways, and thinking about how we can provide better care for our patients.
Thanks, Azra. It's actually really interesting listening to you both, but actually seeing that despite working in different sectors, there's still a lot of themes that overlap, you know, upskilling and team working, optimization of care, and actually creating patient access routes, which I think for us moving into prescribing and looking at doing our prescribing course means a lot, knowing that wherever we go, it's going to be entirely relevant to our roles. But what I'd quite like to know now is on your career path in general, but particularly when you were working on your independent prescribing, what were some of the challenges that you faced and how you overcame them?
I think challenges, just rewinding back, I think, you know, look, the 90 hours. Sometimes when you're working in a hospital setting or whichever setting, you always that's pressure to do your day-to-day job and also having to do your commitments with university study. So balancing that work-life balance of going back to uni, work on your portfolio entries, and also doing your, you know, your day-to-day job. So I think the first bit was really advocating for having protected learning time at your workplace so you can get your 90 hours of practice. It was a challenge at times, but also you had to negotiate and try to make it work. So I think that can be challenging at times, having time to go and spend time with a pain clinic or something else, otherwise so that you have like sort of a wide breadth of experience. And also unfortunately when it comes to assignments, everything else, that the preparation, the learning has to come at your own time. So when you're doing your assignments, so it's just about, you know, deadlines, going back to uni again essentially, and, you know, working along, completing your assignments and everything else that goes with it, and the OSCEs and everything else around university can sometimes be challenging, but nevertheless it was an enjoyable experience. But I wouldn't do it again, but nevertheless all of it was going back to uni certainly was and you know, a useful experience. I think I mentioned it before, you know, finding a DPPE, finding your scope of practice. I think at that time there weren't that many roles of pharmacists within hospital. You had, you know, the HIV specialist pharmacist and anticoagulation and pre-admissions, but aside from that, it was about scoping out what was possible. So I remember when I was in oncology and I was doing a service improvement project, it was about, okay, what can we do within oncology? So it's about scoping out what's going on in other hospitals that are using prescribing pharmacists within that realm. And I remember thinking, actually, there might be scope to do outpatient breast clinics, medications and prescribing around that. So that was an idea as well. So it was just thinking about the service, because it's great to have the prescribing qualification, but it's even more important to use that qualification and do right for the patient and optimize it, because there are many pharmacists that unfortunately don't use a prescribing qualification, but with time goes by there'll be a lot more opportunity, especially with the whole redesign of clinical services, thinking about pharmacists and utilizing them to the top of their clinical competence. So if they're prescribers, utilizing their skill sets as part of that. So it can be frustrating at times, trying to find a DPPE, trying to find the scope of practice. But I'd say everything will come at the right time. But at the same time, look for opportunities and scope out and speak to people, speak to prescribers, see if there's any opportunities. Also find out what you actually want to do as well, and think about actually what's your scope, what's your passion, where can you look for opportunities, but also having mentors and coaches as well. So thinking about how you can help overcome some of the challenges. Yeah, over to you, Jen.
Yeah, I would say it's really important to be doing something that you're interested in and you enjoy while you're doing the course, because you have to do a lot of work around those things. So if it's something you're not interested in, that makes doing that bit of work much harder. I did my prescribing course was the weekend course that no longer runs at Reading, which was just for pharmacists, so it was quite a shortened course. So it was over 6 weekends, over 6 months, which was suited me because of my 3 days a week at the time. I was then doing 2 days at the weekend, and I could take some time back, or I could get paid for some of that time. And it's like, well, how do I fit in the 90 hours when I'm only working 3 days a week, and then actually I'm taking some time back for my weekend course that I've just been on? So that's particularly challenging. So if you have got other commitments that aren't as flexible, it can. The other thing I really don't recommend doing is having surgery the day before you start your prescribing course. And I started my prescribing course with my arm in a sling because I had my carpal tunnel released on the Friday and started the prescribing course on the Saturday. So I turned up for my first weekend with my hand in a sling and a big bandage, which made it interesting, but fortunately it was my living and things like that. But yeah, so my main challenge was getting my 90 hours in along with my working week. Doing my work at home was doable, but it involved quite a lot of planning, and I was really lucky in that I planned, because I knew I was going on my course. I knew I'd have to write a case study, so I actually found the patient before I went off had the surgery because I wasn't going to be in work. So it meant I actually had time to do some writing. So I did some chunks of my work for my prescribing course during my sick leave, which I didn't do them later because I'd done some of that coursework during that time. And I had, my daughter was at nursery for 3 days a week, so I could get a lot of that paperwork done. The other thing to do is when you come to do it is when you get the list of competencies, there's so many things on that list of competencies that you have to be able to show that you can do. A bit like when you start your evidence for, it's a similar sort of process. That can be really overwhelming to sort of sit with that list and sort of think, how on earth am I going to prove that I can do all these things? I'm currently doing through that again because I'm now going through a DPP for a dietitian, so I'm having to sort of having that bit of existential crisis again, looking at how can I prove that I can do all these things for this portfolio. So it can be challenging, but actually sitting down, being completely honest and saying, actually, or whatever it is, because this is a multidisciplinary competency framework, and as a pharmacist, you can already do some of these, but the things I needed to focus on was patient assessment and things along those lines, making sure I was up to date with some of the legal things, because obviously it's been quite a long time since I've done my degree and some changed over time. So I'm doing my getting the things that I needed to do, so spending time with people and how they had conversations with patients. I went with the intensive care registrar with them down to the emergency department when they went to review patients to see how patients. I spent a day with the critical care outreach team again because they go around and review patients on wards, and how do they get all that information in order to make the decisions for how you're going to care for this person next. So it's sort of trying to, yes, you've got to do all these hours, but there's things you have those hours in ways that you can get that knowledge, get that learning, but also get the evidence for the competencies that you need for your portfolio. So sort of making that time work well for you when you're there. I didn't have to spend as much time with my DMP as a lot of the courses now specify. So a lot of the courses now specify you have to spend a certain chunk of those 90 hours in direct supervision with your DMP, DPP, which you didn't have when I did my course. But a lot of the time I was able to spend time with other ITU consultants, not necessarily the one who was actually my DMP. Whereas now it's a little bit more tricky because you've got to maybe try and coordinate that relationship and spend enough time with the person. So if you are part-time and the person you want to be your supervisor works on different days of the week to you, that's not going to work. So you have to sort of plan these as well, making sure that the person who you're going to be working with from that super difficult for you to get all the hours you require if that person's going to be away for 6 weeks holiday at some point during your 6 months. You're not going to get all that contact time you need. So while takes a little bit of organisation. We're all now adult learners, and hopefully it is a challenge and it is a skill to be learned. So, but hopefully you have people in your department or wherever you're working who can help you with that sort of organisation and that planning, and to you sort of say, I'm really struggling, I need to get some evidence in this area, who should I talk to? They might be able to either direct you to the right person or help you or time or those sort of experiences that you need. And we're really lucky. I think most people in pharmacy are really keen to help others develop. And well, that's certainly been my experience. You go and ask people for help, they're more than willing to help you. We are generally a very caring profession. So I think actually going to say to somebody, look, I need your help, this is what I need to do. Have you got any suggestions? Most people will be delighted to help you. So hopefully you can find the way around those problems. But that was my main problem, was logistics.
Yeah.
Trying to fit all this stuff in a 6 month. Like I say, I have one of the at the time. So while the other two were at school, that was fine, but I still had a 3-year-old running about. So it does put a challenge on your time, but with a bit of organisation, it's doable. And if you can do it part-time, anyone can do it. So.
And I think I just echo what Jen said around planning and organization. Like when Jen was talking about her experience, it is a lot of work, especially when we had to do weekly reflective diaries, portfolio entries, learning, but then going home and writing about it. So it did feel a bit like pre-read when you're collecting evidence and then writing about it, but don't leave it to last minute. Because I remember my DMP was going to go on holiday for 2 weeks around that time, and thank God I had planned everything in advance, because if I had left everything, I would have been in a very not in a great situation. So do plan in advance and have a look at the learning outcomes and look for potential ways that you can find examples of how you can match those learning objectives as well. And I think that's why having that peer network, having people that are on your same course, or having a WhatsApp group, you can ask people saying how, for suggestions, because they'll be like, oh, I did this for that one, I did that for, and then you're like, oh yeah, that might give me an idea. But also utilize your networks, utilize people that you work with, and think about that, because you're right, as adult learners, we absorb things, we learn things differently to how we were when we were younger. So just thinking about that. And also the prescribing course doesn't teach you how to prescribe in your area of prescriptives. You've got people that are from all different disciplines, all doing their own scope of practice. So the learning around your scope of practice will come from your experiences within your 90 hours shadowing and getting that exposure. And those skill sets that you learn from universities will make you an all-rounder when it comes to prescribing qualification. But even after prescribing qualification, pharmacy is a lifelong career of learning and development, and you'll have to continuously invest in yourself to continue to grow and develop as part of that. So yeah, I hope that was helpful.
Yes, immediately after I did my prescribing course, because I was in that sort of evidence producing point of view, I actually submitted my faculty submission to the RPS and did my faculty credentialing, because I was in that sort of, I'm in the scope of mind now, especially my faculty submission. Don't try to do it retrospectively, it's really hard to do it retrospectively. Do it as you go along, it's so much easier. So gathering the evidence from my prescribing to get that was so much easier, because I was doing it in real time, than then sitting going, okay, so 10 years ago, what did I do? So I can get the evidence to get its point from my faculty submission. Certainly now trying to work on consultant pharmacist portfolios, it's the same sort of thing. It's like, I need to write this down now, because if I don't write it down now and collect the evidence now, it's so much harder to.
Lovely. Thank you both for very insightful thoughts and insights into what you've been through, and very valuable tips and advice as well for us that will one day have to do the independent prescribing and the challenges that we might face. Sally, you've got your hand raised.
Yeah, I just wanted to chime in also with a question as well, because I think this could maybe be in relations to, you say that with the prescribing course, I think defining your scope as well comes with the experiences you have throughout the whether it's the 6 months or however long the course itself is. But essentially, my question is, I think there's a lot of sort of different people who's gone through the prescribing course say different things. So whether when you were doing the prescribing course, did you get to define the scope immediately, or was it just like a generalization of understanding how to do diagnostic assessments and then seeing all different kinds of patients, and then maybe towards the end you can define where you're most comfortable prescribing in, and it's more entirely up to you than it is defined by the course itself?
So in terms of at the time when I was doing my prescribing qualification, you had to, as part of your expression of interest, you had to talk about your scope of practice. So you had to have a defined area of practice, and they were very hot on having a narrow scope of practice. So having a decision, actually, I'm focusing on hypertension, I'm focusing on anticoagulation, or I'm focusing on a particular area. They wouldn't let you enroll sort of as a generalist. And even now, I don't think that's changed. I think you still have to choose a narrow scope of practice and complete your prescribing qualification within that. And as time has changed since then, I did it within anticoagulation and it was great, but in my day-to-day practice as a PCN pharmacist, as a generalist, you do require a different skill set, because you won't just have anticoagulation patients, you will have everything. So actually having a generalist sort of course would be better when it comes to prescribing, and is more fit for purpose. But I think they've gone with the decision of actually keeping it, actually thinking about scope of practice, gathering your 90 hours within that area and expanding it, and expanding your scope of practice as you go along. So yeah, so for us, we had to have that scope of practice, had that focus, because you were collecting evidences and your portfolio entries linked back to your scope of practice, and everything had to link back to your scope of practice. I don't know, Jen, if that was the same for yourself as well, around
Yeah,
having a narrow scope.
that was the same. That was the same for me. But my scope of practice might be a bit broader than necessarily yours was. So mine had parental nutrition and sort of adjuncts to parental nutrition, dose adjustments for organ failure, and a couple of other sort of fairly woolly type things on there. Just because of the nature of working on intensive care. So I had things to do with the care bundles that we use on intensive care. So it does vary from course to course what the requirements are. I know the GPHC requirements for when you do the 90 hours within from 2025, 2026 are still looking for a narrower scope of practice. Partly because from the assessment point of view, I think it's much easier for people to assess from a sort of reasonably narrow point of view, where you're focusing on something maybe like diabetes or post-MI or something like that. So reasonably, but just because you're using that scope of practice for the course doesn't mean that that's your scope of practice forever. You're there to learn the general principles of prescribing. And when you're qualified, you can prescribe anything within your competence. That's what basically the guidelines are. So if you can sort of say, this is what I'm competent to do, I've got the evidence to show that I'm competent, you can pretty much prescribe pretty much what you want legally. Ethically, you could argue, not so much, but legally, you could prescribe what you want. But I the correct dose. I'm happy doing what I'm comfortable that it's the correct thing to do. But for example, we had a pediatric patient on one of our adult intensive care units that they wanted nutrition for, and I said, I am not competent to prescribe nutrition for this patient because I don't know how to nutritionally assess a child, because that's not part of my scope of practice. I'm happy to advise on other things round about that, but this is not part of my scope of practice. And part of being a professional is saying, actually, no, I'm not competent to do that. And I'm sure Asha would say the same if they came along to you and said, oh, actually, I want to put on something else. You don't say, I'm not competent to do that. And that's a entirely reasonable thing for you to say, because you're not comfortable doing it. What I am working on at the moment, because I have within my rotational band 7 team, I have got 2 within my rotational band 7 team who are already prescribers. I have one person in course. So we were looking at having a sort of standard scope of practice for our rotational band 7 pharmacists, because obviously they're not working in a specialist area all the time because they are rotating around clinical specialities. But we're sort of looking at a sort of core group of items that we say we are confident that any pharmacist who's a prescriber can do these things. So make dose adjustments based on therapeutic drug monitoring, restart patients' medication from home like their hypermelos eye drops, dose type actions, and that will be part of their standard thing that they can do that anywhere in the hospital because they're sensible grown-ups, qualified, we trust them to make decisions. Then potentially in the rotation, so say if I maybe dealing with them again after a few months, I might say to them, right, I'm very happy that you understand the concept of stress ulcer prophylaxis or the need for these bundles. This is our guideline. I'm happy for you to prescribe in line with this guideline. So there've been assessments sort of down the line in the speciality of saying what else you can do. So when you go to cardiology, for example, and they've been assessed by the lead pharmacist for that area, they might be in the position that they say, actually, we're happy for you to sort of go ahead and prescribe things as appropriate for using ACS in conjunction with the team. So we're trying to sort of look at how we can look at having a sort of core group of expected things in, and we're hoping to get that up and running before we start to have newly qualified band 6 pharmacists that come through as prescribers. They'll have a bit more potentially narrower focus because of the lack of experience, and that we want to be there developing them and giving them this, well, you have got the knowledge and you have got the course, you've got the qualification, you might not have that experience and confidence to be able to do it safely and comfortably. Consultant can be challenging, and that potentially does come with time. And I certainly am much happier to say no to my consultants than say the on-call band 6 pharmacist might be. And that's just something to bear in mind. So we want to make sure we're not putting too much pressure on our newly qualified pharmacists when they start as prescribers to be expected to prescribe everything just because they can. Does that make sense?
That makes sense. Alexander mentioned the regulations are that we not identify a scope practice, but it does not need to necessarily align with previous experience. That is correct. So you don't necessarily need to have previous experience in that area. So when I did anticoagulation, I was new into that role. I was a new 8A, and I just started outpatient clinics, and I was doing my prescribing course at that same time. But I had an opportunity to practice it and work closely with the MDT team, and especially with the new prescribers that will be coming out in 2026. The lack of experience working in a clinical setting, they will develop their confidence and competence with experience, and they'll become a lot more confident. So again, as Jen mentioned, we don't want to be putting unnecessary undue stress on the newly qualified and expectation to prescribe and expand the scope of practice from day one. So giving them time and space to grow.
Lovely. Thank you both once again. I'll move on to the next question. I'm just a bit mindful of time. So the next question focuses on kind of your personal thoughts and insight into the independent prescribing model and the framework. And if you've got any suggestions or area for improvement.
I think it's really exciting in terms of we're going to with time the newly qualified pharmacists that will be coming out will have prescribing qualification, because that really gives pharmacy more time and space to think about how we want to deliver our clinical services. So moving and operating at the top of our clinical competence and prescribing will become essential to all of our roles, but that also means what do we do about our legacy staff as well, and also supporting yourselves who are just who are going through, who've just graduated. How do we support our existing staff to become prescribers and also have the access to the same opportunities and develop and grow at the same time? But you can see the development within pharmacy, especially when you've got the pharmacy first that was launched this week around getting community pharmacists to working more in a clinical developed, delivering consultation clinics, working within those same domains. Even though it's PGD, I think the future ambition is to commission more and more clinical services in all settings and thinking about utilizing prescribing pharmacists. So I think it is an exciting time to be a prescriber and a great time to be a pharmacist as well, because just so many opportunities. And I've seen it, over the last 10 years, prescribing was, maybe a few people that were doing it, but we're going to a stage where, majority of pharmacists will be prescribers. And just thinking about the future of pharmacy, I think it's a really exciting time and place to do. And also, it also unlocks career progression. So thinking about, as you think about your career trajectory, you might want to do your foundation pharmacist, you might think about advanced level practice, your prescribing course, thinking about your consultant framework, or you might really enjoy the diagnostic elements and you might want to go pursue a sort of advanced clinical pharmacist pathway route, and just utilizing your advanced skill sets when it comes to delivering patient quality care. But at the same time, you might want to do what I did in terms of thinking about leadership and being part of those conversations when you're thinking about service design. So I think the opportunities are endless, and I think it will clearly it will open up doors for all of us in the future. And yeah, I think that's yeah. If I have a few more things, I'll come back to it. But Jen, do you want to?
Yeah, what that's in place at the moment is a sort of a bit of a hybrid between people who've been maybe in. So a few years ago, you had to be working in an area for at least 2 years before you could do prescribing. You had to have that background and skill, and over time that's changing, and that's good because it seems a bit pointless for people who are doing roles where they could be prescribing to have to just wait and wait and wait. And actually the prescribing course, because you do have to learn all about the drugs that you're going to prescribe. So as I was saying, she learned all about her DOACs very quickly too, for more than one reason. So that's really helpful. You could argue that actually it's a really good way of building up your knowledge in one area very quickly, because you've got to focus for a period of time on it. I think the model start to move away from maybe the structure. It's difficult because we're currently got different models running at the same time. The card is only just going into tools for them to be able to facilitate, and other providers obviously to facilitate that training during. So it will change over time, and I think this is a really exciting opportunity for us to be able to feed back and get those models built, and potentially get the degrees changed before they get set, and say, actually, this is what we need to have in our degree, this is what we need to have in our foundation training year, to have people coming out who are completely ready for practice. And this is actually a really exciting opportunity while all this change is going on, to feed back into the system and sort of say, this isn't working at all, what can we do to make it better? And I think it's really exciting time. It's also challenging, because at the moment, as we've got within the trust, I'm very aware of the fact we're going to need to have another 12 DPPs available to support trainee pharmacists in a couple of years, going through year 5 training, at the same time as we've got all our legacy workforce and people like you guys who will be finishing your diplomas or doing that last module of diploma in prescribing. So potentially where we had maybe 4 or 5 people going through a prescribing course at any one time, you might have 10 people going through prescribing courses. And instead of prescribing courses running twice a year, they're running 4 times a year. And how are we going to manage to support people doing that, as well as all the other support that we're giving? And it basically means that people who are currently in more senior roles, and maybe not even in more senior roles, maybe sort of start saying, we need you to be mentoring, you to support people as part of your role. You need to you will have a trainee pharmacist to be a designated supervisor, or you will be a diploma tutor, or you will be a DPP. And a lot of the time, people, I love being a diploma tutor because I learned so much from being a diploma tutor, because people will go off and bring me back an MOT or whatever, talking about spiritual medicine at the moment. It's not just nicotide, salbutamol, and ipratropium anymore. There's 50 million different inhalers that all seem to be the same but different. And actually, it's really useful for me, for my learning, to have somebody come and tell me about all the new things that have changed since for 15 years. And I learn loads being a tutor. I really enjoy it. And yes, it can be hard working. Yes, it's another thing to do, but actually it's really rewarding. And I do think there's a bit of a mindset, particularly with things in HS, the way they are at the moment. It's like, I've got so much to do. Actually, trying to get our senior people to follow in the future means that you won't have so much to do, because they'll be able and competent to do it as well. And it's one of my passions, is to develop people and get them seeing people achieve their full potential. I think it's so important, and I'm really keen to support anybody who wants to do that. And I think all our senior pharmacists should be doing that as well, because it's an incredibly rewarding thing to do. And I love seeing people develop, and I really enjoy being able to celebrate people's success. And thinking, damn, I wish I'd had the opportunity to do that when I was band 6 or band 7. I would have loved to have done that. But I'm able to give people the opportunities I didn't have, and I'm really keen to do that for all my staff. And hopefully you find people like that in your work.
Amazing. Thank you so much, you guys. I think we've got time for one more question. But of course, if any of our team, if any of our attendees have questions, please do put them in the Q&A and we can come to them. That's not a problem. But I'd like to hear from you guys now about if you could give any advice to those of us who are going to need to undertake an independent prescribing course, and also anybody who's thinking of undertaking their clinical diploma. What sort of advice would you give to them?
Okay, so just recapping on some of the themes that we discussed. So first thing, passion. If you've got an area of interest that you particularly want to enjoy, you can see yourself growing and developing, that's always a good place to start. But don't put pressure at the same time. If you don't know what your scope of practice is, you don't know what you're going to be specialized in, don't worry too much, because even though I did my prescribing anticoagulation, I prescribed a lot more hypertensive, heart failure medication, all other medications, more so than anticoagulation. So it doesn't matter where you start, but thinking about other scope of practice. But of course, it makes it a lot more enjoyable when you're learning about something that you're really passionate about. But also think about practicalities too. So if you're if you work in general practice, for example, and you've got an interest in Parkinson's disease and initiating Parkinson's medication, it's a very narrow scope of practice. And in your day-to-day practice, you're not going to be initiating, or you're not going to be seeing patients regularly to actually utilize that. So thinking about what would be beneficial, what can you experience within your practice regularly for you to utilize as part of that. So thinking about what will you see regularly, so that it's easier for you to collect your 90 hours of prescribing practice and learn from the people around you and utilize their expertise to build your portfolio. Invest in your learning, whether it's diploma, whether it's prescribing course, spend time investing in your learning and development and your professional development, and areas that you want to develop your competence in. Keep up to date is really important, especially with pharmacy. Utilize all the learning experiences, network, shadow, meet people, ask. If you don't ask, you don't get. So if there's any opportunities that you want to go shadow a hospital pharmacist or a community pharmacist that's doing prescribing, it's worthwhile reaching out and accessing areas. And just a tip that one of my, it's not mine, it's somebody else that mentioned it, was thinking about, you're prescribing. I think there's a lot of focus around what prescribing, but also think about de-prescribing. We're in a situation where we have problematic polypharmacy. People are living longer, there are multiple medications, they've got many comorbidities. So as we keep adding the medications, think about actually holistically completing structured medication reviews. Actually, is there a need for a medication or not? So somebody always said to me, don't start what you can't stop. Because if you end up if you're thinking about starting a medication, knowing actually when would I stop the medication, what counselling can I give to that person, so that they're also aware when to stop. And yeah, utilize your pair network. You've got a great group here, BPSA memberships, your networks, you've got your local networks within your hospitals, your community, whichever setting you're working in, and you have university academic, you've got a huge platform, and you also got RPS as well. So if you've got to reach out to us, connect, speak to people, please do reach out and make use of all the learning and experiences that everybody has as part of that. So those are my top tips.
I completely agree about deprescribing, and I spend a lot of my time stopping things that people don't need anymore, especially on ITU. It's like they don't need that night sedation. We don't need that PPI anymore because they're eating. If we don't stop it when they're on ITU, they'll go on it to the ward. The ward won't stop it because it started on ITU. The patient will go home on it and be on it forever, and then they'll have some other complication due to the fact they didn't need to be on omeprazole. So I do spend a lot of my time doing that sort of thing. It's actually, yeah, it's a holistic thing, thinking about what is the right thing for our patient. But with regards to courses, if you've got the opportunity to do a course, somebody else is willing to pay for it, take it. I think it's really worth doing. So I spread out, I did certificate and diploma separately, waited a few years, went back and did an MSc, gone back and done some research since. I don't think you need to be in a rush to get prescribing done. I think it's not a rush to get your diploma done. You need to do things, just doing it quickly to get it done and out of the way. It's doing yourself a bit of a disservice because you deserve, it's such a good opportunity to spend time and learn about areas you might not have the chance to learn about. It's really hard once you've qualified and once you've done these things to get a chance to do anything else, to find funding for things or paying for it yourself. So I would say you don't have to do everything now. I also say, which is sort of general careers progression, don't be in a rush to get up the grades. Actually, being on rotation for a period of time is incredibly good for you because it gives you that good background knowledge about everything. It gives you really good skills about working with different people in different situations. Don't know. So you don't know that you've suddenly got a passion for urology that you never knew you had. You don't know that you've got a passion for cardiac medication, or you don't know that you particularly. I always thought I wanted to be an oncology pharmacist until I went and did an oncology rotation and was incredibly bored because it was all so protocol driven. So you don't know what you don't know. So actually being on rotation for a period of time, yes, it's difficult and yes, it's challenging, but at the same time, it's an opportunity it's really hard to get again later in your life. So I would say your careers for your life, please don't really enjoy your opportunities to learn. It's much easier learning when you're younger, and when you haven't got 50 million other things to worry about. I know I've tried, but yeah, I strongly recommend use the opportunities that you're given and enjoy them. And if you've got the opportunity to do a whole diploma and don't have to do prescribing as part, and that suits you, great, go for it. But under pressure doing stuff, I strongly advise that you do what's right for you, and say don't rush. Sit back and enjoy your career for the rest of. Hopefully, you'll be in pharmacy for through it. If you find something you're passionate about, and like I say, I love care because it's so different all the time. Asher clearly loves working in her clinics and working with her patients because she's found relationships with patients she sees all the time, and I think that's great. But if you just jumped at the first thing that came up, we might not have found these. I think so. Yeah, please don't rush. Take the opportunities that come to you, especially for those of you who are still doing your training year. When you get towards the end, say, I didn't do this, I want to go and do it. Ask somebody. But with the ambulance service, ask someone, we can probably arrange it, that sort of thing. So please, yeah, take the opportunities that come to you and don't feel any pressure to rush and get things done just because somebody else has done it. Sorry, I'll get off my soapbox now.
Amazing tips. And thank you so much again to Azra and Jen for joining us today and just talking through their experiences, independent prescribing. And I hope that all of you take away that really big tip there, that there is no rush. Take the time to find what you love and what you enjoy, and the rest will follow. So Sally, I'm going to hand over back to you now.
Lovely. Thank you, Key, Emma, and also thank you to Azra and Jen for sharing all of that, I mean, it was just such a great conversation, I think. And there was so much transparency and just so much insightful things that I think a lot of people, you know, who are aspiring to do their prescribing course do not have that much guidance and knowledge about the entirety of what it's like to do the actual course. I think a lot of people have a lot of assumptions of, you know, what they can do and what they cannot do. But as you said, it's mainly looking at it as this great opportunity to almost elevate yourself and enhance the clinical knowledge and non-clinical knowledge that you have succumbed to throughout the year. So really great way, and love the way you guys put it, and love the way you guys given us, like, you know, a lot of guidance and advice, especially towards the end as well, and that little bit of motivation. I mean, for a trainee as myself, and I've you know, so excited to get a wide range of experience across different settings, but also the advice that I will take personally as well is not to start sort of going into the niche side of things or specializing too early. And I completely feel that I'm so curious about all the different parts of pharmacy that I do want to gain that knowledge and maybe do my prescribing course in a wider, more generalist you know, covering different topics first before specializing essentially in the future. So that was really, really great. And thank you guys for joining us and putting all that effort to putting that together. Really appreciate it.
Great. Thank you for having us. Take care,
Thank
everybody.
you for
Thank you,
inviting me.
guys. Thank
Bye-bye.
you.
Yeah, thank you for inviting us.
Of course, Jen.
Bye-bye.
Thank you very much for being here. Thank you very much. I think Kina, you're here as well. Thank you for joining us. And yeah, I really hope that you've heard a bit about that as well. And yeah, no, it was we're excited to have you deliver a workshop for us today. I think we can start in 10 minutes time, because I know Emma, I'm not sure if you want to do like a quick, we could have a little quick networking session. I think we've prepared like a mentee meter. So feel free to stay and maybe participate with us as well. But we will commence the workshop, I'd say about yeah, 3:10, if that's okay. Yeah. Lovely, wonderful. Emma, you can take it over now.
Thanks,
And
Sally. Actually,
Amazing.
Super. Thanks for the intro, Sally. And yeah, congrats to the BPSA team for putting on one of these conferences, because it's so important. I think it doesn't even matter if like 2 people go away and you've like, you know, they remember something. It's like so worth it. It's definitely quality over quantity. I'm going to go ahead and share my screen. I'm going to put out a massive caveat just to say that there are a lot of slides. But I just wanted to make sure that no one's like trying to write down notes and stuff. Like I hate going places where I have to just write down everything because there's not much info. So yeah, hopefully the team will be able to share the slides after, and you have that as a resource, not just now as like students and trainees, but like for life when you are like navigating your way from job to job. So bear with me while I just get my slides up. Hopefully this will work. I'm going to ask in a second if people can actually see slides pop up in a moment. Can everyone see that loading? Super. Sally, really sorry to pull you up and take you back off mute, but just want to check, and it's no problem if there's not, but are there any polls uploaded for this session?
Yeah.
There are. Okay, awesome. Yeah. Great. So yeah, at some point you will see a couple of polls come up. I haven't exhausted us with too many. So if you're able to just yeah, interact and take part. But yeah, like the team have said, that this session is all about kind of CV building, the kind of do's and don'ts. So we will weave in some tips along the way. And just yeah, just knowing what to sort of look out for when you go from job to job, whether it's summer placement to training placements, or just where you want to be kind of in your career for X amount of years. And then we'll touch on the interview process as well in a minute. So our first poll is really just to get a feel of how confident you are all feeling right now. So when you think about applying for jobs, whether that's a summer placement or your actual next job after your foundation training year ends. So give that a quick go and yeah, tell me how you're feeling. And BPSA team, whenever you feel like enough people have taken part, because I can't see it, just feel free to give it a close. Super. Okay, so we have a nice spread. I like the fact that someone is feeling very confident, which is super good. And definitely keep that momentum up. Absolutely fine for the rest of you that aren't really quite there yet, and yeah, perhaps not, you know, feeling confident at all. That's completely normal depending on where you are right now. And things change, and we know that as you go on in your career. But hopefully by the end of the session, you'll start to feel a bit more confident with how you're feeling. So not to bore you, but just quickly, a couple of learning outcomes. So hopefully by the end of the session, you'll be able to understand how you can get, I guess, the most out of CV writing and actually developing your own CV. Some key considerations as well, what to be aware of and what to look out for when you are applying for a job, just to know if that's right for you. And then hopefully I'll be able to give you a little bit of some pointers and some advice about how to actually prepare for your interviews. And then later I'll touch on a tiny bit of support that RPS have on their webpage as well. If you are members, all of that is available to you. So when you're thinking about your CV, some people will probably have drafted one before, some people have maybe done one back, you know, in college days and not had to really do much with it at university. But essentially, as a quick reminder, that if you look at your CV as like your personal marketing document, that's pretty much what it is. It's you, I guess, putting down your biggest highlights in terms of, you know, the professional world and trying to almost get other people to buy into you as an entity, if you like. Please do make sure that you are personalising your CV as well. So although some of you might have one sitting on your desktop or a USB stick, whenever you come to applying for a role, so for example, if it's an internship role that you've seen somewhere or it's a summer placement, think about what it is that you're applying for. If it's a full-time job, again, look at this job spec. Most things do come with a job spec. If you have to, literally pull out some words from the job spec and put them onto your CV and see how you can link some of the stuff that you've done in your career, just to kind of show people. Because like, if you think about it, as an employer, they're going to have lots and lots of CVs land, you know, whether it's on their desk or in the virtual world on their emails. And they're going to have to really, really quickly sift through those first lots of CVs just to see who could be potentially right for the job. And if they don't quickly see those buzzwords that they put into their own job spec, then you might have already lost, you know, that attention that they, in terms of like getting yourself out there in your CV. Of course, keep it really concise. So similarly, like I said, when people, especially myself, if I'm looking at CVs in practice, the concise ones are really the ones that I remember. People that are really good at kind of just quickly putting their points down as well. Think about the structure, so we'll come on to that in a moment, and obviously keep it up to date. So if you've done something, you know, in the last summer or whatever, or even if it's like a summer placement job or just a bit of shadowing, just do note it down and just keep it up to date so people can see how you're progressing as well as you go along. So really quickly, another quick poll, just to get a gist of how long you think a CV should be. So do you think it should be 1 page, 2 pages, 3, or 2 plus any extras like appendices or extra bits that you've done? And then team, I'll ask you to just close that whenever you think is necessary. Perfect. So another spread, if you like. 1 page, 2 pages, that's good. And then 2 pages plus appendices, things like that. And by appendices, I meant things like, you know, references, not just references, but it could be references or things that you've published, etc. I guess the golden rule is 1 to 2 pages max, usually. I'd say particularly at your stage where you are, you know, students or trainee pharmacists, we would recommend 1 to 2, just really, really pick out your biggest highlights, if you like, and note them down. But I'll talk you through what, you know, how you can go about building your CV. So at the moment, you know, we always would say that, you know, you probably have done a lot as as students at currently doing your MPharm or doing your training year. You'd have had loads of placements and things like that. But if you feel like some of them really don't add much value, rather than listing them all, just put down the ones that, you know, it's definitely quality over quantity. Put down the ones that helped you progress in some way or apply skills that you've, you know, done in university, learned in university, but actually been able to kind of go out and do in practice. That way, employers will quickly be able to see how hands-on you can be and how you can transition from being, you know, a student or a trainee to actually the workplace setting as well. Pop down things that you might have done development-wise. It might be CPD stuff that you've done throughout uni. I know it's not mandatory, but you might have done something. You might have done training. You might have been mentoring people and leading or teaching them in some sort of a way. It could be other years that you're looking at, you know, after, if you're, say, a 4th year student, you might be doing stuff for third years to help them. So think about all of those transferable skills as well that could definitely be utilised in your workplace that you could write about. Avoid using things like "I want to help people." Obviously, it's a really good thing to do, but maybe flip the narrative and write down how you've done something that helped people. So, for example, you know, if you're a trainee pharmacist, so I know a few who are on the call, you know, when you've done your audit in practice during your training year, whether that's alongside your supervisor, maybe write literally a couple of lines about that and how that actually helped the end user person, whether that's the patient or something about the process. So that way people can quickly see that, right, you have a mindset where you want to ensure that processes and things are smooth enough to ensure that the end user and the patient gets what they need. So you can kind of change it in that way and make it a bit more tangible. In terms of your format for your CV, we touched on this earlier, give it a bit of structure. So obviously you'll want to put down lots and lots of things, but if you give yourself like quick, clear headings, people will quickly be able to glance over them and see, right, what's important to me? Is it that I need to know what your details are and anything about that? Probably not. They're just top line things so that people can contact you. The ones that I'd home in on the most are obviously your employment history, education, and key skills. So they're the things that people want to see if you've kind of met that bar, if you like. Again, talk about any roles and responsibilities that you might have had, even if that is just as a summer student or a trainee pharmacist. Definitely use all of that experience that you're building up. When it comes to qualifications, obviously at this stage you can definitely put down things like your high school grades or your your college grades, university stuff. As you go on, my tip would be maybe you can whittle them down or just mention the very top line what you've got, bulk them up together, because then there'll be more and more things that you want to add onto your CV that might be more meaty, if you like, as you go on in your career. Definitely write down things like member of BPSA, member of whatever other professional body that you're a member of. That just shows your dedication to the profession, might help you have a bit of an edge over others as well if they see that you're dedicated and passionate about your profession. So that's a huge thing. And of course, any training or certificates that you've got along the way. The reason I put down driving license in the key attributes is now more and more employers are looking for people that can maybe work across different sectors or like multi-sector, like GP, community. So it's not just about your, you know, all your placements that are like that. Some people in practice need people to go and flex between two different areas. Something like just writing down that basic skill that you have about getting yourself from A to B could actually give you a bit of an edge over someone as well. So think practically about things like that. Obviously write down, you know, if you're going into the education sector, write down things like Word, PowerPoint, Excel. I definitely had to do that for the role that I'm in, just because I have to do a lot of kind of workshopy stuff or webinars, etc. So if you've got stuff, you know, skills available that are tailored to the job, make sure you write them down as well. And obviously interests and hobbies, keep minimal if you can. Talk about them when you want to, but again, if they're not adding much value, then just keep them very minimal. You obviously do want to show that you're well-rounded, so definitely don't drop them off or anything. And then references, it's entirely up to you. There's no like right or wrong, but generally speaking, people I tend to see will just say available on request, and that's absolutely fine. And obviously you'll need to check in with who you're going to note down as well if you are going to leave a name there. Super quick activity here. It's just to write into, I don't know if it's the chat box that's available for everyone or the Q&A box, but just a quick couple of ideas of what you think you could do to fill up an empty looking CV. So write down anything that you think you could write about, and we'll go through that in a second. So it could be, I don't know, doing a new course in X, Y, or Z. So any ideas? And don't be shy. There's no right or wrong. Great. Thanks, Kieran. You've got the ball rolling. I'll give it another couple of, like 10, 20 seconds. Perfect. We've got commitment to CPD, development courses like CPPE, attending BPSA and RPS conferences. You've already hit the nail on the head with those, and you're already doing that. Attending conferences again, events, placements, hobbies and interests. That's a good one again. So great ideas. I will, in the interest of time, I'll move on. Languages, that's a really good one, particularly if you're in like a different type of setting, or, you know, you cannot underestimate communication at all. So languages is a fantastic one. I might add that onto my slide deck next time, actually. So thanks for that. So yeah, let's look at what we put. So a lot of what you've written in the chat boxes are the types of things we would also be looking for. So think about where you can, I'll go back to shadowing only because no one's mentioned it, and that's a really good one. But again, submitting abstracts and things like that. So a couple of you mentioned going to conferences. When you think about going to a conference, so for example, the RPS conference that runs annually and the Clinical Pharmacy Congress that runs over the summer, they'll always have, when you sign up to these things, they'll always say, oh, do pharmacists or trainees, etc., want to submit an abstract? If you think you've done something in university or your training year or even outside in your professional life, if you think, oh, I could turn this into an abstract, I've done something really groundbreaking and I've got some results around it, or you've done an audit and you want to write about it, think about submitting an abstract, because then that can give you an edge when you go to the conference. People will start to come up to you, you'll have a poster displayed and things like that. So that stuff is really, really good to also put into your CV. The other stuff we would say is in your actual workplace, so whether that's like summer placements, training year, whether that's actually once you're qualified, you know, try and shadow and learn a bit more about what other people are doing. And if you're doing that enough, you can actually write that on your CV. So you can almost outright say, although I don't have experience, I've got a passion in this and I've been shadowing team members to learn more about X, Y, or Z. So again, that's showing growth. It's showing that you're quite in touch with the rest of your team as well. Things like mentoring are really good. So I know I mentioned this earlier, particularly if you're at university and you have a bit of time to, like, even if it's calculations or something that someone's struggling with in different years, see if you can mentor them, because that again is a really good skill that a lot of employers look for at the moment as well. Because if you think about it, the way that staff and things happen on the ground, like everything is so tight, so they're always looking for actual employees to look after other employees rather than getting more and more staff all the time. And the other thing to do, again, people have touched on it, is attending conferences and things like that. And what goes in hand is also webinars. So a lot of BPSA, I know, run a lot of webinars, RPS do, lots of other people out there and organisations will run webinars. So see if you can maybe go to a couple just to build on your CV and I guess your knowledge as well. So that's really important. And you can do that all in the comfort of your own home. Obviously, if you're still struggling, again, think about if you've gone to an event and you've had to speak, or you've, I don't know, done an audit and you've had to present that to people. Think about things that you've done that are a little bit outside of the box, because those things will really give you an edge over, say, just writing that you attended something. So if you've done something more, that's a really good thing to write down. One thing that I didn't know about until I qualified, and I wish I did, is writing like opinion pieces. So I don't know if anyone's ever picked up or subscribed to a journal. So often they'll have on the towards the end of the journal like a opinion pieces area. So that's things that you can write in about. You might be working on something, you might have read about something that you're really passionate about in the professional world. So you can actually write in to the journal and see if they'll accept your piece. It won't be an article as such, but it will still be a letter, and that will still get published. So definitely something you can write about. For example, I did one myself even when I was in role. So when I looked after the mentoring platform at RPS, not a lot of people talk about mentoring. So I spoke about the effects of mentoring in our profession, and then that got published. So that's something that I can definitely add into my CV. And likewise, when you're on the ground, depending on what relates to you, you can also add in things as well. Again, show like your commitment. So if you're doing any courses and things like that, write that all in. And if you've still got gaps, I think Kieran mentioned it in the chat that, you know, see if you can do any development courses. So CPPE, they have so many things available. You can do them in your own time. RPS later on when you qualify have got things like post-reg frameworks and things like that, and portfolios that you can build on as well. So that's kind of the CV bit in terms of getting that all, you know, up to scratch. So you've submitted that, if you like, to someone, possibly with a personal statement. And I guess the bit before that is where to submit to. So when you're thinking about jobs, these are the sorts of things that you should consider. And I'm sure that a lot of you are aware of these things, but I'll just highlight them again. If not, there are so many sectors out there now. It's not just, I think, you know, a lot of people tend to think community and hospital and then maybe industry, but there's so many other things out there. There's like academic pharmacists, there's organisation pharmacists where you can work for, you know, places like GPHC, you can work for RPS and things like that. So take a look at where you want to be. Some things can be like split roles as well if you want to do a couple of days. So I think when you look on the GPHC webpage, they have a lot of things about like part-time opportunities where you can become like part of their council and part of things like that. So have a look if there's something that you want to split your time across. So if you're thinking, oh, actually, I want to work in community because I want to speak to patients and learn more about, you know, medicines and counselling skills, but I also want to dabble with something else. So you don't have to, you know, stick to one sector if you like. Just going to take a quick pause and just have a quick look because I don't want to miss this question. So someone's asked what type of post-reg frameworks are there with RPS. So the main post-reg framework that there is out there, so that we've basically got advanced framework, that's for people that are qualified, I'd say like 2 or more years. And then we've obviously got the consultant framework out there, which is like when you're, you know, really, really qualified. The one that would be most applicable for you on the call would definitely be the post-reg pharmacist framework. So that's like a pathway that you follow. I think it's a 2-year course, and you usually have an e-portfolio that you build up your skills within as well. So when you complete that, I think there's IP involved in there as well, but when you do complete that, you'll obviously have extra credentials as well. So you have a bit of an edge over your fellow peers. So hopefully that answers that. But if you're looking for more details, I'll share our support email at the end as well, and they can give you more info. So again, think about the location as well. Not everything, you don't need to think, oh my God, I'm in, you know, the north of England and there's nothing around me. We have lots of people, for example, that work at the RPS virtually. They live in, like my team is made up of more people in Wales than in London, for example. So don't let that be a barrier, and think about what you like to do. If you don't work that well, you know, virtually, and you're a people person, then obviously don't apply for that because you will hate the job and you probably won't do it any justice. Think about obviously the size of the organization. So are you more like a people person and you want to do things with like little groups, or do you not mind working for a big corporate organization or being a relief pharmacist and going here and there? So really give that all thought, because if you don't think about that and you just blindly start applying for things, then you'll start to resent your job and not really do that well. And obviously think about training and development opportunities that they offer. And of course, employment conditions. Don't forget to read the small print. Are you going to have a pager if you're on hospital, you know, in that sector? Do you have to work different shifts, etc.? Bank holidays, weekends, all of that. Think about that, especially if you've got caring responsibilities or you're just a social butterfly that wants to be out all the time in your own time. So those things can, you know, hinder where you want to be. So think about them. Practical ways to look for jobs. We always get this question from people, like our members especially, or when we're out and about. So I would say definitely look on any organisational homepages that you're, you know, fond of working for. So for example, RPS, where we work, we have an About Us page, and then it's like a come and work for us. So always have a look at any opportunities. Again, as students on the call as well, it's not just when you've qualified, we have like internships and things like that we run. Obviously NHS jobs, LinkedIn, etc. So do go onto the company webpage. A quick example for myself, I was a bit stuck in terms of what I wanted to do in the education field before I got to RPS. And I'd heard a lot about the National Pharmacy Association, literally went onto their webpage, saw that they had an opening, and I was like, okay, let's go for this. And I went for it, didn't have any experience in terms of what the job spec said particularly. But because of the way that I'd worded my CV and some of the shadowing that I'd done and a few initiatives that I took in terms of training people in community, that almost gave me the edge, and they could see that actually I would be really good in that role. So have a think, and just, yeah, don't think, oh my God, the job spec's a lot, I'm going to be put off. And again, make sure that you're networking and volunteering where you can. The other thing I would say is if you're, once you do qualify and you're out of work, or you're still looking for a job, you know, at any stage, if you are on LinkedIn, you can use their badges if that's something that you want to do. People might have seen you or seen an abstract that you've posted or anything like that, and they might actually think, oh, I want this person to work for me. So opportunities can also come to you. And don't think of all of this as linear. That's a really, really key thing. I think, you know, don't think, okay, I've had this job and now I need to get more money in my next job, or I need to get a higher position. Like, I think progression is all about going horizontally as well, sometimes backwards if you have to, when you've had, I don't know, children, for example, you've moved into a different part of the UK or anywhere else in the world. Sometimes you do have to take a pay cut, etc. So don't think that you're, failing yourself in any way. It's all about the experience at the end of the day. And quick considerations, I won't dwell on this too much, but obviously think about what you're applying for. Do they, are you available for the interview, for example? Have you already booked a holiday away? That will just be a waste of your time. So consider that. Consider whether you need to call up, the organisation beforehand. Do you want a site visit? Do you want an informal chat? None of that is unheard of. We get a lot of queries coming in before people apply for jobs. So ask away rather than not and going to the interview and it not quite being what you thought it was going to be. And obviously think about if you can make the interview as well. So talking of the interview, I'll take a quick pause there. I don't think there are any questions, but yeah, if there's anything on jobs at all, then let me know and I'll go back to that. So just a super quick poll again, just to check if anyone's actually had a job interview before, and that could be for like summer placements, Oriel, anything. So let's see. Great, so everyone's had an interview, so that's good. Hopefully I'll be able to whiz through the next set of slides, but that's interesting to see. And hopefully, even if they haven't gone bad, I always say, any interviews that you've done are experience, whether they went the way that they were meant to go or didn't, it's absolutely fine. All of it definitely makes you rather than breaks you, and definitely look at it like that. So I won't dwell on this for too long, but essentially you'll have all known that, try not to look at it as anything more than just literally meeting somebody. Just the way that you'd go out and meet a friend, but it's just a little bit more structured, that's all. But they essentially just want to see you, understand a bit more about you and your potential. So that's really what the purpose is. I think sometimes people can just see that and get like really anxious. So just try to really strip it down and think, right, what does someone want me to do? And it's literally just going in to talk to them. There are different types, so I don't know what everyone's experiences, but there's obviously the traditional in-person and obviously virtual now, which we see. Sometimes the first step of an interview might be a phone call. They might want to see how you communicate and things like that before you even get to the second stage. So consider those as well. That's, it's not a bad thing. And sometimes they're a bit less nerve-wracking as well. People feel like when you can see something, it's a bit more, that feeling's there. There are group interviews as well, which definitely aren't heard of, especially because people want to see how you interact with teams. They'll have like little activities that they'll want you to work on. Again, whenever someone invites you to something, have a look at the small print and see what they're asking of you. And then there's things like assessment centres and aptitude tests. So things like SJTs might be part of something, or just making, they might want to see how you will respond to certain things. So they'll ask you questions to see what your values are and how you will respond. And some of them will be like, come along to the interview, we'll ask you questions, but also do a presentation. And usually they'll ask you to do a presentation on something that you will have no knowledge on whatsoever. And it's more about what your research skills like, how do you condense things that are really dry sometimes as well, and see how you bring that to life. So don't be put off, just do your best and present it with, I think the way that you present obviously is more than the content that you present as well, because in reality you won't be presenting something that you don't know. So don't worry too much about that, and always factor in time for questions as well. That's an important thing. Again, I won't dwell on this too much. I know everyone's had an interview before, but think about what they might ask you beforehand. They might have made it clear, but if not, be prepared for things like knowledge base. So, what do you know about X, Y, and Z? And then you'll have to quickly, tell them those in black and white. There might be things more about competency and behaviour. So again, your values, how you're going to respond to things, what sorts of things you would do. And then there'll be theoretical things where they might give you a little scenario and say, what would you do in this situation? So the best bit of advice I would give you here is just really align yourself to the company values. So have a read of who it is that you're going to be working for, what the organisation's like, what the hospital trust is like, and see what type of person they're looking for. And really your response, you want it to be authentic to yourself, but try and mould it to what they're looking for. That's really the best bit of advice that I'd give you in terms of what they want to hear. And then obviously preparing for the interview once you do get called for one, again, have a quick read of that job spec, make sure that you know what they might be asking you about. Research the organisation's values. So again, every place that you apply for, if they do have a web page, I'll have like a little bit about us. They'll have a blurb about what people think of them as well, perhaps. So have a little read of that. And then prepare yourself by thinking about some common interview questions. Don't over prepare, but just think about some things that are out there now. So again, scenarios, depending on your setting, that will all make a bit more sense as and when you begin to prepare. But yeah, and then think of questions that you might ask as well. So it's not just about them asking you things, but make sure that you go in there a little bit proactive. So, they're aware that you're quite interested as well. So that's always a quick tip. Your outfit, I put this in because it is really, really important. So when you do go to an interview, the last thing you want to do is like, I won't state the obvious bits about being quite smart when you go to these things and being simple as well. But it's like, don't go out there and buy a brand new suit or order something from ASOS like the night before and then you wear it and you feel like stiff or something's not feeling right. That is just going to show through. Like, just wear something that you're completely comfortable with. My tip would be definitely wear something that you've had for a while and that you know how you feel in it. You don't want to be uncomfortable because that will definitely come through. And it isn't always about wearing a suit and a tie as well. So you can be smart in other ways. So if you want to wear that, that's absolutely fine, but just be comfortable. That is the main thing. Really, really silly little things as well, but I'll mention them. Like if you're, just make sure that your nails are polished or whatever, if that's something that you get nervous about, or, you don't want people to look like, just think about how you want to be so that you're not, how you're presenting yourself. So you're not worried about it on the day. That's the main thing. And first impressions do count as well. So just make sure you are smart. As the day approaches, obviously think about the things that you need to get done in advance. So things like just overlooking your CV or your application form. I know it sounds really obvious, but myself, sometimes I've applied for a few different jobs and it's just all at once. So it's just about going back and just checking, right, what should I put on this one? What did I say? What were there, what was the job spec about for that? So just double check what you've applied for. Again, the practice questions, do them one in advance and just see if you can get any feedback from anyone else. Someone, particularly if you've been asked to do a presentation, just say it, do it in front of a little group, or, if you're at home with a flatmate or your mum and dad, just see what they think of it as well. They'll give you a bit of honest feedback. You might be talking really fast, you might not be talking clearly, etc. So just get their perspective. And then obviously the night before, just think about, planning your route, checking for strikes and all the practical things. And then on the day, obviously, I won't say them all, but just stay really hydrated and lots of deep breaths. And it is just that meeting, that's all. Really quickly, I just want to get an idea of what types of questions you might ask if you were at an interview. So just think, right, you've applied, I don't know, you're a newly qualified pharmacist and you're applying for a job in a community pharmacy. What sorts of things could you ask? In the interest of time, I will move on. All someone's written. So we've got strengths and weaknesses, and then we've got examples of what you've demonstrated and relevant skills. So that's good. So that's more like what the interviewer might ask you. But in terms of, yes, someone else has put opportunities for development and funded IP course. So that's really, really good stuff. I'll quickly show you a couple that you might want to use in the future. But again, those ones are really good as well. So you could ask them, what a typical day might look like. So just anything that you ask them, just it shows that you're really interested. And I think that's the main thing that you need to get at. You could ask what your objectives might be, day to day, or what your projects might look like, depending on your setting. Someone's written how to manage conflict between your teams. Yeah, that's really good. That's probably what the interviewer might ask you, which is definitely a good question to kind of think about before you go in. These ones are more questions that you can ask them, so just to make sure that you're looking engaged as well. And then obviously what training and things like that you'll receive. Someone's touched on that, so development opportunities. So definitely ask them as well. The job needs to be right for you. It's not just, are you right for them? Another quick couple of tips. So obviously do create that really good impression. body language, lots of eye contact as well. We've definitely had a couple of people that might interview, like I've seen things where they're just not that engaged. So just, yeah, make sure you're sitting nice and straight and listening as well. Ask for clarification. Obviously you won't understand every question because you naturally might be a bit nervous, and it's absolutely fine just to ask them to repeat and things like that. So just, yeah, say whatever is on your mind at that point. A quick couple of tips about some common sorts of things that we hear. So when we ask the simple question about tell us about yourself, it's, you know, whatever you say, just link it back to, you know, your passion, if you can, for pharmacy or whatever it is that you're applying for and how it's helped you develop. So any progression that you can talk about in terms of when you mention things about yourself. If anyone asks about gaps in CV, it's not just, you know, oh, I went on holiday, etc. It's more about like, what did you do in that time to strengthen your weaknesses or just like better yourself, or what CPD did you do to sort of keep in touch? So they're the sorts of things that we'd be looking out for. And then when we ask about SWOT analysis and things like that, it's about your method of overcoming weaknesses. So for example, one of my weaknesses is that I could spend forever trying to work on a document and perfecting it. So the way that I overcome that is by making sure I'm utilizing my team members to, you know, ask them, can you proofread this for me? And things like that. So think about your own weaknesses and how you overcome them, and make sure that when you do mention it, you say to them, I have measures in place to, you know, make sure that X, Y, and Z doesn't happen. And then again, when people are asking you what you're proud of, it's absolutely fine to say what it is, and then perhaps how it makes a difference, or, you know, helps you do what you're doing. Super quickly as well, I'll touch on what I look for as an interviewer. So I want to really see that people have the potential to develop. They don't need to be, you know, absolutely ready for the role. You know, everything is always work in progress, and just that you share our values as well, and you're quite honest in the way that you're coming across. That's really important. A few things to avoid, obviously not being prepared. Hopefully that would never be the case, but yeah, we're just making sure that you are prepared, you've read up on things beforehand. A poor attitude, so just feeling like overly confident and things like that. Just stay humble until you get it. Well, even when you get it, just it's nice to be a people person, and you know you're gonna work not in isolation as well, so with teams. So make sure that that's coming across. Don't just mention that you can do this. Try and back up with, I can do this, an example being at university or during my summer placement or during my training year, etc. Try and cut to the chase, so no long-winded answers, just maybe top line say, oh, just to summarize a little bit of what I did, this is what they, and if they want to know more, they'll ask you more. Quickly just looking at this, sorry, what types of questions would you recommend asking? So I think Sally's highlighted this one, but we would really recommend talking about like development opportunities. So what could your organization offer me, or what are your objectives as an organization in the next, you know, year or 2 years, things like that. So just show a bit of, I guess, you know, an interest in how they can develop you, and also what their long-term goals are as well. So yeah, the no questions is on there. So just make sure you've got some questions ready. And of course, social interests are great, and it shows that you're a people person, but not too much focus on that, and just link it back again to what they are looking for. So just remember that bit. After the interview, obviously, I won't talk about this too much, but the key things to consider are, you know, if it hasn't gone well, don't worry, reflect, and it's an experience and you can build on that in the future. The main things are just making sure that if you have got that job, that you've got things in writing. Things can fall through occasionally, so don't feel disheartened, but you know, having contracts and things like that in place will stop that from happening. And then think about if you need a mentor. So if it's a new sector or anything completely new that you're going for, definitely go out there and look for a mentor. RPS have their own, but maybe some other organisations do as well. But as a member, you can access the RPS mentoring platform for free and match up with people who you wish to match up with. Obviously, when you get to your first day, you'll have lots of documents, hopefully from the employer. But if you don't, and you are an RPS member, we have lots of first aid guides. So there'll be things about, you know, what to expect, what you could wear, what sorts of indemnity insurance you might need, just like those key practical considerations. So do have a little rummage through the guides. They are really, really useful, just to kind of, yeah, help you feel at ease when you enter into that workplace. Other RPS resources. So if you ever do choose to become a member, or you are a member, you might see things like the Pharmaceutical Journal. We've got a really great platform on there with lots of articles and things like that to help you keep in touch. There's an e-library with so much more in terms of books and things like that. The Careers Hub, which I mentioned, there's things on like CV tips, further things on there. About the first aid guides. Of course, there's mentoring. So whether you want to sign up as a mentor, which is absolutely fine, and you can put that on your CV, or you're looking for someone to mentor you. So there's opportunity for both, again, all included. And there's internships as well. So I know a couple of you mentioned that you're students on this call. So do have a look at what's available out there. I believe an internship has gone live as well in the last week or so. So have a look at that. It's over the summer months. So hopefully that's something that you would look to do. And really quickly, I did want to revisit this poll. I know you took part in it before, but just to see how confident you're feeling now, and if that's changed. And it's absolutely fine if it hasn't. It has only been like less than an hour. Let's see what the results are saying. Oh, that's good. Okay. Oh no, there was a person that was feeling very confident, which I'm a bit sad about. But that's good. The shift, there is no one that is like, I'm not feeling confident at all, and that's absolutely fine. Yeah, you're not meant to feel like super confident, especially, you know, at this stage, you're still new. Don't put any pressure on yourselves in terms of, you know, going into the profession. But these things come, you know, with experience, and your confidence will build over time. But that's really good to see that some people do feel more confident now. I think everyone's kind of asked along the way, but if there are any other questions, feel free to pop them in. I'll hang on for a little while longer. If you can't think of anything now, don't worry. I know there were some questions about what questions you would ask at the you know, interview. So again, there are those examples, but they can just be, you know, things that you want to know. It might be flexibility around the role. So I know, Emma, you mentioned there's flexibility in the profession now. So if you've got caring responsibilities and that's something that means something to you and you have to have that, you know, noted, then do that. And if you think, oh, it might hinder my opportunities, then ask it later once you've been given a job opportunity. Just play it the way that you think is best. But the development ones are really good. You can't go wrong with that, because that shows a passion and a want for that role as well. Great. I will quickly touch on this just because it's in my slide deck, and I was mindful that there will be some trainees out there on this call. So if you are an RPS member, just let you know that RPS have got lots and lots of support as well available. So we've got our revision course launching, mock assessment as well, and mock feedback sessions that we invite you to. It's all interactive and kind of live, apart from the mock assessment, which you can set in your own time. And again, as trainee pharmacists, there is so much out there. So do with what, you know, go with what you think is right for you. Have a look. But yeah, RPS do have a lot in place as well, if you did want to know more about how we can support you. And really quickly, if you're able to, in the last minute that I've got with you, or 2 minutes, if you're able to scan this code, or I'll put it into the chat, just give us a tiny bit of feedback on just what you need, you know, as a student or a trainee member, or newly qualified pharmacist. Yeah, just how we can help you. So it's a super short survey. It's like 3 questions, just quick answers there. So I'll be really grateful if you are able to do that for me. I'll pause there while you have a minute to do that. Hopefully that's worked for people. But yeah, and I'm very aware that I've given you lots and lots of information, but as I said, hopefully the team will be able to share the slides that I've gone through today. But if there's anything else that you want to contact us about, then please do feel free. We've got our support line number on there as well, so we're always happy to help. And obviously contact me directly if you find me anywhere. But yeah, always happy to help. But hope you found that useful, and I will stop sharing and let the team take over.
Thank you so much, Tina. Thank you. I think that was such a motivating and inspirational. You're bringing us through the journey of how to get this started, and it's sort of, I guess it helps reduce any overwhelming feelings associated with, applying for a job, going for an interview. I think a lot of people find that experience in itself so nerve-wracking, and I'm sure yourself, you've experienced something like this as well. And just almost saying that it's okay and providing us with that reassurance, but also the bank of resources and just, the step-by-step guidance. I mean, I've got so much notes that I can go away with, especially with regards to like the job applications and CV. So thank you so much for giving your time today, and making this as interactive, as enjoyable as possible. But like, Kina says, well, there's so many resources that RPS has to help you in your journey, whichever, stage in your pharmacy training you're in as well. But yeah, thank you for such a thorough and engaging presentation. Really appreciate it.
All right, thanks so much for having me, and good luck to everyone on the call as well.
Thank you. Thanks, Kina. All right, I think we have a bit of time. Hi, Wing. I noticed you've joined us for quite some time, which I really appreciated. But I'll pass it on to Danka to actually introduce you and facilitate your session. Yeah.
Thank you very much, Sally. So thank you very much for joining us for our last session of the day, Wing. I hope you're doing very well. And yeah, so I just wanted to introduce you in a few sentences, if that's okay. So Wing has kindly joined us to facilitate ethical dilemmas workshop, a workshop about professional judgment. And he works currently as the head of professional standards and patient safety at the RPS. So we are very thankful for you to be with us here today. Just before we start, are you okay with your session being recorded?
Yes, that'd be fine, Daniela.
Okay, brilliant. Okay, so we would be happy to start whenever you are ready.
That's great. I'm going to try and share my screen, and hopefully that works. Has that come up at all?
Yes, that's brilliant.
Okay. There we go. Okay, so thank you so much, Daniela, for the introduction, and good afternoon, BPSA graduates. As Daniela explained, I'm Wing Tang. I'm the head of professional guidance standards and patient safety at the RPS, and I'm really delighted to join your conference this afternoon. I think you've had a very full day of workshops and activities, but hopefully have just a little bit more energy for one more session. This afternoon, I'd like to take us on a short journey, which might hopefully help you handle ethical dilemmas with more confidence. This workshop has been slightly adapted for the format today, so I think if this was face-to-face, we would have had broken out into small group sessions to discuss a scenario, and then I'd hear a playback of your findings to those scenarios. That's going to be trickier to do remotely, so I've adapted this a little bit, but we're trying to keep this as interactive as possible, and we'll do that using the chat feature. So I think my apologies in this space. I wasn't as organized as Kina, and I could see those Zoom polls working really, really well, but I didn't get to do that in time. So my apologies for that. However, I do promise to limit this final workshop to no more than 6 slides, as you can see there, of which the first we have now completed. So I'm going to move on to our second slide. I think what we need to do is, so if we're going to explore professional judgment, and if we're going to explore ethical dilemmas and what to do, we first need a very quick recap about the word professional, and what does professional mean in the context of professional judgment, and what does professional mean to all of you. So this first interactive element, if I could ask you all to type in the chat an answer to a couple of questions, and we can discuss those. And if in doing so, if you could please avoid referring to any reference materials. So I'd like you to reflect, think within, deeply within and pull something from your memory banks, if you like. You possibly covered some of this at university, but if not, it's a perfect time to review and think about this now. So what does being a professional mean to you? I'm going to maybe talk about a series of questions. You can answer the one which is most suitable to you, but they all revolve around this definition of professionalism. What does being a professional mean to you? What are the characteristics of somebody who is a professional? And maybe to help you with this exercise, so I'll try and talk and fill in the voids whilst you have a think. Who in your mind do you think of when we say professional? And this might be healthcare, it might be non-healthcare. Anybody you think of when that term comes up, and then why do you think of that person? And so with that, I think the chats are starting now, which is good. And what else? I'm going to open that quickly in a second. But so, what does professional mean to you? What are the characteristics of a professional? Who do you think of when I say the word professional? Why do you think of that person? What characteristics do they demonstrate? What values do they have? What behaviors do they have? So okay, I'm going to delve into the chat now. We'll see what's there. Okay, so we've got Salita with being honest and transparent, respectful of everybody, including those with different values and beliefs. That's fantastic. And as I see these, I'm going to start typing them in. So we've got honesty, transparency. We've got respectful, values and beliefs. Excellent. Let's scroll down a bit. So then we've got Kieran, inspirational and motivational to team. Yep, so we've got team, motivational, inspirational. Some more empowering as well to the team. So we've got somebody who's motivational, inspiring and empowering to their team. Daniela has got some so you've got Daniela's covering communications, so appropriate language, motivational language, inspiring language. Do we have more? Okay, we have Emma we've got ongoing development of keeping up to date. Yes, excellent. Excellent, thank you very much. We've got listening. Good. Keep them flowing in for a little while longer. So we've got Andy, who's talking about maintaining and developing and being able to use professional knowledge and skills. Excellent. So we're talking about professional knowledge and skills, and also this theme of keeping up to date. So that's coming through. Good. Anybody else with any other characteristics or values or behaviors? I think we've captured a good good lot there. So for me, whenever we talk about professional, the first thing I think of is going to be some sort of sports personality, sports person of some sort. And why do we think of as sports people when we talk about professionals? It's usually because they're really good at what they do. And so that's represented in terms of, so if we relay that over to healthcare, to pharmacy, that's relayed in terms of their knowledge, their skills and their expertise, how good they are with their job. You've already come up with keeping up to date. Several people have talked about the value of keeping up to date, so keeping your skills and knowledge and expertise up to date. And then we've also talked about so some values and behaviours have started to come through too. You're expecting a professional to be honest. You're expecting a professional to be transparent, respectful of people, And there's more too. So there's also compassion. And we'd expect a healthcare professional to be compassionate. We'd expect a healthcare professional to have empathy. You've identified working as a team and communicating well as characteristics of a good professional. We'd also expect a professional to be able to put other people's interests before their own. So this concept of altruism, and on top of that, being able to solve problems and do the right thing. And I think there were elements of that which came through from all of you too. And it's really important that we capture this picture of professional, because later, as we work through some of the scenarios, we're going to sense check our final decisions on, what we're going to do back against the characteristics of being professional. So are we being these things? Are we being honest, transparent, respectful of values, inspirational with our teams when we make the decisions that we make? Okay, so that's really helpful. I'm going to move to the next slide now. And this is also a very, very quick recap. It's so what we've got here is is an extract from our medicines ethics and practice guide, and also one of our standalone pharmacy guides. It's the RPS suggested framework for working through an ethical dilemma across a 6-stage process. That process is not by any means fixed. You probably adapt it for your personal use. And in time, there will be steps which you do very much intuitively. So you wouldn't necessarily be manually working through the stages of this professional judgment framework. Perhaps you already do this intuitively for some of these steps. However, for those who'd like a recap or are process orientated or or would like a method in the way that they undertake the activity, then it could be useful to follow this process. And the first step is usually typically to identify the nature of the ethical dilemma or the professional issue. We then move to gathering all the relevant information and researching the problem. And in doing so, we'd obtain the relevant facts. So you'd find out from the patient, you'd find out from the prescription, you'd find out from the prescriber what is happening. You'd gather relevant knowledge. So you'd make sure that you're clinically up to date with the situation that you're dealing with. You might recap on the legal situation. So check in on what are the laws which apply in the situation that we're talking about. You might review any relevant regulatory standards. So you check in with the GPHC framework or the CQC framework to see if anything applies to your situation. You'd maybe review RPS professional standards or RPS good practice guidance to see if we've covered that in guidance. Or you might review the guides of other pharmacy bodies such as the MPA or the PDA. You might take advice from support services, the RPS support service, or from your head office, or from line managers or colleagues. You might phone a friend. And having gathered all of the relevant information and facts, you try to identify all of the possible solutions. And as part of that, you'd gather further information about the solutions as appropriate. Once you have the solutions in front of you, you then consider the pros and cons of each solution, and you hopefully then select one which puts the interests of the patient first. You'd consider and try to manage appropriately any personal interests or organizational goals or incentives or targets, and possibly put those to one side. You'd weigh up the benefits and risks of the different options available to you, and then you would choose an option. By that time, after having undertaken this process, should be in a place to justify the decision that you've made. And this is really important because being able to justify your decision well, so the nature of an ethical dilemma, the nature of a dilemma is that you're weighing up conflicting pathways, you're weighing up conflicting obligations, you're weighing up patient interest, you're weighing up your legal obligations, you're weighing up public interest, you're weighing up contractual terms of service, you're weighing up company procedures, and you're deciding what to do. But the reason why it's a dilemma is because there are multiple pathways which are probably viable. Otherwise, it actually wouldn't be a dilemma if that's the case. It would be quite relatively straightforward. But sometimes when a decision is finely balanced, that's when you've got a judgment to make, and that's when the professionalism comes in. And then we would always advise that you make a record of the decision, and that will cover the reasons leading up to that particular course of action. But it might also be a formal record, so it might be a record within the patient's PMR or within the prescription register, or in your own note book as appropriate. So, and I think I covered this already, but I do want to stress the ethical dilemma and a professional judgment decision. There often isn't a clear right or wrong. That is, I suppose, that's the definition of dilemma, and that means that two very good healthcare professionals might choose to take two different pathways, and with neither of those being wrong. And to some extent, it's about what's reasonable and what's acceptable. The important thing is that both of those healthcare professionals are able to justify their decision if they were to be challenged. Okay, my next slide is, and I'll try to make this bit interactive now. So originally, what I had in mind is that we would would ask small groups to pick an ethical dilemma, and we'd run through the framework using the ethical dilemma, and then you'd report back, after maybe a 15-minute exercise. I don't think we can do this in this format, but we'll tweak this slightly, and I might ask you maybe all to be a little bit intuitive with the framework that we've got. So we might not work through all the steps of the framework, and instead, if I talk a little bit about some of these generic ethical dilemma scenarios, and maybe as a group you could tell me what you would do. So we've got the first scenario there, which is about balancing patient confidentiality with suspected medication abuse or self-harm. So you might have encountered this in practice already. So if we're taking a community example, so this might be where you're supporting a substance misuse service, but in later conversations with the service user, they reveal to you details about medicines or illicit substances that they are taking, in addition to the medicines prescribed within the substance misuse program. And you might have a belief that the combination of the illicit substances together with the prescribed substances can cause harm. And so then you've got a classical ethical dilemma situation where the patient's revealed some information to you, perhaps in confidence, perhaps overtly in confidence, and you've got a decision to make about whether or not you would discuss that with colleagues, discuss that with the clinic raising the issue. The situations could also come up in secondary care or in primary care. So you can imagine a situation where maybe you're having a conversation with a family member and details are revealed which impact upon the care, which the wider prescribing team don't know about, the wider health service team don't know about. And then in that situation, what do you do? Would you tend to uphold patient confidentiality and not say anything? Or would you tend to speak to your colleagues about the situation, and which might result in the patient knowing that you have breached the patient confidentiality in this case, or breached their confidence in this case. I'm wondering, has anybody encountered this type of scenario? already. Maybe if so, you could say so in the chat. But in any event, whether you have or you haven't, I'd be interested to know, in this scenario, would you be inclined at this stage to share that information, or would you be inclined to protect patient confidentiality? I'll just give you 60 seconds or so to say what you might do, and then we'll move to the next scenario.
Wing as well. I was wondering, we can do a quick poll if you'd like to know.
Oh,
If
yes.
and if you like one of us,
Oh,
I could do
yes.
the poll if you want. And was it between sharing breaking patient confidentiality, or if you just let me know what the options are, and
Yes, yes. So I think with the first scenario, it would be about with the participants of the meet today, would they tend to choose to break patient confidentiality and share details with the wider healthcare team, or would they preserve patient confidentiality and hold the information for themselves? I think there's also a third option of, are there other pathways that you would think of and that you would choose in this scenario? And I realise the scenario doesn't have full details. That's the way of these things. And I'd probably do this for each of the generic ethical dilemmas, if that's possible, Salita. Wow, that's so responsive. Thank you. Thank you, BPSA team. Really interested to see how a group of graduates chooses which option to go for with this scenario. Brilliant. So is it calculating the results at the moment? That's intriguing.
I think we've ended the poll as well, Wing. So it seems that breaking patient confidentiality had the higher votes. Yeah.
Oh, okay, excellent. Okay, in that case, let's move to the second scenario then. So the second ethical scenario here, that we've got a situation where we're reporting medication errors, or where you're in a situation where you've seen that there is a medication error. It may or may not be associated with your practice, probably not associated with your practice, and it's the type of scenario where you believe that either a colleague is putting patients at risk. There's a danger to patients, potentially a danger to patients. I suppose if you were sure there were danger to patients, it's clear what you need to do. I suppose there might be, in this scenario, there's going to be uncertainty there. So there's a suspicion, if you like, that a colleague is either deliberately or because of the nature of the medication errors that you're suspecting are taking place, putting the patients and the public at risk. So your dilemma is whether or not to and at what point to raise concerns in this sort of scenario. I think if we make this real, then you might have been a colleague of Dr. Shipman, who was misusing controlled drugs to cause harm to patients, or perhaps you're a colleague of Lucy Letby, and it's about at what point would you would this cohort tend to raise concerns, or maybe not, or would it be about taking other actions, but maybe taking actions, but hopefully not doing anything at all. Thank you for that one. Excellent. Really glad. Maybe I made the scenario not quite an ethical dilemma. Maybe we're talking about Shipman and Let Be. Maybe I'm nudged it down the pathway of going down one route. That's really useful to see that result. Thank you. Our third scenario is a classic scenario, really, and this can happen in all settings. And this is a scenario where you've got an incomplete prescription. It might be a prescription for a controlled drug. It might be a prescription for any other medicine. But for some reason, that prescription is not quite legally valid. Something's missing on that prescription. But at the same time, the patient really needs it. We're now, the scenario might be end of day, out of hours. It might be a Saturday, or 5 p.m., 6 p.m. In the evening, and the prescription may be a controlled drug, might be a serious one. So we know that if we move ahead and dispense that, then we'd be breaching misuse of drugs regulations, and a whole load of other regulations too. But at the same time, the patient really needs it, and it could be a case that they're in pain. It could be in case that they need that medicine for other reasons. And so, classic example. I'm intrigued to see whether this group, the BPSA graduate group, would you be inclined to supply that prescription, even if it were a legal supply, if you like? Or would you choose not to supply and perhaps explore other avenues to help? Oh, so we're finely balanced in this case. So we've got about 50% of respondents opting to supply the medication, even if the prescription were invalid, and we've got 50% choosing not to supply the medication, perhaps exploring other options and routes. If the 50% who chose other options, if you wouldn't mind popping into the chat about what else you might consider, then that would be, I think, really helpful. At the same time, I won't wait for that to go into the chat. Let's move on to the next scenario. There are probably similarities to the one before. This is something that actually happened in the past. So the situation is where you've got a patient from another country, probably let's say the United States, from Canada. And they need medication. They've run out of whatever medication that they've come into the country with, and the situation is that the circumstances mean there isn't a legal way to do this, but there is a medical emergency. So if I add a little bit more detail to this situation. Let's change this to or tweak this slightly to a need for asthma medication. So their blue inhalers are empty. They've come to your pharmacy and they need one. They're from a country where we don't recognise their prescribers, and then you're a bit stuck on a lawful way forward in that time. And so I'm wondering whether this cohort would consider supplying the medication, knowing that it's not lawful, or would you decline to supply and perhaps explore a different avenue to help? Okay, so we've got 67% choosing to supply, and then we have got 33% opting not to supply. And again, if the participants who opted not to supply, if you'd like to put into the chat how you might, if you had an alternative way to support, I think that would be really, really helpful too. I'm going to skip to the sixth bulleted point, and this relates to a couple of scenarios which are conscience clause related or linked to the conscience of the supplying pharmacist. In a past, emergency hormonal contraception probably would have been the typical example for this. I think less so as time has gone by, maybe assisted dying would be the very topical future dilemma in this area. Maybe if I focus the scenario in this case upon assisted dying. So imagine a future, maybe a near future, where assisted dying is now legal. So euthanasia is legal, and pharmacies are now from time to time in receipt of prescriptions for the course of medication, which then helps with assisted dying. I'm really interested in whether this cohort at this time, if the legislation were legal, would you be comfortable supplying that bundle of medication, or would you decline and refer that prescription elsewhere? So I'd be really interested in your thoughts on that. Sorry, I probably by skipping one of the bullets, I probably messed up the poll. But yeah, team have expertly got something up for me, so thank you very much for that. So in the assisted dying situation, would you be comfortable to supply medication? Or would you be more likely to be exercising some sort of conscience clause and decline and refer? Okay, so this is an interesting situation too then. So we've got 33% of respondents who would be comfortable to supply medication, and then we've got 67% of respondents who would probably be declining and opting to refer. That's an interesting situation. So a little bit of info to share at the moment is that the Scottish Government is reviewing assisted dying once more. So that discussion point and the possibility, although it might be a narrow possibility, the possibility of assisted dying becoming legal in the future is being discussed once more. And if it does come into place, then it would impact upon the practice of pharmacy practice. That's really helpful. I'm going to move on to my next slide. So slide 5 of the 6-slide deck, and this is a so this is the issue. This is the most difficult ethical dilemma of the last 3 years. So very current, that the RPS support service, so the telephone service that Kina talked about earlier, they support members by telephone and email. This is the most tricky inquiry type that they receive, and it's about it's a professional dilemma linked to gender incongruence. So I probably would describe it as the dilemma of our generation, or the dilemma of this generation, or the dilemma of this time. And so the scenario is you're working in a community pharmacy, and because it's a real dilemma, and we're receiving queries on a weekly basis with this type of scenario. So the scenario is you're working in a community pharmacy, and you've received a private prescription. In this case, it's inevitably a private prescription. And it's signed by a doctor who is based in the European Union, so not GMC regulated. And prescription is for a child who has not yet reached puberty. And the medicines prescribed are for puberty suppressants. And the dilemma comes in because you understand that a decision to supply or a decision to decline can both result in irreversible harm to the child over a period of time. And I'm wondering what you might do in this situation. I probably can give a little bit more details, because what I don't know is whether or not any of you have encountered this type of scenario in your practice so far. If you have, love to hear about it in the chat. So any sort of affirmation of yes, we know we've handled this within the pharmacy, or we haven't, would be very appreciated. But the nature of this dilemma is that if the pharmacist decides to dispense the puberty suppressant for the child, then there are some fears in their mind. So there is the publicized case of Kira Bell and Tavistock NHS Trust. This was a case where Kira Bell started a transitioning process, or completed a transitioning process starting in childhood, and then in adult life expressed the view that it took NHS to court and won, demonstrating that that they had been irreversibly harmed, and the consent that was in place at the time wasn't as firm as it was believed to be. So there's so it highlights a risk that a patient who might be sure about the medication that they're taking as a child has a different view of that in later life, and we're starting to see more of those cases now play out. There are issues around whether or not and if the child has capacity to give consent. That's quite difficult when they're in a pharmacy setting. There's some issues around do the parents consent? Do the parents know? And that presents problems both ways. It can present problems both ways. So is it a case about linked to the parents and a belief from the pharmacy team that there's some sort of safeguarding issue? Is it a case that the parents don't know what's going on at all? Is there parental pressure for the puberty suppressants, either for or against? And the outcome is that the child may be permanently unable to develop into the male or female. On the other side, if the pharmacist were to decline to dispense the puberty suppressant for the child, then the fear is around permanently preventing a person from being able to avoid puberty, which is particularly impactful on trans female. So this can be associated with poor mental health, self-harm, and suicide. And so you've got a situation where whether the pharmacist decides to dispense or the pharmacist decides to decline to dispense, you've got the prospect of irreversible harm occurring. On top of that, it's a topic which is highly topical at the moment in the media. There are issues around being regarded as transphobic. There's reputational damage. There's targeting on social media. It's an incredibly difficult situation at the moment out there for pharmacists encountering these dilemmas. At the moment, the team try to help on a case-by-case basis, but it's particularly tricky. So in the scenarios we're talking about scenarios where the prescriptions are legally valid. So there isn't a prescription problem, if you like. We've overcome that, although there are prescription risks with the prescriptions being private and non-NHS prescriptions, but also with the EEA prescriber, which is perfectly legal, but risky. So really wondering in this situation, this is a scenario I think we would like to, an interactive discussion would have been even better for this sort of scenario. But what would this cohort do in this situation? Would you supply? Would you decline? Or is there a third option that you'd like to share? Salita.
Yeah, I think this is probably one of those I'm not sure is it a rare occurrence that this happens, or do you reckon it actually is more commonly seen now across different sectors of pharmacy? Or I just wanted to know like how often a pharmacist could come across a case like this and be at the point where they have to make that decision as well.
So the team are encountering this inquiry recurrently, or aspects of this inquiry recurrently. We're in talks with some of the pharmacy multiples, and they're also in receipt of this type of a query. So this is why I've sort of described it as the ethical dilemma of the last few years. It was about I think starting in 2022 or maybe a little bit earlier, but the volume started to be very noticeable in 2022. It's been picked up as a theme, so it's an inquiry type that we're monitoring and planning to see what type of guidance from the RPS could be helpful. Really interested to see how this cohort. So that's really interesting. So we've got in this case we've got the majority of participants here. So all participants in the survey decided to decline and to refer. That's really interesting because I think that is also reflective of maybe the status quo in the wider workforce at the moment. I think our numbers are relatively low in the survey response, but the option to decline and refer is probably the option that's most opted for at the moment. But at the same time, that option is not a particularly fantastic option for somebody who would like to transition, and that's because the NHS doesn't have the capacity at the moment. So that referral option is actually not quite really there. It's sort of declined, but then the referral option then takes 3 or 4 years at the moment. So which is why it's a really difficult situation. But nonetheless, really interesting feedback from this cohort. There is an independent review which is ongoing for this situation. So Dr. Hilary Cass is undertaking an independent review, which includes a clinical review of. So in the future, once that review reports, it might be clearer about what's the right course of action. But right now, the evidence base is rather weak, it's a little bit incomplete. The dynamic of private prescribers issuing prescriptions to the European Union, that's certainly risky and makes things really, really difficult. But at the same time, sometimes we catch these prescriptions on that because they're not legally valid, but legally invalid prescriptions can actually be addressed, and then that issue, the underlying issue, is then still there. And I think I've already covered the compounding factor of that. At the moment, there isn't NHS capacity to deal with the workload, so there's a huge waiting time for referrals. And as promised, those are my 6 slides. I've got no more slides for you this afternoon. This is the 6th and final slide. I did want to say that the Royal Pharmaceutical Society, as a professional leadership body for pharmacy, it is our role to lead and represent the pharmacy profession. So the RPS as an organisation encourages us all, pushes us all to be the best versions of ourselves, to be professionals, I suppose, in our support of the people and the communities that we will serve. Linking back to the discussion earlier about whether or not pharmacy is a profession and what does being a professional mean. So we talked about the individual characteristics of being a professional, which are, of course, critically important and the most important. There are also some secondary characteristics of being a professional or being a profession, and that includes having professional standards to lead the way, in part, so the development of professional standards and following professional standards. And part of that could also be about being part of a professional leadership body. So arguably, a group of people without a professional leadership body, or without a viable professional leadership body, without a body that produces professional standards for the profession, is less of a profession perhaps, or maybe not a profession perhaps. So I'd very much ask that you all keep this in mind for now, and also in the future. I wish you all the best in your graduate year, and hope you can demonstrate the characteristics of being a professional throughout this year and then throughout your careers. Be the best that you can be. And thank you for staying until the end.
Thank you very much, Wink. That was really, really insightful. And I have so many notes and so many things to think about going forward as well. So yeah, I just wanted to thank you one more time, and I will hand over to Sally.
Yes, as Deka said, thank you for joining us, Wing. I think your topic is one that is interesting, and I don't think it's included in many aspects of our training or our MPharm degree at all. If anything, it's more of a concept, and I think, with the MEP, of course, we're told that this is sort of the Bible behind how we can act legally as a professional and what is right and what is wrong in pharmacy. But as you've showed in your presentation, it's not always playing by the book. We sometimes have to think about the patient, and sometimes that means going against what's written in laws and regulations, but having the justification, rationality behind it, and having all of that documented, that decision-making process. So thank you for enlightening us about that. I actually do have a question. I mean, I have a few questions, but I'm not sure. I think maybe other exec team and our attendees as well. If you guys do have a question, please feel free to pop that in, because we do have a few minutes. But yeah, so one of my questions I would say is because there is a gap of knowledge there a little bit of how, as a pharmacist, as a aspiring pharmacist, we are going to be put in positions where we're going to have to deal with somewhat very complex dilemmas like this. How do you think we can best prepare ourselves, whether we're in our training process as a foundation trainee, where we're actually working in those environments? Or even as an MPharm student, how do you think we can almost do self-directed learning to build confidence in dealing with these sort of scenarios?
So I believe it is about practice using the professional judgment framework that we've set up. So that framework through the MEP probably in theory been available to students across their study of pharmacy. I think the graduate year offers the opportunity then to test that framework out against the real things that you encounter in practice. And I think it's about first of all being able to identify, first of all, when professional judgment needs to be used, and when it does, at least initially, putting it through that process until you're very familiar with it, until it's intuitive, until actually you can make those decisions through going through that process without needing to write them down. But I think the best way to prepare is to practice using that framework. I think we also have to learn from, so some of you will be working in secondary care, some of you will be working in primary care, where you present with opportunities to work with and together with, and to learn from other healthcare professionals. I think as a profession, we tend to be quite risk averse as pharmacists. In some respects, we are less confident, and there is something to say about learning from how our wider multidisciplinary team respond to incidents and respond to actions. I appreciate that might be quite difficult if your graduate year is confined to community pharmacy, although having said that, you're seeing more and more prescribers in community pharmacy now, and pharmacy first coming into community pharmacy too. So a wider range of activities and tasks coming into community pharmacy. But so I suppose two things. It would be practice using the framework, and at least for the first couple of ethical and moral dilemmas that come your way, run through the paper exercise until you're well versed in using it. And then secondly, learn from the wider members of the team, whether they're pharmacists or other healthcare professionals. And then maybe the third one would be to recap about in your own time completely what does it mean to be a professional exercise. Have that definition to hand, and then sense check your decision against that ultimate definition. At the RPS, sometimes when we hear the stories that we're saddest about, sometimes are when and I'm glad it doesn't happen often, but we do hear about them from time to time. It's when we hear stories, maybe from a patient perspective or reported back, where the patient has received a very curt decline, but there's no other support. So whatever the request might be, whether it's an emergency supply, whether it's a prescription that the pharmacy doesn't have stock on or doesn't want to deal with. But the worst thing that we hear about is where the pharmacy or pharmacist just declined to help, but there was no follow through. There was no conversation. There was no follow up. We didn't have the stock, or we're not able to do that. It's those scenarios that make us a little bit disappointed, because then that's then about are we in those circumstances being the professional that we set out to be. I think it's you might all be aware that the chief pharmaceutical officers last year published a review into professional leadership. They called for professional standards around values and behaviours for the profession. And if we think about why might that then be needed, why do the chief pharmaceutical officers across the UK believe that professional standards for values and behaviours are urgent and are needed? And then the only conclusion that you can come to for that would be that there's a belief that the profession in some instances has a deficit in this area, and that our values and behaviours across the profession are maybe not uniform or not consistent enough, and there's a need to focus in on those. So reflection upon values and behaviours, what it means to be a professional, and what I'm doing in the workplace. Is it actually professional? Is it helping everybody else, or I'm just putting my own interests first? I think those would be the items that I'd recommend we think about.
Thank you, Wing. I think we can take away so much from your presentation and even the questions we had throughout as well. Really glad we could make it, the poll set up for you as well. And I'm really, I'm really glad that everyone really did take part in that. And we've, seen situations where it's very 50-50 as well. So that goes to show, you mentioning that the profession itself is risk averse. Well, maybe it's balancing the risk averseness of the actual profession, but also putting patient safety first, which is always that professional standards that we are taught, for years and years. This is what you have to do. You put the patients first, but also you've got that side of things. So it's, I guess, a lot of it is just maybe training ourselves and receiving that training and receiving that resources to give us confidence and seeing how we can move forward in difficult situations like this. But yeah, no, thank you so much for sharing all that insights and just sharing everything, especially in your own profession as well, because I know you've worked for many years, in this sort of area and probably seen so much case scenarios and how that's being dealt with over the years. So yeah, it's really thankful you've been able to share with us that today. And it's very thought-provoking, I would say, as well. And I think it's good for us to think about it at early stages because this is possibly something we can face in our in our future careers. So thank you.
Oh, you're welcome. Really glad if it's been helpful. So thank you very much for listening in, everybody.
Thank you. I just realized I'm in mute. So I think we are coming to the end of our conference. Thank you for everyone who stayed towards the end. You guys are absolute legends. I hope you found this really useful for you. I hope you go away, use it as a CPD, use it as a learning opportunity. And if not, at least you've maybe learned something new as well. I think I and maybe other members of the exec, we can safely say we've learned quite a few things today and it might have even inspired us to look into something, or review through something that we found interesting today. So, but yeah, guys, I'm just gonna put up our PowerPoint slides. Just give me a minute. I'm gonna have to share screen. Yes, there you go. Can everyone see that? Yeah, perfect. Okay, if it will load. Right. So this is the part where we say our thank yous. Thank you, guys. It really means a lot for you to be here today. This is our first ever graduate conference. And I think with first events like this, it is a bit nerve-wracking because you really don't know, how it's going to go. But I'm so glad that you guys stayed and participated, and it was super interactive. And I think our speakers really enjoyed being here as well. So I would like to give a big thanks to all our speakers. I know they put in so much time and work to putting this event together and helping us, the BPSA. I'd like to thank all the members of the execs who were able to help me and support me throughout all of this. This is definitely a group, teamwork all the way through. So I really do thank you guys for all the effort, all those late night meetings. It's all worth it. And especially to the attendees as well, guys. You have made it so special for us. I mean, we've even had a raffle today, which I didn't even know that was going to happen. But again, congratulations, Alexandra, for winning that raffle and for being so interactive. Everyone who's put in the chat box and the Q&A, you guys have made it so good. And we're so glad that you came today, decided to stay. you know, and hopefully gain something and learn something as well. I want to thank my graduate subcommittee who has helped me put all of this together. I put friends and family there, but obviously the support system and support network. But yeah, thank you guys. And let me just move on to the next slide. So this is the feedback form, but I think we have another slide. Sorry, let me just have a look. Oh, yes. So before we go on the feedback form, there you go. This is the slide I wanted. This is just a reminder that tomorrow we also have the Business Interpractice Conference. So guys, if you haven't signed up for this, please check out our social media pages. There's an Eventbrite link in the link tree as well. So go to our Instagram page, click onto that. But yes, it will be tomorrow. Emma, does it start 10 a.m.? Yes, 10 a.m. guys. So if you signed up, be there by 10. We have an amazing lineup of speakers, another day, but you know, it's going to be very productive, lots of talks, lots of conversations, and lots of discussions as well. So if you find this conference today interesting, I bet you're going to love that one too. So, and it's also going to be more about businessy side of things. So if you're interested in that, interesting about businesses across different pharmacy settings, definitely go to that conference as well. Okay. All right, and the slide before it is the feedback form. So I'm just going to give you a few minutes. This is the QR code, and if you basically scan it, it should send you to the link where you can feedback about how you found the event today. I appreciate the honesty as well, guys. So if there's anything you would like us to improve, please let us know. But if there's anything that you do like about the event and you'd like to see it in our future BPSA events, whether that be our webinars, conferences, or in-person workshops, also please let us know. But I didn't put it on the slide, but we are having our annual conference soon. If someone would like to speak about the annual conference, someone with maybe more information, Emma, if you want to, yeah, just brief everyone about the annual conference coming up in Norwich.
Yeah, so I briefly mentioned it earlier. So our annual conference, our flagship event, it happens once a year around Easter time when you're all off from university for Easter break. And it's a week full of social events, networking, meeting our stakeholders, speakers. We've got conference business where we're discussing different motions and they become BPSA policy. And then the executive, within 3 years, they have to act on those policies. And we also have elections for the upcoming mandate for the new BPSA executive. So I have my best friends from the BPSA executive and annual conferences. So it's the best thing you can do while you're a BPSA member. So please go and check it out. If you're still an undergrad student, you can go to your head of school and see if you can get your ticket funded as well. Or you can buy it and fund your own ticket. So please check our social media for that. There'll be a lot of promotional material coming out. And check the post from last year's conference just to see what to expect. And feel free to reach out to anyone from the executive if you've got any questions at all. Thanks, Sally.
Perfect. Thank you, Emma. But yes, absolutely. It's one of those events. I mean, I went to my first BPSA conference last year, and essentially before that, I knew nothing about BPSA, and it really did change the trajectory of everything I do now. And it's, you know, coming into this role, it's been amazing as well. But even just being part of the BPSA community and all the work and all the sort of the conversations we're having with members. And it really is an amazing community to be a part of, whether you're a part of the executive team or whether you're our members. So yeah, definitely come to this conference. You'll feel super inspired like I was, inspired enough to apply for a position as well. So but yeah, if you feel like this is something you'd love, go check out our page and get your tickets. But yeah, I think we can. Should we stop share? If everyone's able to fill in the feedback form, that would be amazing as well, guys. And I think if Emma, if you can send in all the link information and everything, I feel like you are right now. Lovely, thank you. Okay, guys. Well, we are coming to the end. So I know it's been a very, very long day, and you know, hopefully you've had enough breaks as well. Hopefully you've gotten your lunch and maybe had breakfast. I do recommend always have breakfast, but if you don't, have a cup of coffee and tea because it will carry you on, carry you through. I'm on my 3rd cup of coffee. It's been great. But yeah, if anyone else on the exec team would like to share how they feel about today and just a few words to our attendees.
I guess I wanted to raise my hand, but it would just take longer than just unmute myself. But thank you everyone for attending. Seriously, it's been such an inspiring and insightful event full of talks. Thanks to our speakers that attended and take some time on a Saturday to come and talk to us all. And well done, Sally. You've been absolutely amazing in all of this, and you've executed the job so well. And to your subcommittee as well, and the whole BIP team and the executive. It was amazing event, and that's our first ever BPSA graduate conference, and you went better than expected. So well done, Sally. We're so proud of you.
Thank you so much, Emma. I'm just waiting for another person to volunteer themselves, but anyone else, thank you, Emma. That really great. And I'm really glad you enjoyed as well and being a part of the team. Really, really grateful to have you and everyone else. But yeah, anyone else?
I think Emma's kind of summed it up, but I hope that to all of you, whether this is your first BPSA event or maybe you've been to a couple before, I hope that this isn't the last one. I think we run a lot of things like this, and please, if you can, spread the word. We put a lot of time and effort into these things, so to know that you guys have enjoyed it, but also know where we can improve, it would mean a lot if you could tell other people. So when we have these events next time, we can get more people, more learning opportunities, more everything.
Thank you, Key, for sharing that. I can see in the comments. Thank you guys for leaving such lovely comments as well. It really means a lot to us. The feedback, you know, it really does go a very long way, and it really helps inform all our future events because we are doing this for you guys, and a lot of the times we are really looking into what you want to see, who you want to see in the events, what kind of talks, what you know most interested in, and how we can help you. So it's really good to know that you found this useful and informative. And yeah, but thank you guys. You are free to go if you wish. But again, hopefully I'll see some of you maybe in person if you decide to join us in our future in-person conferences. And I know, Danke, if you want to share as well, your area coordinator and area conferences.
Yeah, so as area coordinators, we have a few spring area conferences coming up. So those will be in person at different universities. So we have one for the Western area in Birmingham. We have one in Leicester for the Eastern area about pediatrics, which will be really exciting. So it would be lovely to see you guys there, if any of you are free and from the area.
Yeah, perfect. Thank you so much, Danke, for sharing that. I think there was a question about the certificate of attendance. Emma, I'm not sure if you've answered that, but would you like to? Yeah.
Yeah, so yeah, I didn't realize when you answer from the Q&A and the question goes away. So the certificates will be sent to your email addresses that you used to register. I'm not sure when that will happen. We'll wait within a week. Sally, is that all right? Yeah. So we'll send the certificates to your email address. If for some reason you haven't received them, please reach out to Sally. Yes, her email is on the website as well.
Yeah, so I think as long as you've attended this, you should have then access to your certificate of attendance, which will arrive at your mail soon. Remember, guys, always check your junk mail as well. But yeah, we'll try to get that sent to you by in a week's time. And I'm just trying to see how the recordings will be shared as well, because if we're able to get a recording shared to you and sent to your email as well, and we'll see if we can get it up on your official YouTube page. Yeah. So you should be able to find it through a variety of resources, but obviously if you've attended this, you will get the link to the recordings and your certificate as well, guys. So obviously, if you want to use this as a write-up opportunity, I mean, I think I like to sometimes attend conferences and be like, okay, this is great because I've learned this, this, and that. I've attended this workshop, and especially if you're in your training year and you have to fill up your e-portfolio, I hope you found this useful and hopefully helping you do that. But yeah, thanks again, guys, and I think we can just end this.